Hello. हेमलता आपकी स्लाइड दिख रही है, अपना वीडियो ऑन करो। स्लाइड दिख रही है, हेमलता को वहां से ऑफ करना पड़ेगा, म्यूट ऑफ।
हाँ सर, एम आई ऑडिबल नाउ?
आवाज आ रही है, आपकी आवाज आ रही है, और देखिए नेटवर्क आपका अच्छा होगा तो ठीक है।
हाँ सर, एम आई विजिबल?
आप विजिबल है, स्लाइड
सर?
विजिबल है,
और आवाज आ रही है सर?
आपको मेरी आवाज आ रही कि नहीं?
हाँ सर, आपकी आवाज क्लियर आ रही है।
आपकी भी आवाज आ रही है, आराम से स्लाइड भी आ रही है।
ठीक सर, फिर
तो मैं पहले
मुझे लगा मेरी आवाज नहीं आ रही है।
हाँ वो ऐसे ही होता, कान में जब तक खुद की डिवाइस ना लगाओ ना तो समझ में नहीं आता कि।
सर मैं हेडफोन लगा लूं क्या, अगर क्लियर ना आ रही?
हाँ हेडफोन लगा लो,
लगा लूं सर?
बिल्कुल।
एक मिनट सर, एक बार उसके बाद कंफर्म कर लीजिए। हेलो।
हाँ त्रिपाठी सर आवाज आ रही है, हम अभी आपको लिंक देते हैं।
आ रही है, वीडियो नहीं आ रहा।
हेलो, वीडियो ऑन करना पड़ेगा, वीडियो ऑन करिए। आवाज आ रही है हेमलता जी आपको?
हेलो। हाँ सर, आ रही है।
ठीक है,
आ रही है सर?
रही आप गुड गुड।
सर मेरी आवाज अब आ रही है?
आ रही है, आप आराम से रहिए, अभी होल्ड, ठीक है। मैं अभी पहले इंट्रोड्यूस कर देता हूँ, सेशन शुरू करते हैं, फिर आप शेयर करिएगा, ठीक है।
अभी स्टॉप कर दो सर शेयर?
फोटो नहीं आ रही? हाँ अभी शेयर और स्टॉप कर दीजिए।
ठीक
ओके, आ गई सर, आ गई।
गुड आफ्टरनून एवरीबॉडी।
गुड आफ्टरनून सर, गुड आफ्टरनून। आप तो पूरे आ रहे हैं सर। गुड आफ्टरनून सर। बस अभी 2 मिनट रुकिए, 5 मिनट टाइम है सर, हम लोग 5 मिनट बाद शुरू करेंगे।
The sound is little sound is not that good, but anyway, can you hear me?
Yes sir. हाँ सर, बहुत अच्छी हेयर कर सकते हैं।
Okay, so let us start the topic.
सर अभी 5 मिनट है, सर अभी 5 मिनट है। The time is 3 PM, so हम लोग 3 बजे शुरू करेंगे।
5 minutes are there.
या
Okay, okay.
मैं पहले इंट्रोड्यूस कर दूंगा सर चेयरपर्सन और स्पीकर को, उसके बाद आप टेक ओवर करिएगा। शेयर हुआ कि नहीं हुआ इनका? हो गया ना?
जी सर, दिख रहे हैं सर।
प्रेजेंटर मोड दिख रहा है।
क्या कह रहे हैं आप?
प्रेजेंटर मोड सर दिख रहा है, जो स्ट्रीम हो रहा है।
जो ये दिख रहा है?
यस सर।
क्या करें, क्या करना है बताओ। अच्छा, डुप्लीकेट स्लाइड्स। ठीक। ठीक है, स्ट्रीम भी हो रहा है।
Sorry that sound is not that good. Anyway, it's still 2-3 minutes left.
हाँ सर, टाइम से ही करेंगे हम लोग।
1 minute. Okay. Good afternoon, ladies and gentlemen. Now, here is Dr. Hemlata, who is Associate Professor at King George's Medical University, Lucknow. She has done her MBBS from Patna Medical College, and then all her education is at SGPGI and KGMC. And anybody who has worked in KGMC trauma center, I think he is the best trauma physician, trauma anesthesiologist. And she has got all the things which is required to be certified as a trauma specialist. She is ATLS instructor, BLS, ACLS instructor for acute critical care course. She is on the editorial board of the ACME, Anesthesia and Critical Care Medical Journal, reviewer for Indian Journal of Pain, and she has got lot of awards, and few are like outstanding clinician in anesthesiology, fellowship in regional anesthesia and pain medicine, advanced course from Ganga Hospital, Coimbatore in 2018. And I think I had gone next time I got award there in Ganga Hospital, Coimbatore in 2019. Co-author for the best review article in IGA, Dr. Bhojra Award. And she has published more than 30 papers in international and national journals, 4 book chapters, 4 review articles, and she has delivered various guest lectures during national and international conference. Now over to Dr. Hemlata.
Until the Dr. Hemlata is sharing the slides, let me introduce the chairpersons. We have Colonel Dr. Professor R.K. Tripathi sir, who has been a veteran in Indian Army and now heading, he has been the head of the Ira Medical College and established department there. And he has been also at the RML Institute of Medical Sciences as a professor. And another chairperson, we have Colonel Vikas Chawla sir, who is serving in Indian Army, and he is working as a colonel and now posted in Command Hospital, Lucknow. And this time he is on the line of control border of the India and China, as I have been informed. Maybe if he had got network there, he will be there. But he has suggested his input for the session that we will discuss after the lectures. So it's over to Dr. Hemlata madam to start trauma resuscitation.
Thank you so much. Thank you so much for your introduction, sir. A very good afternoon to everyone. Am I audible, sir?
Yes.
Hello. A
Yes.
very good afternoon to everyone, respected chairpersons, seniors, my colleagues, and my dear students. The topic that I have been given for today is approach to resuscitation of polytrauma patient, with a special emphasis on shock management. Let's first discuss what do we mean by polytrauma. As the word itself speaks, it involves more than one system. For example, multiple fractures, associated head or spinal injury, chest injury, abdominal or pelvic injury. And since there is involvement of multi-system, so it needs management by a team, which involves surgeons as well as physicians. Looking at the global burden of trauma, Trauma is the leading cause of death between the ages of 14 to 45 years. As per the WHO and the CDC data, globally, more than 9 people die every minute from injuries or violence. That means about 16,000 per day and 5.8 million every year, which is around 97.9 per 1 lakh population. And most common cause for this trauma is motor vehicle crashes, followed by suicide and homicide. So as we can see, there is a huge burden of trauma on the society as well as on the healthcare. So it's very important for all of us to be aware of how, for all of us anesthetists as well as for all the physicians to be aware about the specific requirements of trauma patients and how to manage them. Now let's look at this particular trimodal death distribution curve, which we have been seeing for long, which basically depicts the death caused as a result of trauma. And it has got 3 peaks, as you can see in this figure. The first peak occurs within seconds to minutes of trauma. That is basically the on-spot death, even before the patient reaches the hospital. And the most important cause of this death is severe head injury or high spinal cord injury or massive hemorrhage, either due to some rupture of aorta or heart. So we can't do much about this except for prevention to reduce this first peak. So prevention in the form of better implementation of traffic rules and this wearing of helmet, seat belt, and all these things are going to reduce this particular peak. Now, the second peak, which is known as early death, occurs within minutes to hours of trauma. And the causes mainly include intracranial hemorrhages in the form of this SDH or EDH, then thoracic injury, most lethal being this hemothorax, massive hemothorax and pneumothorax, and the abdominal injuries, mostly resulting in laceration of the liver and splenic rupture, and pelvic injuries or multiple limb fracture resulting in massive hemorrhage. So all these can be, if managed properly, then we are able to decrease this early deaths. Coming to the late death, which occur within few days to weeks of injury, mostly because of sepsis or multi-organ failure, and these deaths mostly occur in the ICU. If we manage our patients properly in the early stages, that is the initial resuscitation part, then obviously that has effect even on this late death, the mortality and morbidity later on. Now, this is another graph. This is basically showing, the red line is showing the historical trimodal death distribution that we have been seeing till now. And the graphs, they represent the recent data. And as you can see, this data is from 2010. You can see that it has almost become bimodal. The second peak is no more there. So this alteration, this major change has been brought about because of better pre-hospital care, more training, trauma training, better setting trauma care, as well as dedicated trauma management teams. Everything has led to this major shift in this distribution of death following trauma. And we hope to decrease it further to all these peaks. We hope to flatten the curves more in future. The unique challenges to the healthcare posed by these trauma patients includes these patients require resource-intensive care. They have multiple injuries to multiple body systems. Their acute injuries overlie and interact with a variety of underlying medical conditions. So what is the role of anesthesiologists in trauma care? Well, anesthesiologists are involved right from the beginning of the management of these trauma patients, starting from the emergency department, where they are needed for airway, as well as for resuscitation of these patients, proceeding through the operating room, where obviously the anesthesiologists have a major role, to the intensive care unit. Many countries, different countries and different places, they perceive the role of anesthesiology in trauma care differently. For example, in European practice, the anesthesiologists are working in the pre-hospital environment as well as a director of the emergency department, or even as a leader of the hospital trauma team. So that speaks of the role of anesthesiologist in trauma management. In fact, the presence of an experienced anesthesiologist and the immediate availability of an open operating room is Both are core resource standards for accreditation as a level 1 trauma center. So the objectives of today's talk are to discuss about initial assessment and management of the polytrauma victims as per a systematic approach based on the principles of primary and secondary survey, and to correctly assess priorities in the management of polytrauma patients. Let's start with a case scenario. We have a 44-year-old male driver who crashed head-on into a wall. The patient is found unresponsive at the scene, and when he is brought to the hospital via the basic life support team, he is already having a cervical collar in place and has been strapped to a spine board. Technicians are assisting ventilations with bag and mask. Well, the scenario that I have given, I think most of the times here in India, we are not receiving our trauma patients like this. Very rarely they are on a spine board or with a cervical collar in place. Still, I have chosen this particular case scenario in order to emphasize the need for proper transfer, for a proper pre-hospital care, as well as a proper transfer of all the trauma patients in order to prevent further injuries to the spinal cord and in order to prevent further harm to the patient. So this is very, very important. Coming to the case scenario, since I have given only a limited information about the patient, this is what happens most of the time when we are in the emergency department or the trauma center and we receive our trauma patients. Most of the time, we don't have much information. Many a time, the eyewitnesses are also not there. Only the pre-hospital team have brought them, or the ambulance person they have brought. And many a times, even the relatives and other persons are not there. So what is the sequence of priorities in assessing this particular patient with this limited information that I have provided? Do we need to identify the specific injuries before initial management of this particular patient? Well, the answer to this particular question is no. We need not know the specific injuries sustained by any trauma victim in order to start the initial management. So we have to start very quickly. So how to proceed then? Well, to solve our problem, we have this ATLS concept, that is Advanced Trauma Life Support course, which is the most widely accepted trauma training course worldwide. So this is almost there in more than 80 different countries, and more than 1.5 million people or the healthcare personnel have already got trained in this particular concept. So this concept, basically, we will be discussing our all the trauma management. In fact, most of the hospitals in India also, they are following this particular ATLS concept provided by the American College of Surgeons. Though there are many other courses like Canadian CTLS course and other courses are there, but we are following this, and almost all of them, the priorities and whatever the gist of all these courses are seen. So this advises ABCD approach to evaluate and treat all the trauma patients. What is this approach? We will discuss it in detail. It tells us to treat the greatest threat to life first. So whichever thing is going to kill our patient first, we have to address that particular problem first. So ABCD approach means A is going to kill before B, B is going to kill before C, and C before D. That's why we have kept our priorities like that only. Definitive diagnosis is not immediately important in order to manage the trauma victim. Detailed history is not essential to begin evaluation. Obviously, we will be needing all these things for proper management later on, but these are not immediately required to begin our treatment. Time is of the essence, and we should do no further harm to the patient. That's why this cervical collar and the spine board that I was talking about. Now, time is of the essence. This is very, very important, because until we act timely in case of trauma victim, the chances of saving the patient decreases with time. So here comes the concept of golden hour, which all of us are aware. I think most of the residents, they have also heard about this golden hour. Is it the initial 60 minutes from the time of trauma or something? Well, this does not stress on a particular time limit of 1 hour. Rather, it emphasizes the urgency required for successful treatment of injured patients. So it is basically stressing about on the urgency of treatment required. and is a window of, basically a window of opportunity during which, if we act promptly, we are definitely going to save our patient. Nowadays, there is also the concept of platinum minutes. Here again, it stresses more on the importance of time. So it's the platinum 10-minute concept, not yet incorporated in our ATLS recent guidelines. So it is said that ATLS provides a common language which is applicable to clinicians in a variety of situations. So it's not that you cannot manage your patient just by following ATS. You can follow any trauma guidelines, whichever is available. But since this is being followed in most of the places in India, so I am discussing this particular one, it tells us one safe way to save our trauma victims. It is just as relevant to provide in a large teaching facility in America or Europe as it is in a developing nation with rudimentary facilities. That means it only speaks of the basic. It doesn't talk about something very high-fi, which is not available in a particular center. Even if it's not a trauma center, in most of the emergency department or the hospitals who are dealing with trauma, the basic equipments, if that is present, we can easily manage as per the ATLS guidelines. So trauma is basically a teamwork. As you can see, there are so many people required, but still, whatever I'm teaching to my students today, or what we are discussing right now, is what are our priorities. If I say that we have to manage airway first, then we have to manage breathing, and then circulation, it doesn't mean at all that if a person is bleeding severely, so you cannot put an IV cannula and start fluid simultaneously. But the thing is, you cannot neglect airway and breathing and jump onto C. If you have got a big team, you can start things simultaneously. But here I am simply talking about the priorities. We should always keep in mind that we have to manage our airway, then we have to manage our breathing, then circulation, then only we are going to save our patients. So if we follow this systematic approach, we are definitely will be improving our outcomes to a great extent. So the steps in management are primary survey, followed by simultaneous resuscitation, followed by secondary survey once the primary survey is finished and our patient is stabilized, followed by definitive care. This is an algorithm which depicts that starting from the preparation, which is very, very important in all the trauma victims. It's not that we start acting when a patient has reached the trauma center. We should be prepared even before the patient comes. Many a time we receive the information about the patient and some details also. So accordingly, we will prepare ourselves with the equipments, with the drugs, with the personnel, and even the emergency room, the trauma resuscitation room should also be prepared. I mean, the temperature should be warmed. It should not be cold. The fluids and everything should be warmed, and everything should be ready, including PPE, the personal protective equipments. Then comes the primary survey along with the resuscitation of the patients with the use of certain adjuncts for primary survey, followed by re-evaluation. And only once our patient is stable, we should switch on to detailed secondary survey. Again, there are some more. Hello. Hello, is it visible now?
Continue.
Okay, sir. Okay, sir.
Yeah.
So followed by re-evaluation and definitive cure. So this is a depiction of what all is involved in the management of this ABCDE. I'll be dealing in detail. So A stands for airway with restriction of cervical spine motion. So whenever someone asks you in an exam what A stands for, you never say A is for airway. A is always for airway with restriction of C spine motion. So cervical spine immobility or restriction of its motion is very, very important. After you have assessed for airway compromise and managed your airway, next comes the breathing and ventilation. That means it's not just the exchange of airway, but it also involves the gaseous exchange at the level of the alveoli and capillaries. All should be adequate. That we have to assess as well as to manage before shifting on to the C part, that is the circulation along with hemorrhage control. Obviously, hemorrhage control is very, very important when we are talking about circulation. Here I'll give the analogy of a water tank. as you all know, if there is a tap in the water tank and we have kept it open, the tank is never going to fill however water we are going to put in it. In order to fill the tank, we need to switch off close the tap first. So similar is here also. If we don't control the hemorrhage, then we are not, whatever volume we are giving, we are not able to resuscitate our patient. Next is disability, which doesn't mean orthopedic disability, but it's basically neurologic disability. And during primary survey, it's only the basic assessment of the disability, neurological disability. Then comes exposure. In order to look for any missed injuries during the primary survey, and at this time, we have to take special care to prevent any kind of hypothermia of the patient. So like I'm saying, our priorities are A, B, C, D, and E, and we have to manage according to this particular priority. So what about the special group of patients, like the extremes of age, the pregnant ladies, obese patient, athletes patient, because these are slightly different from our normal adult patients that we are normally dealing. For example, elderly patients, they have got diminished physiological reserve, plus many of them are already on many medications. They might be hypertensive, diabetic. All these have their own implications while we are assessing the patient as well as while we are managing the patient. Similarly, if we talk about pediatric patients, they are not simply miniature adults that we all know. So there are so many differences, like differences in the airway, which is obviously more difficult. Then many other things are quite different. The ratio of the body surface area to the body weight, all these are different. Similarly, in pregnant women, as we all know, that is basically a state of hypervolemia. So in a pregnant woman, suppose a patient lands up in shock, there is a blood loss. So as much as 1.5 liters of blood is lost till that time, she might be normal. She might not be manifesting signs and symptoms of shock. So a larger volume of blood loss is required for the manifestation of signs and symptoms of shock in case of pregnant female. But that doesn't mean the fetus is not suffering. By that time, the fetal compromise would already have happened. So we have to keep these things in mind while assessing these patients as well as while resuscitation. Because many of these changes, these physiologic and anatomic changes, they are also going to alter the results of the lab tests. So whatever changes are there, but once again, I would like to stress that the priorities are still the same for all the patients. It's always A followed by B, followed by C, followed by D, and then E. So if I tell you, if I simply ask you to assess the patients quickly to rule out the airway problem, airway compromise, or B, C, D, etc. So can you do it quickly? Yes, it can be done within 10 seconds. The simple way is to introduce yourself and simply ask 2 questions. What's your name and what all happened? If you get a positive and adequate response from the patient in a clear voice, that means as of now, we have excluded any compromise of airway, breathing, circulation, or disability. Because since the patient is speaking, that means the airway is patent, and he or she is able to generate enough air in order to speak. And his cerebral perfusion is also not impaired much. That means still not in severe shock. And since he is able to comprehend and respond, that means the disability is also not there, neurological disability. So being anesthesiologists, we are dealing with airway day and night. So we are well aware of all this. So I'm not going into the detail of this airway. Simply, I would like to point out there are certain signs and symptoms which always point towards compromised airway, which should always look for in any trauma victim, like change in voice, noisy breathing, dyspnea, agitation. Patient might be tachypneic and abnormal breathing patterns, like some rocky kind of breathing or cancer breathing, or even use of accessory muscles of respiration can be there, and later on the patient may desaturate. So you have to act promptly. You have to recognize all these things. We all know that when the airway is compromised, not patent, we need to intervene in the form of intubating the patient or achieving a definitive airway. But there are certain conditions in which we need to intervene even if the airway is patent. So what are those conditions? Well, that can be because of some airway problem. For example, if there is a burn patient having inhalational injury. So right now the patient is able to speak and the airway patency is there. But because of the progressive laryngeal edema, later on there can be narrowing of the airway and airway compromise can be there. Similarly, some breathing problem can be there. For example, the patient is having multiple rib fractures or flail chest or something which is impairing the ventilation of the patient. So, or for any other reason, if we want to put the patient on ventilator, we need to intubate that patient. Next is inability to protect the airway. As we all know, a GCS of 8 or less is an indication to intubate the patient so as to protect the airway. Or many a times, in order to give short-term hyperventilation to the patient in order to control intracranial aplasia in case of TBI patients. So there are many more indications where we need to intervene even when the airways compromise is not there. These all are the list of obstructed airway causes and inadequate ventilation. So as anesthesiologists, we all know that we have a huge armamentarium of airway equipment, starting from the very basic supplemental oxygen, which must be given to all the trauma victims, followed by basic techniques like maneuvers, chin lift, jaw thrust. We have got basic adjuncts like airways, the nasal, the oral, the Goodell's airway, all that. Then we have several ways of achieving definitive airway and difficult airway adjuncts. So we all know all that. So I will simply ask, if in exam somebody asks you what is definitive airway, so how are you going to answer? Simply remember 4 things that must be satisfied. 4 conditions must be satisfied in order to call it a definitive airway. There should be a tube placed within the trachea. Its cuff should be inflated below the vocal cords. It should be connected to some form of oxygen increase assisted ventilation, and the airway should be secured in place using tape or some other means. Then only we will call it a definitive airway. So what all are definitive airways? One is the endotracheal intubation and another is the surgical airway. Now talking about surgical airway in trauma patients, which surgical airway will be preferred? Well, as per the guidelines, the preferred technique is cricothyroidotomy over the tracheostomy. Why? Because it is easier to perform, it involves less blood loss and takes less time to perform. Nowadays in emergency rooms, we are daily, on routine basis, we are performing percutaneous dilatational tracheostomy, but that also is not an emergency procedure and that is not advocated in trauma patient where we have emergency. Moreover, it requires hyperextension of the neck. Coming to the how to predict difficult airway, we all know we are doing it day and night in the PSC clinic. Simply remember the lemon mnemonic. I'm not going into the details. I hope you all are knowing it, or either you learn it by heart. Coming to difficult airway, you should never hesitate to get help. Be always prepared with your plans A, B, and C. And you should always be ready with the choices as per your setup and as per your expertise. And in case you are stuck up with difficult airway, there are a whole lot of things that are available. Suppose on laryngoscopy, you are not able to visualize the vocal cord, so you have got elastic bougie or the Eastman's tracheal tube intubator. Then we have combi tube, laryngeal tube airway. We have got supraglottic airway devices. Option of straightforward going to surgical airway if it is an emergency and you are encountering difficult airway, and other advanced methods like video laryngoscopy and fiber optic, these all are available. And in emergency situation, if you're not able to achieve a definitive airway, you can always go for a needle cricothyroidotomy, which can simply convert this emergency into an urgency, and that is going to buy some time. That is not ventilating your patient, but obviously you will be oxygenating your patient, and you can sustain for as high as 30 minutes. In the meantime, you should go for a definitive airway. So you should have a protocol in place, which you should follow. I'm not going into the detail, but this is one example of an emergency airway management algorithm, which is simply a modification of the ASA algorithm as per the trauma victims. Once you have identified and you have managed any airway compromise, second is to assess for breathing and ventilation. So how to assess? Well, by assessing the respiratory rate, the chest movement, air entry, whether it's bilateral and adequate on both the sides, and the oxygen saturation of the patient. So these all we are going to assess. There are certain signs and symptoms which point towards the chest injury. which can be tachypnea, respiratory distress, hypoxia, tracheal deviation, abnormal breath sounds, and percussion abnormalities, as well as chest wall deformity. Now, out of all the chest injuries, there are few which are immediately life-threatening chest injuries. Like laryngotracheal injuries, obviously this is going to compromise our airway, so it has to be dealt with early in the primary survey. Then comes tension pneumothorax, open pneumothorax, and flail chest with pulmonary contusion. These three conditions are going to compromise or affect our breathing and ventilation of the patient, and that's why they have to be, and they're going to kill our patient very fast. So that has to be managed during the primary survey itself. And we have massive hemothorax and cardiac tamponade along with tension pneumothorax. These three are causes of massive hemorrhage and the patient can land up in shock. So they have to be addressed during the primary survey itself. Besides these, we have a whole lot of conditions which can be potentially life-threatening if we don't pay attention and don't manage them timely. So I'll briefly tell you about these life-threatening conditions only, so that you are able to manage and identify this. Now, coming to the tension pneumothorax, here I would like to emphasize that this is basically a clinical diagnosis. You need not go for some hi-fi investigation or even for a chest X-ray in order to diagnose tension pneumothorax, because it is something very urgent and you need to act very fast. The patient might have respiratory distress, along with the patient may be in shock if that is basically an obstructive kind of shock, because as you can see in the picture, this air collection, the distance collection of air in this pleural cavity, and it is pressing against the mediastinum, and this lung on the same side is collapsed, and it's pushing the mediastinum towards the opposite side. So the patient will have distended neck veins because the venous return to the heart is decreased, because of which the cardiac output is also decreased, and the patient will land up in shock. Then we have tracheal deviation towards the opposite side, absent breath sounds on the affected side. The percussion note will be dull, and we will find an elevated hemithorax which will not be moving. The absent breath sound will be there. And cyanosis is a late sign. As I said, this is a clinical diagnosis. Once you have diagnosed this, so what should we do next? Well, the treatment is very simple. Initially, we have to do a needle decompression. So we have to insert a wide bore needle where should we insert it? Well, traditionally, we have been taught to insert it in the second intercostal space in the mid-clavicular line. And that would result in a sudden gush of air, and the tension pneumothorax is converted into simple pneumothorax. But recently, it has been shown that the chances of this improvement or relief is much better. It is more successful when the needle is inserted in the fifth intercostal space, just anterior to the middle, axillary line. So after we have done needle decompression or even finger decompression, finger thoracostomy is advised nowadays. So whatever we are doing, later on, it has to be followed by chest tube. Otherwise, again, it will convert into tension pneumothorax. Now, in open pneumothorax, the problem is basically of ventilation. As you can see, because of the large defect, the air is leaking with whenever there is an attempt for ventilating the patient. So because of ineffective ventilation, it becomes an emergency. We need to insert a chest tube away from the site of this wound. And moreover, we need to cover the defect. But it should be a three-sided cover, not complete. Otherwise, with time, this three-sided cover effect basically produces a flutter effect, so that this gets sucked in during inspiration and there is no air leak. So it helps in ventilation. But definitively surgery will be required. So what do we mean by flail chest? Well, this is a segment of the chest wall which has detached from the rest of the thoracic cavity. So it results in paradoxical respiration. As you can see in this picture, during inspiration, it is going outwards as against the rest of the thoracic cage, which is going inwards. The segment is going inwards as against the rest of the thoracic cavity, which is going outwards, and the opposite is occurring in expiration. So there is again ineffective ventilation, plus there can be pain, because of which patient might require short period of ventilation For that, we might need to intubate the patient. We have to oxygenate and may have to ventilate the patient to allow the lungs to re-expand. Anesthesia has to be provided, and fluid administration should be judicious because that may lead to fluid overload and further affect respiration. So when we will call it a massive hemothorax, well, if there is a sudden accumulation of more than 1.5 liters of blood in this pleural cavity, that results in massive hemothorax, but the collection is very fast. What are the signs and symptoms? There will be no breath sounds. There will be percussion dullness, and neck veins will be flat. So as against this tension pneumothorax, in which the dullness is, so the percussion note is hyperresonant, here it is dull, and the neck veins were engorged there, here it is flat. So the patient will be in shock. So this becomes a component of C. So what we should do, we should restore volume and auto transfusion of the blood which is collected in the intercostal drain. Obviously, we need to put an ICD, and if the facilities are there for auto transfusion, it is highly encouraged in these particular patients, and definitive operation has to be done. Coming to cardiac tamponade. So as we have seen that massive hemothorax is a reason for this hemorrhagic shock, but cardiac tamponade as well as tension pneumothorax, these are the producing basically obstructive kind of shock. In cardiac tamponade, as we see in this second picture, there is collection of blood all around in the pericardial sac. So it is compressing the heart from all around and impairs the filling of the venous filling of the heart, as well as impairs the cardiac contractility, resulting in decreased cardiac output and shock. So we will be finding distended neck veins, muffled heart sound, and that's why we always advise to listen for heart sound as well during auscultation of the chest, not simply the breath sounds, because this will tell us about the diagnosis of cardiac tamponade. However, in the noisy, you can see there is a Beck's triad. These three things constitute the shock, low arterial blood pressure, distended neck veins, and muffled heart sound. This is known as Beck's triad. But in a noisy resuscitation room environment, you might not be able to listen to the muffled heart sounds, and because of the shock, the patient might not have distended neck veins. So how do we know then? Then there can be Kussmaul signs, which is paradoxical increase in JVP during inspiration. And patient may land up in pulseless electrical activity, which is one of the rhythms of the cardiac arrest. That means patient may land up in cardiac arrest. It comes, if you remember, if the students remember, this comes under the 5H and 5T of cardiac, of the causes of cardiac arrest. So how to diagnose? Well, focused assessment by sonography in trauma, this fast is going to help us. When we put our probe in the epigastric window, we can find the collection around the heart. And so we can see the collection around the heart like this. So this is going to help us. And we can do an emergency pericardiocentesis followed later on by the surgical, definitive surgical treatment. Now coming to circulation part. Once we have managed the airway and breathing part of the patient, we need to go for C. So what is most important in circulation? Circulation is always with hemorrhage control, that I have already told you. What do we mean by shock? Well, we should be very clear what shock means. It is not simply a combination of hypotension and tachycardia, but it is much beyond that. Shock is an abnormality of the circulatory system that results in inadequate organ perfusion and tissue oxygenation. So it results in a state of generalized hypoperfusion, leading to inadequate oxygen delivery, catecholamines response, and other kind of responses. Since there is diminished oxygen, anaerobic metabolism is there, cellular dysfunction, and ultimately cell death will occur. This is occurring at the cellular level. So overall, if we remember, cardiac output is always heart rate times the stroke volume, and stroke volume is determined by three main factors, that is a preload, myocardial contractility, and afterload. If we understand this basic relationship about the cardiac physiology, it's very easy to understand shock and its pathophysiology, the pathophysiology of blood loss. Early circulatory responses to blood loss are compensatory. what happens in shock is that in order to preserve blood flow to the important organs, that is the kidneys, the heart, and the brain, there occurs progressive vasoconstriction to the rest of the vascular beds, that is the cutaneous, muscular, and the visceral circulation. There is a compensatory increase in heart rate in order to preserve cardiac output as the stroke volume is decreasing. Then tachycardia is the earliest measurable clinical sign of shock. It manifests much before hypotension manifests. By the time hypotension manifests, the patient is already in grade 3 shock. That we'll see later on. Release of endogenous catecholamines increases the peripheral vascular resistance, which in turn results in increased diastolic pressure and reduced pulse pressure. So even before this hypotension occurs, there is a decreased pulse pressure because of increased diastolic blood pressure. So most effective method is to restore venous pressure to normal venous return to normal by locating and stopping the source of bleeding. Because unless we stop this source of bleeding, the volume repletion is not going to help. Immediate involvement of surgeon is necessary in most of the trauma patients who land up in shock, and early transfer should be considered in those patients whose need outgrow our facility. So there are certain terms like acute traumatic coagulopathy and trauma-induced coagulopathy. I'm not going into the details of the pathophysiology, but yes, we should understand that in trauma patients, there is a state of coagulopathy because of the trauma itself. And there are many other factors which will further precipitate this coagulopathy. Well, the very first step in the initial management of shock in trauma patients is to recognize its very presence. So until and unless you recognize its presence, you won't be able to manage it. And to diagnose the presence of, or to recognize the presence of shock, you need to know about its manifestation. Let's take up another case scenario. We have a 28-year-old female who has met with an accident. Patient was unrestrained, and she presented to us with a pulse rate of 126 per minute and a blood pressure of 92/70 millimeters of mercury and a respiratory rate of 28 per minute. The skin is cold and diaphoretic, and the patient is confused and anxious. With this much information, can we say that this patient is in shock? Yes, we can say this patient is probably in shock. Let's see how to recognize shock. Obviously, by the signs and symptoms of impaired tissue oxygenation, like alteration in level of consciousness, anxiety, which is present in this particular patient, cold diaphoretic skin, tachycardia. So why is the skin cold and diaphoretic? Like I said, it is one of the compensatory mechanisms, that is the vasoconstriction to the blood supply to this skin, so as to conserve it for important organs of the body. Then we have tachycardia, followed later on by hypotension. Tachypnea and shallow respiration will be there, and decreased urinary output, which is also one of the important signs which helps us in monitoring the shock state and whether our patient is reviving from shock or not. In trauma, we say that any injured patient who is cold to touch and is tachypneic should be considered to be in shock until and unless proven otherwise, because the most important cause of shock in trauma is hemorrhage. And most of the time, the cause of this hypotension and tachycardia is hemorrhage only. Now, estimated blood loss. We can estimate how much blood has been lost based on the initial presentation of the patient. Like you can see, we have graded the patient in 4 grades of shock: class 1, 2, 3, and 4. Like initially, there is tachycardia, which is manifesting starting from class 1, and in grade 2, it's up to 120 per minute. And grade 3, it is further increased, whereas hypotension is manifesting when the patient has already lost as much as 30 to 40% of the blood volume, which is around 1.5 to 2 liters. This is how we come to know how much blood has been lost by the patient and what to do as what to give as initial fluid replacement. Obviously, we have to start with crystalloid. The moment we receive a patient of shock, patient is in shock, initially we insert 2 large bore IV cannula, preferably 18 or more, and We take some sample to send for typing of the blood, cross-match, as well as other investigations, pregnancy test in case of female of childbearing age. Then we have this blood gas analysis if possible. All these investigations we have to send, and simultaneously we have to start the fluid resuscitation. Nowadays, base deficit is also considered a very good guide to grade our patient in different grades of shock, as well as in guiding the management while we are doing the resuscitation of the patient. Now the question is which fluid to give, what should be our vascular access, and in how much volume we should give it. These are the very, very important questions and very important for the management of shock patients, so that we don't do further harm to the patient. And monitoring the response to fluid is equally important, and to prevent hypothermia is also of utmost importance here. So what vascular access should be preferred? Should we go for a peripheral access, or should we go for a central access? So many a times when I ask this question to students, many of the students say that we should right away go for CVP line insertion, but it's not so. In trauma patients, we have to give fluid fast. And if we remember the Hagen-Poiseuille equation, we know that the flow is directly proportional to the fourth power of the radius and inversely proportional to the length of the tube. So if we go for a peripheral venous cannula of the same gauge as a central line, so the flow is going to be much, much more as compared to the central axis. So definitely we are going to have a peripheral vascular access. But suppose we are not able to achieve, because of any reason the patient is already in shock, all veins are collapsed. So what next? Shall we go for central venous access? Yes, we can go for, but before that we can also try intraosseous access. And I know many of you have never ever tried, even in a mannequin or in any kind of workshops or something like that. So I would sincerely request you all to be acquainted with intraosseous access, because it is one of the accesses which is very helpful. After peripheral, we should go for an intraosseous access, because you can give large volume of fluid through that access also. So what type of fluid? It should be a warmed crystalloid. Isotonic fluid should be given to the patients, because of the reasons we all are much familiar with. Because of the lack of time, I won't go into much detail. Simply, I would say always go for a warm crystalloid solution. And how much to give? This is the most important question. Here, I would like to point out towards the earlier recommendation of aggressive volume replacement. In earlier guidelines, even in the ETS guidelines or in other guidelines, we used to see that they were promoting at least 2 liters of initial fluid before going for blood or blood component therapy or any other measures. But it has got its own risk. Like it increases the blood pressure during initial resuscitation. If we increase the blood pressure, then it's going to cause further bleeding. Before we have stopped the hemorrhage, we should not go for aggressive fluid replacement. This also decreases blood viscosity. The more fluid we are giving, the more dilution is occurring, and this coagulopathy is further increased. Then the transfusion requirement is obviously going to increase, because the bleeding is increasing and electrolyte imbalance is occurring and direct immune suppression. And these all are going to happen, and further risk of hypothermia, because if we are giving this fluid not pre-warmed, rather at room temperature or cold, then it may lead to hypothermia, further hypothermia. And so what is recommended nowadays is balanced resuscitation, which is known by many other names like hypotensive resuscitation or permissive hypotension. So all means same. So what is being balanced here? Our goals of adequate tissue perfusion and oxygenation has to be balanced against our goals of avoiding rebleeding. So during the initial stages, these two both are our goals, but we have to maintain a delicate balance between the two. So for that, we need to accept a lower than normal blood pressure so as to just maintain adequate tissue perfusion, but at the same time preventing any kind of rebleeding, and early use of blood and blood components is advocated. So I was going through Miller's Anesthesia and came across a very interesting sentence. Like this as you can see, cilia of increased hemorrhage and the charybdis of hypoperfusion. So an anesthetist need to navigate between these two. So this is a very interesting story. I think from the Greek mythology, you should go through it. I'm not going to details of these, but yes, this is very interesting concept. We need to maintain a balance between these two. Here again, I would like to emphasize that this balanced resuscitation is not a substitute for definitive surgical control of bleeding. So ultimately, we have to do this till the time the control of bleeding is achieved, but we have to be very quick in doing that. So why hypothermia should be avoided? Because it further precipitates coagulopathy by having a direct effect on the coagulation cascade as well as on the platelet aggregation. So a vicious cycle is established. So this is the lethal triad of trauma comprising of coagulopathy, hypothermia, and acidosis. So we have to avoid this vicious cycle. We should not enter it and try to come out of it as early as possible. So the goals of early resuscitation should be to maintain a systolic blood pressure of around 90 millimeters of mercury, never more than 100 millimeters of mercury, and maintaining a lower hematocrit and platelet count just above 50,000 and core temperature of 35. As you can see here, we are simply maintaining the things. We are not trying to normalize everything. We are not very aggressive. Whereas, so we are dividing the resuscitation into an early and a late part. In late part of resuscitation, once the hemorrhage control is established, obviously we can go for a higher blood pressure, and now we can try to normalize the coagulation status, the electrolyte balance, and everything else. Depending on the patient's initial response to whatever treatment we have given, the fluid that we have given, our patients can be classified. We can look for the improved organ perfusion, and accordingly, we can classify our patients into either rapid responder, transient responder, or minimal responder. So if the patient has responded well to fluid, so that means that patient is less likely going to require blood transfusion. So blood loss was not much, and it was less than 20%, and it has stopped. If the patient is transient responder, that means if he has responded initially, improved initially, but later on again hypotension and signs of shock are there, that means the blood loss is ongoing, and it's maybe up to 40% of the total blood volume. So here we will be needing blood transfusion, and agar time hamare paas kam hai, we can go for a type specific blood rather than going for cross matching, which is going to take time. Whereas in case of non-responders or minimal responders, we can even go for a emergency blood release in the form of not even type specific blood, even a O negative blood can do. And if it is a female patient in the childbearing age, we should always go for a Rh negative blood. So this is a simple guide to go ahead depending on the response of the patient to this initial fluid therapy. Now coming to massive blood transfusion protocol. So when will we call it a massive blood transfusion? When the replacement of whole blood volume takes place within 24 hours, or half that within 3 hours. There should be a massive transfusion protocol in place in all the trauma centers or in all the hospitals who are dealing with trauma patients, because they have shown to improve survival, prevent wastage of limited resources, avoid errors, and improve delivery of products in a timely fashion. Well, nowadays, low ratio resuscitation of the blood components is promoted, which is mostly 1:1:1. That is the PRBCs, the plasma, the FFPs, and the platelets. So it should be given in 1:1:1 ratio. We should have a protocol, MTP protocol in place in every trauma center. It can be institution based. This is one example of an MTP protocol. Here you can see, based on the clinical criteria, there are certain criteria that has to be fulfilled. And if our patient fits in that criteria, we have to immediately contact the blood bank for emergency release of the blood. We have to send the person's sample and for the cross match immediately. Then we have to simultaneously do damage control resuscitation, which I am coming to, which involves limited crystalloid administration. Target should be lower, uncross-matched RBCs and FFP should be given till the time the cross-matched blood is available. Like in RBCs, we have to give blood group O to all the patient as it is a universal donor. Similarly, in FFP, we need to give AB. If we don't know the blood group of a patient, we need to give AB. It is a universal donor in case of plasma. Like in this particular protocol, you can see that the blood bank releases the first pack, which consists of 4 RBC and 2 FFP. Along with, we are considering hemostatic resuscitation in the form of tranexamic acid 1 gram given over 10 minutes, followed by infusion of 1 gram over 8 hours. And later on, the subsequent packs consists of the components in 1:1:1 ratio. So this is how this protocol works. Coming to our case scenario, 2 large bore IVs are in place. 1 liter crystalloid has been given. The vital signs post-treatment are blood pressure of 98/76 millimeters of mercury and the heart rate of 104. The patient still remains confused and unable to give medical history. So the second step in managing shock is to identify the probable cause of shock and adjust treatment accordingly. Well, to remember what are the causes of shock for the students, especially the exam going students, the PG students, I would like to tell you a mnemonic. How we remember this, the causes of main important causes of hemorrhage which leads to shock. 1 on floor and 4 more. As we know, the most important cause of shock is hemorrhage. Rest are non-hemorrhagic. And in hypovolemic shock also, it's not the fluid loss, but it's the blood loss, which is the cause of shock in all the or most of the trauma patient. Non-hemorrhagic causes include the obstructive causes like tension pneumothorax and cardiac tamponade. Then we have cardiogenic causes, neurogenic causes, like spinal cord injury, high spinal cord injury. Here I would like to point out that in neurogenic shock, what is different from hypovolemic or hemorrhagic shock is that the patient will not manifest tachycardia. Instead, there can be bradycardia along with hypotension and rarely septic shock in the later stages. So I told you that shock is due to blood loss in most of the causes. Now, when we talk about the causes of bleeding, the mnemonic I was going to tell is that 1 on floor and 4 more. Always remember this mnemonic, 1 on floor and 4 more. So what we mean by 1 on floor is the external hemorrhage for which we can apply local pressure, which should be done immediately. Then 4 more includes from the thoracic cavity, bleeding in the thoracic case, then abdomen, pelvis, and long bones. These are the major causes of vast majority of cases of hemorrhagic shock. In case of thoracic causes, most of the time we need to insert ICDs immediately as early as possible, and definitive treatment can be done after that. In cases of abdominal bleed, for abdominal bleed, we most of the time fast examination, that is ultrasound in the emergency department, that is very helpful, and that helps us in locating whether there is a collection in all of the 4 windows of the fast, and if required, patient has to be taken up for laparotomy early because surgical intervention is required if there is an intra-abdominal bleed. The next is pelvis. At times, this pelvic bleed is hidden and we underestimate this. But here I would like to tell you that in pelvis, as much as I think 2 liters of blood can accumulate. So it is one of the major causes of your patient landing into shock. Then is long bones. In case of fracture of femur, as much as for 1 femur fracture, as much as 1.5 liters of blood loss can occur. So you can easily imagine what if both the femurs are fractured. So splinting is a very important thing in case of bleeding from the extremities. So how it helps? It helps in 3 ways. First is it prevents further blood loss. Second is it prevents pain, because the sharp bone ends, they impinge on the nerve structure around and may cause severe pain. So it prevents, so it provides analgesia also, and it prevents further injury to the structures that are present around, including the neurovascular structure. So bleeding as well as soft tissue injury is also avoided. So this is simply a short form to remember what are the big 5 causes of hemorrhage in trauma victim and how to manage them. Obviously, 1 hour is a very small time to deal everything in detail. So simply, I would say that to locate bleeding, we should go for a complete, we should do the clinical examination properly, as well as we should take help of the diagnostic tools. In case of primary survey, for locating hemorrhage, it is basically chest X-ray, pelvic X-ray, and the FAST. TPL used to be done earlier, diagnostic peritoneal, but nowadays it's not done at most of the places. So now we know the causes of bleeding. So depending on what is the source of bleeding, we have got so many type of interventions which we need to do to control or stop the bleeding. So as I told, direct pressure can be done for external bleeding. Tourniquet is one important point to be discussed. And I think a few words regarding tourniquet. Normally, tourniquet is not advised because it has got its own complications or side effects. But if you are required, mostly in case of profuse arterial bleeding, in case of some extremity injury, so you should go it in order to, but whenever you have applied a tourniquet, you should keep in mind the time. It should not be applied for continuously for more than 1 hour. Meanwhile, the definitive intervention has to be done, be it surgery or anything you have to done at the earliest, or is it, if it is some kind of ligature of the vessels or anything. And if you have chosen to apply tourniquet, you should be aware that a choice of life has been made over the limb. That means we might be sacrificing the limb later on because of impaired distal perfusion and all that, but still our aim is to save the patient. So tourniquet has its own role. Then reducing pelvic volume, how we can do it? By simply applying a pelvic binder. If it is not available, we can simply use a bed sheet or certain other things to bind around the pelvic. Before that, you should look for pelvic instability, and that should not be repeated time and again, because that is going to dislodge any clot if it is there, and that will promote further pelvic bleeding. So it should be done once only, the pelvic instability test, to look for any pelvic fracture. Then surgery obviously is very important. Coming to hemostatic agents or the antifibrinolytic agents, like I was talking about tranexamic acid, it is advocated nowadays. It is one of the component of the damage control resuscitation, which encompasses basically 3 things. One is permissive hypotension that we have already discussed. Second is hemostatic resuscitation. Nowadays, it is promoted so that along with fluid resuscitation or giving volume, we are also giving hemostatic agent to prevent blood loss in the initial stages. So studies have shown, there are many studies like I think crash to trial, all those are there. I'm not going into detail, but yes, the studies have shown that if tranexamic acid is given early on, preferably within 1 hour, but not beyond 3 hours, then it definitely improves the overall outcome, the morbidity as well as the mortality. So hemostatic resuscitation is very, very important. And when we talk about damage control resuscitation, it simply means in order to control the bleeding. Initially, if laparotomy has to be done in a patient of shock, that has simply to be done to control the bleeding. इस टाइम पे किसी भी तरह की कोई डेफिनेटिव सर्जरी करने की जरूरत नहीं है, and that won't be tolerated by the patient because the patient is very low right now. So अभी हमें केवल damage control surgery ही करनी है. So these are all the components of damage control shock resuscitation. Another important point is to avoid vasoconstrictors. Why? Because it is simply vasopressing or vasoconstricting and further reducing the peripheral perfusion, the end organ perfusion. So try to avoid vasoconstriction, especially before you have filled the volume. Kai baar we have seen ki residents initially also even before giving fluids or blood, they start on the patient on vasoconstrictor. That should not be done. NORAD ko immediately nahi start karna hai. Then coming to the concept of fresh whole blood, this is again something very controversial, but I think in army setting or the military setting, this is still available at many of the centers, and they are going for it, and this is very, very useful, but we have to be very cautious that it has to be really fresh blood and not after it has gone for refrigeration. Then regarding the antifibrinolytic agents, recombinant factor 7A, in army setting or the military setting, this is still available at many of the centers, and they are going for it, and this is very, very useful, but we have
to be very conscious that it has to be really fresh.
Sorry, yes, I can discuss it later on, ma'am. Hello, let me finish my talk. I will be coming to that. Now coming to the role of other, hello. We can have a discussion on the role of fresh whole blood. I would also like to contribute, ma'am. Now coming to the other methods of this hemostatic resuscitation, there are many other things available like factor concentrates we have got. Then we have got prothrombin concentrate and calcium, etc. all should be utilized for the hemostatic resuscitation of the patient. Then few words about the role of whole blood viscoelastic test in the form of thromboelastography and ROTEM or many other tests that are available. So these are the point of care tests and they have their own benefits. Like they are assessing the in what is happening, the whole process of the in vivo, what is happening that can be visualized in vitro. And accordingly, they tell us about which component of this blood is lacking. Accordingly, we can plan what to give, whether we need to give cryoprecipitate or the FFP or a particular factor concentrate and or antifibrinolytic, everything they tell us. If we are able to interpret the graph properly, it is very, very useful. And it should be there in all the trauma centers, especially in the dedicated trauma centers. And nowadays it is being used widely. This we have already discussed. So we have to keep in mind these patient factors, including many patients who are on pacemakers or medications like beta blockers, which will impair the manifestation of shock or even the resuscitation that we are providing. Then we have already discussed about the vicious cycle of shock. That is one of the most important complications progressing to the case scenario. The chest X-ray of this patient shows multiple refractures and right hemothorax, massive hemothorax on the right side, large right side hemothorax, I should say. Right chest tube was inserted, 750 ml of blood was obtained immediately and subsequently 50 ml in the 2 hours. Later on, the vitals of the patients improved and the patient was no more confused. So that means we were able to manage and bring out the patient from shock. After the ABCs have been managed, we will look for disability. Here only it's a quick baseline neurological evaluation, which simply includes the GCS as well as the pupillary response, the lateralizing signs and other detailed examination that will be seen in the secondary survey, or if the patient is fully stabilized. And if required, even at this stage, we can go for neurological consultation if there are signs and symptoms of head injury or of neurological deterioration in the patient. Then we need to expose the patient by completely undressing the patient in order to look for any missed injuries which are responsible, because of which our patient is not being able to stabilize, or we are not able to, if we are not able to find any source of this hemorrhage. And we should be very cautious to prevent hypothermia by covering our patient and all other measures, whatever we can do, like giving all the fluids pre-warmed and keeping the temperature of the room warm, or other active measures of warming the core temperature. So we have got various adjuncts to primary survey, which these all are the adjuncts. We are doing it regularly. Obviously, the vital signs, ABGs, pulse ox, CO2, and this catheters. There are 2 catheters which need to be inserted during the primary survey itself. That is a urinary catheter, and the this Ryle's tube has to be inserted. And urinary catheter is very, very important. Also to monitor the progress of a shock patient by looking at the urine output, by measuring the urine output and ECG. So talking to second, I will be finishing it very fast. Talking about the secondary survey. So, sir, within 5 minutes, I am completing, sir. 2-3
5 minutes. आप ये secondary survey खत्म कर लो.
जी sir. जी sir. So when to do secondary survey? It has to be started only when our patient is stabilized and we have completed the primary survey. And what to do? It has got these components. Take a detailed history of the patient, a detailed physical examination starting from the head to toe to look for all other injuries. Like it's always said that during primary survey, we are basically focusing on the physiological changes brought about, physiological effects of trauma. Whereas during secondary survey, what we are focusing on the anatomical effects of the trauma. Then we have to do a complete neurological examination. And now we can go for special diagnostic tests like CT, MRI, or anything we want to do depending on the injury sustained by the patient. And again, re-evaluation is very, very important, and it has to be done at every stage. So these are the things. Now I'm skipping one word about this compartment syndrome. We should know about it. Students should go and read about it. This is basically a clinical diagnosis. Obviously, there are many things like delta P, the compartment pressure, which are there to diagnose it, but it is a clinical diagnosis based on the feature of pain out of proportion to the injury and tense and shiny skin, all that, and increased diameter of the extremity. You can diagnose it, and what you need to do is simply give a longitudinal incision in that particular facial compartment. Then whichever patient needs to be transferred, they have to be transferred. The decision has to be made early, and they need to be transferred as early as possible. This is the whole summary of what we need to do during the initial survey and resuscitation. To summarize, favorable outcome for a polytrauma patient demands an integrated approach to trauma management. Initial management is dictated by patient's immediate physiological requirements and not the anatomic requirements. ABCDE approach should be followed uniformly. Patients who exceed the capability should be transferred early. We should recognize compromised airway and breathing and manage accordingly. Any patient who is cold to touch and is tachycardic should be considered to be in shock until proven otherwise in the scenario of trauma. Hemorrhage is the most common cause of shock after injury. First step in the initial management of shock is to recognize its presence. Tachycardia is the earliest measurable circulatory sign of shock, and all efforts during resuscitation should focus on reversing all the signs and symptoms of hypoperfusion and all that. And DCR, that is decompress, damage control shock resuscitation, is very important and should be done. Massive transfusion protocols should be in place. Primary goal of all trauma patients with suspected brain injury is to prevent secondary injury by preventing hypotension and hypoperfusion to the brain. And spinal motion has to be restricted in all the patient until and unless the cervical spine injury has been ruled out. Thank you so much for your patient listening, and any questions are most welcome. Sir, I tried to finish in 1 hour, but obviously it is a huge topic.
It's okay, I can understand, but it was very good, that shock, how to be managed, we have discussed. Anything from the chairperson? Pati sir?
Thank you so much for your patience.
Thank you, Dr.
Any questions?
Thank you, sir. Sir,
So,
someone was...
In 1 hour, but obviously,
You have taken 12 minutes.
I can understand, but it was very good.
So that is justified. This is a vast topic.
That shock, how to be managed, we have discussed. Anything from the chairperson? Pati sir?
Yeah, I know about the limit of this hematocrit. What is your idea about the hematocrit?
So I want to say that another chairperson is from on the border, because Colonel Chawla is there, and he has asked that. सर आप बंद कर दीजिए, अभी आवाज सही नहीं आ रही है. त्रिपाठी सर आप ऑन मत करिए, क्योंकि वो वॉइस बहुत खराब आ रही है. दूसरा ये चीज है कि उन्होंने ये कहा है कि त्रिपाठी सर आप ऑफ रखिए प्लीज. ओके. त्रिपाठी सर आपकी तरफ से जो वॉइस आ रही है वो बड़ी डिस्टर्बिंग है, प्लीज उसको ऑफ रखिए, उसको ना चलाइए. ओनली थिंग दैट आई वांट टू से दैट कर्नल चावला हैज सेड दैट पहली चीज तो ये है कि हमको ये देखना है कि अगर ट्रॉमा सेंटर दूर है या जहां एक्सीडेंट हुआ है तो व्हाट इज बेटर, स्कूप और रन और स्टे एंड प्ले, which is better. So scoop and run is better, because जितना जल्दी मरीज को अस्पताल पहुंचाएंगे उतने बचने के चांस है. दूसरा, हम एक शॉक में डॉक्टर हेमलता ये बात करना चाहेंगे कि एनेस्थेटिस्ट को ये लगता है कि हर एक शॉक में नॉरेड, डोपामीन, एड्रेनलिन लगा दो, लेकिन हेमरेजिक शॉक पहली बात तो जब आपको पेशेंट का ब्लड प्रेशर कम मिल रहा है उसको हाइपोटेंशन हो रहा है बिकॉज ऑफ हेमरेजिक शॉक, और वो ग्रेड 4 में, ग्रेड 3 में वो मान रहे हैं जो अच्छा मैनेजर नहीं. If you consider it grade 4, then you will able to save this life. Another thing is that there is no role of any vasopressor or inotrope in hemorrhagic shock. Anesthetist को अपनी अंधी सोच से निकल के बाहर आना पड़ेगा, क्योंकि शरीर का ब्लड वॉल्यूम ही लॉस हो चुका है, and there is no fund to do the vasoconstriction in the body or increasing inotropy and chronotropy in these patients. This is not septic shock. This is hemorrhagic shock. तो पहला काम है स्टॉप द ब्लीड. चाहे वो सर्जरी कराने, इस पेशेंट की जल्दी सर्जरी कराना तो लेना पड़ेगा. वी कांट डिले एनी पेशेंट ऑफ ट्रॉमा हु इज इन शॉक or severe head injury or need laparotomy. We don't need any investigation. This patient to be run, जैसे डॉक्टर हेमलता ने बताया, प्राइमरी सर्वे में रिसक्सेशन करते हुए ओटी में जाएगा. Anesthetist should not delay anything to take this patient. You need only blood grouping. और वो 15 मिनट में हो जाती है अगर आपने सैंपल भेजा. No other investigation needed. And there is no role of vasopressor or inotrope to increase the blood pressure in this patient. Blood product, जैसे कि बताया ना, damage control resuscitation करना. So now we are moving from, thank you Dr. Hemlata and Chairperson Dr. Tripathi sir. Thank you so much for your time and patience. We are moving to the second session, and we have, for this session, we have Chairperson Brigadier Shivinder Singh sir. Sir, आप slide शुरू कर रहे हैं क्या? शिवेंद्र जी को बना दीजिए कोस्ट. सर अपनी वॉइस ऑफ कर लीजिए. ब्रिगेडियर शिवेंद्र सिंह सर, आपकी वॉइस ऑफ है, ऑन कर लीजिए. सर आपकी इमेज आ रही है. आप अपनी सर जो मैंने स्लाइड भेजी,
I can hear you.
Yes sir.
I can hear you.
Please share your slides. CV slides.
Yes. I don't think I'll be able to share the slides. You'll have to project the slides from there only.
No problem.
I'll be introducing Dr. Shavis Sehgal, who will be talking to us about the approach to.
Let me introduce yourself. We have a chairperson,
Yes.
Brigadier Shivinder Singh sir, who is professor and head at Command Hospital Lucknow, and I always respect army doctors because they are serving for the country and we are serving for ourselves. So they are ahead of us, and he has lot of he gone through this service. To be a brigadier, it's very means, I will say, it's a rare for a doctors even in army, because usually they retired at colonel. So I think Colonel Tripathi can understand what I am saying. Being brigadier means you are super professor. What I should say for the participants. And he has very like military awards like GOC in C and other achievements to his credit, besides other publications like 7 in international and 19 in nationals. And
Professor Sahu, I seem to have lost you.
Hello?
Hello.
Hello, we can't hear Dr. Sahu. I think the
Okay.
connection is lost.
So at the outset, if I'm heard, I'd like to thank Dr. Sahu for his wonderful introduction, and a pranam to my guru, Dr. Tripathi, Dr. Colonel Tripathi, under whom I've trained. and I have the highest regards for him. So I'll be introducing to you Dr. Shavi Sehgal. She is an associate professor from the MLB Medical College at Jhansi, and she's a young professor who's been taking active part in the COVID epidemic, and she has also been recognized for that by the government. And she'll be talking to us today about the approach to a trauma patient for orthopedic surgery. I hand you over to Dr. Shavi Sehgal, please.
Good evening. Good evening. Hello. Am I audible?
Yes,
Hello.
Dr. Chavi. Yes, you are. Please
Good
carry
evening,
on.
everybody. Thank you. Thank you, respected chairperson. And good evening, Dr. Sahu. So straight away, I'm started sharing my screen. Yeah.
ये ortho education.
छवि अपनी स्लाइड शेयर करो.
हाँ
ठीक है.
प्रोसेसिंग में.
ठीक है. ओके. ठीक है, आपकी स्लाइड दिख रही है और आपकी वॉइस शुरू कर दीजिए.
Audible है. They are still being uploading. So I would like to thank you the SGPGI for inviting me for this talk, and there has been an overwhelming response this time too. I think there are many participants. So starting straight away with an approach to a case for orthopedic surgery, fracture neck femur. I'm presenting 68-year-old male with a history of fall 2 days back, history of hypertension for the last 10 years. He was on medication. Trauma was sustained by slipping in the bathroom, and that resulted in excruciating pain in the right hip region, and he was rushed to casualty by his son within 1 hour of fall. Then examination was carried out. Patient was conscious. Blood pressure was slightly raised, 170 by 100. Pulse rate was slightly on a higher side. Respiratory and cardiovascular were within normal limit. Hemoglobin, TLC, platelet count, RBS, urea and creatinine, sodium, potassium, serum albumin, they were all within normal limit. ECG showed left ventricular hypertrophy. 2D echo showed diastolic dysfunction as predicted in this age, with a preserved ejection fraction of 58%. So what was the goal of management? It was immobilization of the fracture site and prompt surgical fixation by the orthopedic team. And two types of surgeries were proposed. One is the head conserving surgery, which was not advised because the age of the patient was 68. And secondly, the replacement surgeries, which is now becoming an effective procedure for relief because now it is in growing demand, and it is now performed as an ambulatory surgery as a fast track system. So we were called for the preoperative assessment of this patient. Patients posted for orthopedic surgery, they have a broad spectrum of problems. On one side, we deal with elderly patients and they have a lot of comorbidities, while on the other hand, we have young patients which are usually with no comorbidities, but they are polytrauma patients, which has already been discussed earlier. Age is not a deterrent factor for surgery. Now, this line explains that chronological age of the patient does not determine that they are difficult to handle. But these elderly patients actually have a limited end organ reserve. So a very important matter in this is we should take a proper history that will reveal the chronic conditions that can have an impact on anesthesia to be given. Age-related osteoporosis is very important in these, very prevalent in this age group. Osteoporosis, especially in the post-menopausal females. It is due to the loss of trabecular bone, and these patients are at risk for stress fractures like in minimal impact trauma bhi, like a slight slip in the bathroom, जैसे कि इस patient में था, can lead to fractures. Bones at risk are hip, hand, foot, spine, knee, like इसमें fracture neck femur, what we have seen. Then osteoarthritis is another common problem. In this, as we know, it is inflammation of the articular cartilage, and patient comes with pain, reduced mobility, and deformed joints. There is swelling at the distal and proximal interphalangeal joints, and there are no systemic manifestations. Now, why this is important for us? It is important so that it's for the surgical positioning of the painful joints for regional anesthesia. Then rheumatoid arthritis. Rheumatoid arthritis is different from osteoarthritis by the thing that this is a systemic disease with exacerbations and remissions. Patient presents with early morning stiffness कि मुझे जब सुबह उठते हैं तब हमको multiple joint pain होता है, and as they resume their activity it decreases. Now the important thing is that patients जो rheumatoid arthritis के होते हैं, they are on chronic drugs पर होते हैं, like NSAIDs. So we have to assess them for gastric ulcers and renal complications. Glucocorticoids ले रहे होते हैं वो लोग low dose continuously, so stress dose of glucocorticoids is important. And disease modifying anti-rheumatic drugs पर भी होते हैं, like methotrexate and leflunomide. It is started, they are started early, but what do these drugs do? They increase the risk of infection. Then another important entity is ankylosing spondylitis. Ankylosing spondylitis is fusion of the axial skeleton, like SIJ से शुरू होता है वो, and it ascends to the cervical spine. And what is important to us is patients can have a challenging airway. They can present with TMJ synovitis with a limited mouth opening. They can have damaged cricoarytenoid joints. They can have a narrow glottis, which interferes with the passage of the endotracheal tube. इसमें in this disease, we should order lateral cervical spine X-rays of both flexion and extension of the head, so to see the this thing, the कितना involvement है atlantoaxial joint का, because atlantoaxial joint जो है वो instable हो सकता है, and that a slight extension of the spine during endotracheal intubation can lead to quadriparesis. Preoperative cervical flexion spine radiographs are therefore very important. और अगर diameter of atlas और orantoid के बीच का जो area है वो less than 3 mm आता है, then it's okay. If it is more, we have to plan for awake fiber optic. Then अगर regional anesthesia के लिए हम सोच रहे हैं तो ossification of ligaments is important, and rigidity of the thoracic spine itself demands elective need for mechanical ventilation in the post-operative period. Then coming to cardiovascular changes in the geriatric patient, which we will discuss. On one side, we have arterial aging, that is the atherosclerosis. So we will get increased BP, blood pressure in these groups. On these, and other aspect, we have a fibrotic myocyte, which with decreased contractility. This is very important, that beta receptor responsiveness in times of stress is decreased in these patients, so they can have decreased response to drugs. And conduction delays and arrhythmias के लिए they are prone. Left ventricular systolic and diastolic dysfunction coexist in the geriatric patients. So what we have is a non-compliant heart and blood vessels, which can neither tolerate hypovolemia or exaggerated transfusions. So consider fluid administration carefully in these patients. Then coming to the respiratory system में, because of the elastic recoil and loss of height of the vertebrae and the ribcage, we have a barrel-shaped chest. Lung compliance बढ़ी हुई मिलेगी because of the hyperinflated chest, and chest wall compliance because of the elastin or collagen के loss से कम मिलेगी. So they will be dyspneic, increased work of breathing मिलेगा. And this is important, that ventilatory response to hypoxia and hypercapnia is naturally impaired. Lung volume changes mean diffusing capacity, FEV1 is decreased 6 to 8% per decade. Residual volume is increases by 5 to 10% per decade, and closing capacity, we all know it is the volume at which the smaller airways tend to close. 44 years tak it is written that closing capacity is always less than the FRC. At the age of 44 years, it is equal, and after 44 years, this becomes encroaches on the FRC. So there are more chances of VQ mismatch in the elderly. Then coming to renal and hepatic systems, there is decrease in the GFR of 10% per decade and decrease in the hepatic blood flow also at 10% per decade. So what we are dealing with is a nephrosclerotic kidney and again a liver which has decreased metabolism to of both phase 1 and phase 2. It's a slowing down process. Cognitive issues, we have in a geriatric patient, they deal with issues like memory decline because of neuronal shrinkage and the neurotransmitters involved. And important things here to discuss is they can have dementia, delirium, and depression. Depression is more common in these patients. जैसे Alzheimer's के patients होते हैं, है ना? So they have problems of sleep problems होती हैं, agitation, fluctuations in the level of anxiety, anxious होते हैं बहुत ये, attention and confusion is another aspect. Now, why we are discussing these cognitive issues is that because it is important in the ethical issues of consent. Consent is only given, autonomy to give consent is only to that person that has mental competence, that can understand the complexity and gravity of the situation and its related consequences. So a diagnosis and screening of cognitive issues is very important. It's not easy. We have to use an 88 questionnaire. And हम surrogate consent ले सकते हैं या advanced directives दे सकते हैं. Surrogate consent is that patient knows that he or she can suffer with a such and such disease, and he or she can give surrogacy consent to his or her relative or son or daughter कि ये the person will give consent in situation if the such situation arises. That is the advanced directives and the surrogate consent. Now, important aspect is of cognitive issues comes also when we plan the patient for regional anesthesia. The issue of cooperation arises. And also patient controlled analgesia का question आता है when we are dealing with pain management. So that we cannot give them. Then एक frailty index आया है, that is the index of functional reserve. In patients में multisystemic loss of physiological reserve होता है, तो we have divided into 3 components. First is weakness, second is fatigue, and third is weight loss. And the criteria is there is a weight loss of more than 10 lb. There's exhaustion feel कर रहे हैं patient on day-to-day activities. There's limited physical activity, walk time कम है, grip strength कम है. So these patients are known to be frail or more disabled during or after dealing with stress. Then coming to investigations, which we will order for. First is CBC, hemoglobin, TLC, DLC, ESR, platelet, RBS, then cardiopulmonary, chest X-ray, PFT, ABG, SpO2, resting ECG is important in cardiac patients, 2D echo. Renal में serum creatinine, blood urea, electrolytes are important because they are again on several medications, cardiac medications होते हैं, diuretics पे होते हैं. Airway or spine is important to assess the range of limb and neck movements. Then assessment for positioning on table for regional blockage should be made, whether they will follow the command, and proper position can be made for regional anesthesia. Then risk assessment. Risk assessment is done on factors of age and comorbidity, whether the surgery is elective or urgent, whether the surgery will have massive blood loss and fluid shifts too. Risk is more related with the sum of underlying comorbidities than with the chronological age of the patient. ठीक है? So, अगर 70 years का patient है and he only has a history of hypertension, simple hypertension, and that patient will have less risk as compared to a 60-year-old patient that has undergone a stent placement. So, age alone is not a deterrent factor for surgery, chronological age. It depends overall on the other things, whether the comorbidities and the overall ASA grade of the patient. And we should not subject the patient to abnormal non-invasive cardiac testing because that does not change the management in orthopedic surgery. And we should not delay the surgery because of these investigations. And they say it is written, it is documented that morbidity is not decreased by coronary interventions preoperatively. And if we start the patient on anticoagulants, and they have to be discontinued before surgery. So perioperative bleeding is an added risk factor. So what should be done? What is the ideal time of surgery? Surgery should be performed within 48 hours of admission. अगर हमको morbidity और mortality कम करनी है और post-op complications कम रखने हैं. So what to do is, अगर हमारे पास कोई ऐसा AS634 patient आ जाता है, तो answer is hemodynamic stress reduction. We can use beta blockers. They should be started in a high risk patient, और अगर already they are taking, they should be continued to have a target heart rate of less than 80 beats per minute. Then coming to the intraoperative management of total hip replacement. Usually anterior approach लेते हैं या lateral approach लेते हैं. Surgeons prefer lateral approach, and the patient is kept in lateral decubitus position. So anterior approach में there is chances of less exposure to the tissue, and also chances of lateral cutaneous nerve of thigh जो होती है, that उसके damage होने के chances होते हैं. So lateral approach is the preferred approach, and but the lateral decubitus position के अपने problems हैं, VQ mismatch के, तो हमको we should be ready to deal with them, है ना? And we have to prevent the pressure on the axillary artery and brachial plexus by the dependent shoulder on the dependent shoulder by placing a pad or roll beneath the upper thorax, like we can see in the picture. Then preoperative preparation. Preoperative traction is already put by the orthopedician. Then oxygen therapy is very important in the preoperative period for 48 hours. This is to prevent any hypoxemia. 48 hours are crucial because उस समय आपका fat embolism भी हो सकता है अगर long bone का fracture है. Patient already एक hypoxemic patient है, already उसका already VQ mismatch हो रहा है, उसको cardiac reserve भी कम है, functional reserve कम है, frail patient है, so hypoxemia बिल्कुल नहीं होने देना. So oxygen therapy should be started at once. Large bore IV access लेंगे on the non-dependent arm. क्रॉस मैच ब्लड अवेलेबल कराएंगे. डीबीटी प्रोफाइलैक्सिस शुड बी स्टार्टेड, क्योंकि ऑलरेडी जो पेशेंट है ओल्ड एज पेशेंट्स होते हैं वो malnutrition वाले होते हैं, एंड ऑलरेडी दे आर ऑन बेड. यूजुअली वी सी कि रात को सोने के लिए उठे एंड देन दे सस्टेन अ फॉल एंड दे फ्रैक्चर. Antibiotic prophylaxis is a must. Prevention of pressure sores is again a very important issue. Polypharmacy and adverse drug reaction. We should take history from the patient that whatever drugs they are already on. Then these patients are again in a very depressive state of mind because they deal with chronic pain symptoms, जैसे कि arthritis, which I have told you in the previous slides. So now on table, our problem is कि technique क्या use करनी है. Technique of anesthesia. So it is broadly written that no anesthetic plan is superior. सबके pros and cons होते हैं. ना सबसे पहले हम रीजनल एनेस्थीसिया के लिए बात करते हैं, बिकॉज रीजनल एनेस्थीसिया इज द अपकमिंग थिंग. रीजनल एनेस्थीसिया को हम अगर इफ वी विजुअलाइज वी सी दैट द एपिड्यूरल स्पेस, द एनाटॉमिकल एस्पेक्ट देखें तो एपिड्यूरल स्पेस एरिया जो होता है इन जीजैटिक पेशेंट्स का, इट इज लेस, एंड परमेबिलिटी ऑफ द ड्यूरा मैटर इज इंक्रीज्ड एंड सीएसएफ वॉल्यूम इज लेस. सो डोज रिक्वायरमेंट्स हमेशा कम हो जाते हैं. So for a given volume of central neuraxial blockade, there will be more cephalic spread and shorter time of onset and duration of the block. Then regional anesthesia ki advantages overweighing the disadvantages. Advantage is that mental status assessment can be done. Vascular flow is good because there is peripheral vasodilatation. There is decreased chances of deep vein thrombosis and pulmonary embolism. In the post-operative period, there is less surgical blood loss क्योंकि venous pressure already veins पूरी collapsed है, venous pressure कम है, तो surgical blood loss कम होता है. Then opioid sparing techniques use करेंगे तो POCD, post-operative cognitive dysfunction के chances कम होंगे. And another entity, another name है यहाँ पर preemptive analgesia. So what you understand by preemptive is कि हम analgesia ऐसा दें hip fractures में या orthopedic surgeries में जो intra-op period में के लिए नहीं हो. It should be started in the preoperatively, carry in the intra-op and continue the post-op. So the aim is for early mobilization. Disadvantages of regional is that patient can refuse straight away. Doctor Saab, I don't want any needling in my back. Sedation requirement is there, obviously. Oxygen देना है आपको उनकी anxiety को settle करने के लिए. Hemodynamic instability हो सकती है in some operations because there can be large fluid shifts. Delayed onset can be there if your technique is a failure. Early wearing off हो सकता है, and multiple body surgery cannot be like upper and lower both cannot be operated at once. Then coming to regional anesthesia, we deal with first with issue points है हमारे पास subarachnoid block, point number 1, epidural anesthesia, another in our array is epidural, which is we combine usually subarachnoid with the epidural to give a CSC. Or peripheral nerve blocks. Peripheral nerve blocks are ultrasound की वजह से they are now the upcoming things. For hip arthroplasty, we can use a 3-in-1 block, femoral nerve, obturator nerve, and lateral cutaneous nerve of thigh. Or a lumbar plexus block can also be done. It blocks the sciatic nerve, which has a component supplying the hip. So these are the types or an array of regional anesthesia, which we have. Then coming to the most common anesthesia used, that is the spinal anesthesia. So what we need in hip surgery is a profound block up to T10, and that can be achieved by a small amount of local anesthetic. Main challenge is to control the intrathecal spread of local anesthetic. Hyperbaric LAs sink, which what we know, while hyperbaric LAs swim in a way that level of spread depends on the interaction of the density of local anesthetic with the patient posture. So जैसे हम use करते हैं hyperbaric bupivacaine, you can use 3.5 ml at L2, L3 interspace as shown in the figure. अगर हम lateral decubitus position patient is not able to sit and we want a lateral decubitus position में ही हमको we have to administer the block, then we keep the surgical hip schedule side hip schedule for surgery side upwards, and we make the patient we can make the solution hypobaric by using 1.5 ml distilled water, adding it to 3.5 ml isobaric bupivacaine. Then epidural comes. Epidural anesthesia, which we are all familiar. Certain loss of resistance technique is there, and it passes through the needle passes through the ligamentum flavum and enters the epidural space, and catheter markings are there. Then we can remove the tuhoid needle holding the catheter tightly. Now this analgesia for hip fractures guidelines आई हैं 2020 की. These are important, so I wanted to discuss here. Now guidelines say by the Association of Anesthetists that a single shot nerve block should be provided in the emergency department, and at the time of surgery, at least 6 hours have passed between both the blocks. They should be provided earlier. पहले ही आपको emergency department में जैसे ही patient आता है उसका early resuscitation के साथ you should give a single shot nerve block. The idea is again that of preemptive analgesia. Femoral or facial iliaca block can be used यहाँ पर, and the latter possibly providing better incisional analgesia after surgery. ठीक है? So we can use ultrasound guided placement can increase the accuracy and therefore the adequacy of analgesia. Peripheral nerve blocks should be used routinely to supplement general or spinal anesthesia, they say, and their administration before positioning for spinal anesthesia may reduce the need for additional sedation or intravenous analgesia. Now they are studying the ease of positioning for spinal anesthesia also by giving peripheral nerve blocks in the ED itself. Okay. And they say that whether you are giving a renal block, epidural, spinal, or GA, आप उसको एक block तो दे ही दो. Usually the facial iliaca block or other blocks are there also in line, which we will discuss in the further slides. First, coming to the femoral nerve block. This I will discuss in short because I think there is a separate seminar on nerve blocks. Femoral nerve is nerve supply to the hip joint is very important. It is supplied by the femoral nerve, obturator nerve, superior and inferior gluteal nerve, nerve to quadratus femoris, and sciatic nerve. So we can perform the femoral nerve block by a nerve stimulation technique. As you can see, VAN, vein, artery, and nerve. Femoral nerve can be identified at the lateral aspect in yellow color. So we mark the inguinal ligament and palpate the femoral artery 2 to 3 centimeters below the inguinal ligament. Or this is simply a 22 gauge needle से we inject 10 ml of LA. So that is the landmark technique or the nerve stimulation technique. Then USG guided दे सकते हैं. Via USG transducer को हम place करेंगे. Honeycomb appearance दिखेगी हमको femoral nerve की. Needle insert करके, aspirate करके और local anesthetic inject. Now, this is a very important block, facial iliaca block or FIC, facial iliaca compartment block, as they say, or the technique. This is a technique. इसमें क्या करते हैं हम inguinal ligament identify करते हैं and a femoral artery is again identified, and this is divided into 1/3. 2 centimeter distal to the junction, medial 2/3 और lateral 1/3 के junction पर we insert the needle and 30 to 40 ml of local anesthetic is given. 2 pops are felt. पहला pop मिलेगा हमें facial atta का, which we can see in the diagram. ऊपर facial atta है and then उसके नीचे fascia laika है covering the iliacus muscle, which is beautifully seen in the pink color. And then again vein, artery and nerve, femoral nerve can be seen. Now fascia laika technique they have divided again into suprainguinal and infrainguinal, and they say that suprainguinal is a better technique than infrainguinal. Then another is the pink
Dr.
block.
Sehgal, ma'am, if I may, you'll have to
Yes.
summarize fast because we'll be running out
Yes,
of
yes.
time soon. Yeah.
Okay, sir. Okay, so peng block is another entity that is a pericapsular nerve block. We can use ultrasound guided peng block. In this, we deposit the local anesthetic below the psoas tendon, as we can see, or the landmark technique. Landmark technique is 5 centimeter medial to the anterior superior iliac spine. If we compare the FICB and the peng block, they say that both are equally efficacious, and they say that regional anesthesia is again prefer kar rahe hain rather than general anesthesia, because again it decreases the pulmonary complications, post-operative complications in hip fracture patients. This is the lateral femoral cutaneous nerve block, again 2 centimeter below the anterior superior iliac spine, 2 to 3 centimeter below. This nerve is very important for post-operative pain control. Then lumbar plexus block is now not given, technically बहुत difficult block है, and it's associated with again a lot of number of complications of eletoxicity, large volume देनी होती है, retroperitoneal damage हो सकता है, total spinal हो सकता है. Then coming to general anesthesia issues are this आपको यहाँ bleeding, वहाँ पे तो venous pressure कम हो जाता है, peripheral vasodilatation हो जाता है, तो bleeding के chances कम होते हैं. यहाँ पे आपको कौन सी technique use करनी है? यहाँ पे आपको induced hypotension की technique use करनी है. But the issues for general anesthesia are that pediatric patient है तो delayed emergence हो सकता है, and temperature maintain करना है. Advantage again early onset as long as it is needed, multiple surgery हो सकती है, and greater patient acceptance. Disadvantages again airway instrumentation and impairment of the neurological examination in the post-operative period. Then coming to physiological changes in elderly. When we are dealing with general anesthesia, we should know that elderly patients have a decreased gastric emptying. So we have to remember this. And they have increased body fat. So volume of distribution of the lipophilic drugs is increased. And that of the polar drugs is also concentration of polar drugs is increased because they have decreased body water. Hepatic metabolism and renal भी GFR rates भी कम होते हैं, तो हमको ये भी अपने you have to keep in mind. Then pharmacology of anesthetic agents in elderly patients is that again we can see in this table that brain sensitivity is increased for all the agents. We can see the inhalational agents, the induction agents, all the opioids की brain sensitivity are increased, and clearance from the kidneys decreased. So ultimately क्या होता है? Dose of every agent which we are using in a geriatric patient is decreased. So what should be the choice of anesthetic agent which we are using? We should use a short acting and a less lipid soluble drug. So what drugs are there in our armamentarium? Propofol, fentanyl, rocuron, atracurium, sevoflurane, and desflurane. Okay? And the causes are that because we are dealing with an aging heart and vasculature and a person with blunted responses and blunted both renal and hepatic clearance. इंट्राऑपरेटिव प्रॉब्लम्स क्या आ सकती हैं? पेशेंट की पोजीशन से लेटरल डिक्यूबिटस पोजीशन की प्रॉब्लम हो सकती है, हाइपोथर्मिया की प्रॉब्लम हो सकती है क्योंकि लंबी चलती है सर्जरीज, और ऑर्थोपेडिक ओटी जो होती है उसका टेम्परेचर 6 डिग्री 4 डिग्री सेंटीग्रेड तक हो सकता है. So hypothermia is another problem. So fluid warmers can be used, and blood loss ranges from 0.5 liter to 2 liters तक हो सकता है. But the important thing is that कि orthopedic surgery में blood loss जो हमको दिखता है on table, that is not the actual blood loss. जो blood loss after the release of tourniquet होता है, जो post tourniquet bleeding होती है, that we have to take into mind कि हमको बाद में भी blood loss can double itself. Then bone cement implantation syndrome is another problem which we encounter in cemented surgeries, and it is manifested as hypoxia, hypotension, unexplained cardiac arrest हो जाता है patient को, and it occurs at the time of cement fixation, prosthesis insertion, joint reduction कर रहे हो, and यहाँ पर जो culprit है वो polymethyl methacrylate है जो हम use करते हैं, and इसकी वजह से क्यों होता है? पैथोफिजियोलॉजी क्या है? जब ये हम प्रोसेस कर रहे होते हैं तो फैट, मैरो, cement and bone particles जो होते हैं, they can be seen in the vasculature. They are actually forced into the vasculature and embolized into the vasculature. क्यों होता है? क्योंकि इंट्रामेडुलरी प्रेशर जो है वो जो नॉर्मल इंट्रामेडुलरी प्रेशर होता है वो 30 to 50 मिलीमीटर ऑफ मर्क्यूरी होता है. जब हम रीम कर रहे हैं, सीमेंट लगाते हैं, तो एक एक्सोथर्मिक रिएक्शन होता है because of this binding, and because of this the debris is forced into the circulation. Other theories कहती हैं monomer absorption होता है, histamine release होता है, complement factor और anaphylotoxins are involved. Risk factors क्या है इसमें? Old age important है, comorbidities, pathological fracture अगर patient को है, या intertrochanteric fractures में ज्यादा होता है. तो हमें what should be done? How we reduce the risk and the management? In high risk cases we have to discuss कि cemented करनी है या uncemented करनी है. And usually at the time of cementation we have to increase the oxygen concentration for a good hemostasis. Then medullary lavage कर सकते हैं to decrease the clot formation. And venting of the bone at the lower end permits the air to escape from the end of the cement plug before the process's insertion. अगर हम suspect करते हैं BCIS, so we have to increase again the oxygen concentration and continue it in the post-operative period. और symptomatic treatment होता है with IV fluids, vasopressors, inotropes, and heparin. Heparin acts as a emulsifying agent, and it also helps to increase the end organ perfusion. Then fat embolism is another entity. Now, what is fat embolism? It is simply fat in the circulation. Lekin when it starts to involve the multiple systems, it is known as the fat embolism syndrome. Incidence तो कम है, less than 1%, but mortality इसकी ज़्यादा है, 10 to 20%. Onset can be within 24 to 72 hours, and it is associated with long bone, pelvic fractures, and closed fractures. Risk factors again seen in young males: post-traumatic multiple fractures, bilateral femur fractures, and surgery-related factors again nailing, reaming, bilateral अगर joint replacement है, या फिर high volume of processes use हुआ है. इसमें ट्राइड मिलता है हमको. pathognomic rash होता है on the axilla, conjunctiva, oral mucosa, and neck. Pulmonary dysfunction. Patient can manifest as dyspnea, acute respiratory insufficiency, simple non-tachycardia मिल सकता है patient को, and neurological non-specific symptoms of confusion and delirium. Goods criteria.
Dr. Shavi, we are way over time. I request you to conclude, please.
Okay.
I know I've given that extra 10 minutes. Yeah, I know.
Okay. So diagnostic criteria includes Goods type, which at least includes one major and at least 4 minor features. We can go through, and Schoenfeld fat embolism index भी दिया हुआ है. अगर इससे more than 5/16 होते हैं तो it is diagnostic. Treatment is again symptomatic. Use of steroids is controversial, and supportive treatment. Then venous thromboembolism is important. Patient can present with clot in the deep veins of legs. Risk बढ़ जाती है because in orthopedic surgeries patient की age ज़्यादा है, immobile है, trauma का patient है, and orthopedic surgery is another factor itself for increased risk of DVT. And when this clot travels to the lungs, we say it as pulmonary embolism is there, and this carries a very high risk for death rather than DVT alone. Now, diagnosis of DVT again is very crucial in these patients, because patient can have no signs and symptoms, and so what we can use is an ultrasound or a chest X-ray or simple history and examination. Risk of VT we can see hospitalized patients में, medical patients में तो कम होती है, 10 to 20%, while in hip and knee arthroplasty and patients scheduled for hip fracture surgery में it is the most highest percentage of 40 to 60%. So prophylaxis में we can go for mechanical stockings, intermittent pneumatic compression devices, and IVC filters. Then pharmacological aspect, patient can be placed on an antiplatelet or a warfarin, ultrafraction heparin, enoxaparin, fondaparinux, or dabigatran, zymelia-gatrin. These are direct thrombin inhibitors which are now in use. NICE guidelines of 2018 say that they have preferred a low molecular weight heparin for the prophylaxis and treatment of DVT. And ASRA, American Society of Regional Anesthesia, has given some recommendations regarding to the use of anticoagulants and regional anesthesia. So I think we all should be familiar with them. So I just read one line that low molecular weight heparin is a very important thing. यहाँ पर an interval of 12 hours after the administration of usual dose of low molecular weight heparin and placement of CNB, And epidural catheter ka removal at least should be 8 to 12 hours after the last molecular dose of heparin, or 1 to 2 hours before the next. We can skip this. Bridge therapy पे रखते हैं patients को, which are those on anticoagulants. Why do we need bridge therapy? Because we have to get an appropriate INR, and we have to switch over from warfarin to a low molecular weight heparin. So this is the bridge therapy. Discontinue warfarin for 3 to 4 days before the major surgery and begin low molecular weight heparin every 12 hourly देते हैं, 9 AM and 9 PM. And 3 days सीरीज की चलती है, और उसके बाद लास्ट डोज हम 9 PM को दे सकते हैं इन द इवनिंग, एंड INR को मॉनिटर करते हुए इफ इट इज विद इन नॉर्मल लिमिट देन वी कैन गो फॉर द सर्जरी इन द मॉर्निंग, एंड अगेन इवनिंग में हम इनॉक्सापैरिन स्टार्ट कर देंगे, 3 days देंगे, एंड देन वी कैन स्विच ओवर टू warfarin. Post operative complications, again cardiac complications, which I have already discussed previously also. These patients have a high risk of myocardial morbidity and mortality, and respiratory complications also age related होते हैं सारे. Neurological इसमें aspect बहुत important है. Post operative cognitive dysfunction, that geriatric patients posted for orthopedic surgery long term immobilization में 25 to 50% is a good incidence number. These patients suffer from the problem of cognitive dysfunction, either irritability or awareness deficit or attention deficit में, but not affected by any approach of anesthesia which we have chosen, either GA or regional. Risk factors हमको ध्यान में रखते हुए prophylactic continue करना है medications को, identify करना है at risk patients को, and वही IV fluid and electrolyte का correction करना है, maintain hematocrit, oxygen saturation, and pain. बिल्कुल, pain is an important thing, because unless and until pain control is not there, early mobilization we cannot start. So prevention of pain is important for early rehabilitation. Then post-operative management, again oxygen, pain control in the form of intra-articular injections लगा सकते हैं, local anesthetic with opioids, paracetamol, है ना, fluid balance. Then coming straight with TKR. TKR में issues हैं, advantages, single bilateral TKR में exposure कम होता है, पर higher incidence of perioperative complications हैं. So जो भी AS 3 and 4 patients होते हैं, या more than 75 या कोई comorbidity से suffer कर रहे होते हैं, chronic liver kidney disease suffer कर रहे होते हैं, they are not indicated for single bilateral TKR. This we should know. Now this is important. 2020 में 4-in-1 block of saphenous nerve, obturator nerve, sciatic nerve, and nerve to vastus medialis, they have come in. They're expanding the horizons in post-op analgesias for below knee surgeries. This is all just to decrease the post-operative pain, early mobilization. These are again the blocks which I think will be discussed in another seminar. Hand or upper extremity surgery में brachial plexus is important. Forearm and hand surgeries में intravenous regional anesthesia or bias block is important technique. We can exsanguinate the limb by limb elevation, a smart bandage, inflate the tourniquet by 250 millimeters of mercury, and then we can inject 30 to 50 ml local anesthetic in the hand vein. 0.5% lignocaine is injected, but this is important that this technique is limited to less than 1 hour procedure. This is the diagram showing the brachial plexus. The supraclavicular brachial plexus block is the spinal of the arm, which we say. And usually in orthopedic surgery, we apply a tourniquet. So this is important, that what is a tourniquet? Is a compressing device applied over extremities to control the circulation for a period of time to provide a bloodless field. This is the cuff, tourniquet cuff. It should be applied over proper padding after exsanguination of the limb. Optimal limb occlusion pressures. Occlusion time जो होता है, patient orthopedician हमेशा पूछता है, what is the systolic? Please close the fan. What is the systolic blood pressure of the patient? So 50 to 100 mm above the systolic blood pressure in the upper limb, it is usually 250 millimeters of mercury. In the lower limb, it is 350 millimeters of mercury. And occlusion time is kept to a minimum of 1 to 3 hours. Then prerequisites होते हैं, adequate hydration should be there, temperature should be normal, and blood volume should be normal. And contraindications are there: sickle cell disease, peripheral vascular disease, crush injury, diabetes mellitus, and diabetes neuropathy is another entity in which tourniquet is not applied. Local effects are there of tourniquet inflation. These can be due to the compression and ischemia of the tissue over time. Okay, so at inflation we can see increase in the heart rate and mean arterial pressure after 30 to 60 minutes of inflation, increase in the pulmonary artery pressure in poor ventricular compliance patient. Prolonged inflation में systemic hypertension can develop, so we have to use vasodilators. Then deflation per the opposite happens. There is decrease in the venous and arterial pressure and decrease in the systemic vascular resistance. Then metabolic responses. A washout of acidic byproducts occurs from the ischemic limb to systemic circulation after deflation. So there is a transient decrease in the pH, which will lead to an increase in the EtCO2. Transient metabolic acidosis occurs during the process of deflation of the tourniquet. Then compression, neurologic complications may, there is a combination of nerve compression and ischemia. Upper limb radial nerve is most commonly involved, lower limb common periodial nerve. And if we increase the tourniquet inflation time to more than 2 hours, it can cause postoperative neuropraxia. Then tourniquet pain. Tourniquet pain is a very important thing. It is a poorly defined dull aching pain at the site of application about 1 hour after application. And if we deepen the anesthesia और patient को sedate कर देते हैं या nerve block पे लगा देते हैं तो भी ये जाता नहीं है. So we have to deflate the tourniquet for 10 to 15 minutes and then re-inflate it. So this is important. Then temperature and hematological change. Inflation पर increase होता है core body temperature because it is cut off from the peripheries. Deflation पर decrease होता है. There is redistributive hypothermia. Inflation is in hypercoagulable state and deflation leads to anticoagulation, जिससे post tourniquet bleeding, which I told you, you have to monitor the blood loss in the next 24 hours even after the surgery is over. Then coming to another entity, shoulder replacement. Shoulder replacement is another upcoming technique. Standard monitors लेते हैं, GA use कर सकते हैं. Technique हमारे में with an armored tracheal tube, or we can use an interscalene approach to brachial plexus, which improves the operative conditions, decrease the blood loss, and good muscle relaxation.
Sivinder sir.
I am here.
Yeah. Okay, sir. I think slide are hang, so we can now stop this. Your kind permission.
Yes, I agree with you.
Hello.
हाँ छवि, हम लोग यहाँ पे रुकते हैं अब, क्योंकि हाँ डॉक्टर छवि, हम लोग यहाँ पे रुकते हैं. आपका बहुत अच्छा प्रेजेंटेशन है. I will say we are discussing this, that your presentation is very good and it is very elaborated. लेकिन time issues के मारे हमको रुकना पड़ेगा अभी here.
Sure. We have to stick to the time.
Yeah. No problem. Okay. We will circulate your PDF to all students. That's not a problem. So I will request Sivinder sir to introduce the next speaker.
Thank you, Dr. Chavi. That was an extremely detailed presentation, and I realize you have a total of 94 slides. So you really got everything into this, including the elderly trauma as well as the young trauma patient. We move on to the next speaker, Dr. Prateek Singh Bias. Okay. He's an assistant professor at the SGPGI MS, and he'll be talking to us about the trauma patient for laparoscopy. I'll briefly introduce him. Doctor, there's not very much that they've given me to speak about. So maybe go on to Dr. Bias. You may start, Dr. Bias.
Yeah, sir, I am audible?
Yes. Yes, please start. Dr. Prateek, you'll have to unmute yourself. Dr. Pratik, your mic is off.
Sir, is it audible now?
Yes, now it is. You'll have to come down on your volume.
Okay, sir.
Is it okay?
Is it okay
Yes.
now, sir?
Yes, please start.
Okay, sir. So today in brief, I will be discussing about anesthesia for laparotomy in a trauma patient. It's a weekend duty and we get a call from ED that a patient with blunt trauma abdomen has come and the patient is having positive DPL, or a patient is having fast positive, he's unstable and he's being planned for emergency laparotomy. When we take history, we find that this gentleman was just having drinks and his meal. So to concise, trauma, abdomen and the patient planned for polytrauma are full of surprises. Most urgent cases occur at night usually and during the weekend shifts when more experienced anesthetists are not available. Patient information is limited and previous medical history and details of chronic medication, allergies or genetic abnormalities are unknown. Patients often present intoxicated or full stomach. There can be multiple injuries like thoracic trauma combined with abdominal trauma, and the patient might require several procedures in the same OT setting. So it is associated with different positions for different, like a patient going for laparotomy, then he's having thoracic trauma and he might need lateral positioning and thoracotomy. Another consideration is a difficult airway is not unusual and special airway management equipment may be required at very short notice. Occult injuries such as tension pneumothorax and cardiac tamponade can manifest on OT table itself. The indications are all penetrating wounds need to be explored, all gunshot wounds, and blunt abdominal injuries with the patient having signs of peritonitis or if uncontrolled shock or hemorrhage is there, clinical deterioration during observation, and if the patient is having hypotension with positive fast or diagnostic peritoneal lavage. In pre-op preparations, we should inform all concerned and activate the operating room, adequate arrangement of blood products, informing the blood bank, and arrange for the massive transfusion protocol. If cross-match is not available, at least trauma pack should be present. Basic investigations including pregnancy test if appropriate for age. Neck stabilization all through the preparation and shifting is essential. Fluid resuscitation and antibiotics should be started. And after ruling out head injury and urethral or pelvic injuries, Ryle's tube and urinary catheterization is necessary. In management of anesthesia, the basic points which we will be looking is rapidly securement of the airway with minimizing the risk of pulmonary aspiration. Hemodynamic stability during the rapid sequence intubation is necessary and throughout the perioperative period. Optimal volume and type of fluids as well as blood products. Analgesia or last May post-operative considerations. Coming to induction, careful positioning with ASA standard monitoring is guaranteed. Then minimum 2 wide bore IV access is needed prior to induction. Patients for laparotomy for blunt trauma abdomen, we should have established arterial line for monitoring and sampling during the perioperative period. Hypothermia is an important consideration and applying warming blankets over the non-operating field. Then surface warmer should be in place and rapid infuser systems or hotline should be there in OT. Prior to induction, nasogastric tube suction to minimize the risk of pulmonary aspiration of gastric content is important because we will be considering all the patients full stomach. In airway securement and rapid sequence induction of anesthesia, the anesthetic technique, whichever we are using and the drugs which we are using, it shall provide rapid onset anesthesia and neuromuscular blockade. So the neuromuscular blocking agent which we are using should be fast acting and it should provide good conditions for tracheal intubation. Then in measures to avoid hypotension at induction of anesthesia, we can use increased dose of opioid and reduce the dose of thiopentol or propofol. Then ketamine in dose of 1 to 2 mg per kg can be used as IV induction agent or in combination with thiopentol or propofol. The use of rocuronium instead of succinylcholine has gained popularity. It removes the adverse effect of succinylcholine such as hyperkalemia, increased intraocular pressure, succinylcholine apnea, and malignant hyperthermia. Maintenance of anesthesia can be with volatile agents or total intravenous anesthesia, depending upon clinician's preference and clinical situation. Coming to management of fluids and hemodynamic support. The management of fluids is guided by hemodynamic features such as heart rate and arterial pressure, and markers of organ perfusion such as serum lactate and base excess. Balanced crystalloid solutions offer the mainstay of therapy. Synthetic colloids such as hydroxyl ethyl starches, which were used earlier, are no longer indicated due to association with renal injury. Intraoperatively, large crystalloid volumes lead to gastrointestinal complications such as increased extremity compartment pressures, coagulation disturbances, electrolyte imbalance, hypothermia, and abdominal compartment syndrome. In blood products, the blood product should be always considered and used in resuscitation as well as replacement whenever patient is having anemia, thrombocytopenia, or coagulopathies. In situation of severe hemorrhage, massive transfusion protocol should be initiated. If the patient is actively bleeding, we have to transfuse to keep the platelet count to more than 50,000. INR should be maintained less than or equal to 1.5. And fibrinogen should be measured intermittently in perioperative period, and it should be maintained to more than 1 gram per liter. If the patient is having associated head injury, then a platelet count of more than 1 lakh should be maintained. It is important to have perioperative and intraoperative investigations going side by side. If the facility of TEG or ROTEM is there, then we should use that also. And the values of base deficit, lactate levels, and urine output should be there, should be measured intermittently to guide intraoperative resuscitation. There is a newer concept of damage control surgery. In this, the definitive treatment of the injury is not possible. If the definitive treatment of injury is not possible due to their extent or due to the shock, which is accompanying hypothermia or coagulopathy, then the operation should be terminated with packing done in the abdominal cavity and the temporary closure of the abdomen. Definitive treatment of the organ injuries can be undertaken earlier, and it can wait for several hours or till next day. And the patient should be taken to the OT again when their hemodynamic situation is better and there is physiological restoration with the patient's body temperature or organ function have improved. We should always remind surgeon to look for to keep in mind regarding the abdominal compartment syndrome, where if we are feeling that it's difficult to close, and all the patients, we have to remind surgeon that kindly look for retroperitoneal bleed also and check all 4 quadrants: splenic fossa, subhepatic, pelvic region, and retroperitoneum. Extubating a patient or continuing the patient to post-op ventilation depends upon patient's acid-base status, oxygen requirement, vasopressor requirement, and temperature. If the patient is severely hypothermic or very unstable on high inotropes, then any acidosis is there, then it's better to shift patient to post-op unit with continued ventilatory support. Suppose the patient's physiological status is good enough and we are planning for tracheal extubation, the risk of pulmonary aspiration we should keep in mind, and we should always suction the Ryle's tube or the nasogastric tube which is placed there, and also suction the pharynx or the oral cavity. In post-operative considerations, the analgesia is very important. Poorly managed pain may lead to distress and increased risk of post-operative pulmonary complications such as atelectasis and pneumonia. Techniques to minimize the use of opioids include central neuraxial analgesia, transverse abdominis plane block, or posterior rectus sheath block. These blocks can be combined to central neuroaxial anesthesia, analgesia, and then the patient should have a better outcome. Thoracic epidural analgesia can provide superior analgesia for abdominal and pelvic surgeries and reduce the incidence of postoperative ileus. Other options of analgesia include intraoperative administration or co-administration of lignocaine, ketamine, or magnesium infusions. Lignocaine given IV with a bolus 1 mg per kg and then 0.5 mg per kg per hour infusion has been found to reduce opioid requirements. Similarly, ketamine and magnesium infusions, magnesium infusion at around 25 mg per kg per hour and ketamine infusion like 0.3 mg per kg per hour have shown to decrease the requirement of opioids. In other post-op considerations, avoidance of hyperglycemia, optimizing the nutritional status. Since sepsis, surgical stress, and trauma itself, they are catabolic states and they can lead to lot of energy consumption and loss of muscle mass. We should always maintain patient's nutrition status. If enteral is not possible, then parenteral to prevent malnutrition, sarcopenia, and weakness. Thromboprophylaxis is another important thing which we have to keep in mind. So stockings if the injuries allow, and unfractionated heparin postoperatively is important. Thank you, sir.
Thank you, Dr. Pratik. I think that was very quick and concise. I have one question for you, and that is, you mentioned that starches are not good, colloids should not be used in resuscitation for hypovolemic patients. Whatever evidence that is available today is more for septic shock. Is the role, my question to you is, are they as bad even for hypovolemic shock? Are they actually contraindicated?
Sir, not contraindicated as per se. Hydroxyl ethyl starch, sir, we are avoiding. If we are using also, we are using polyethylene based like Hemaxil. And studies in trauma itself, sir, I didn't find any study which is showing that there is incidence of renal dysfunction or renal compromise.
Precisely. Yeah.
Yes, sir.
Thank you so much. If there are any other questions, Dr. Sahu, Professor Sahu could please ask.
Sir, they have one question is a post-op thromboembolism is suspected. How early to give low molecular weight heparin? I think anyone can take, Dr. Pratik can take, or Dr. Chavi. If I will add on, post-op thromboembolic phenomena is a like exclusion. We always make a differential diagnosis of exclusion. Although the chance of DVT in post-op is around 50 to 60%. And it is mostly neglected, I think, practice, especially in India, because in Western country, they are very concerned about early mobilization, early hospital discharge, and they give the prophylactic low molecular weight heparin to almost all patients, especially those are having high risk criteria and their scoring system is high for the deep vein thrombosis, and because followed that there will be thromboembolic phenomena. So I think this is enough for the PG student that they can read more about this. And we are going for another session. So I request Brigadier Siven sir to introduce Dr. Badri.
Dr. Badri is Badri Prasad Das. He is an associate professor at the IMS BHU. He's an instructor for AHA, BLS, ACLS. He's got FCCS, FCCS, OBS, He's got numerous awards to his credit: the Hansraj Nair Award, the Eugene Go Award, Best International Scientific Research Award, citation by KSCCM Seoul, the V. Mahadevan Award, and the Research Excellency Award, in addition to all the others that he has. He's got 11 publications, 7 international and 4 national, and he's been a guest lecturer in numerous conferences. And he'll be talking today to us about traumatic brain injury, the anesthetic considerations. Dr. Badri, please.
Am I audible, sir?
Yes.
Good evening to one and all. At the outset, I would like to thank Sandeep sir for giving this topic. So for next 20 minutes or so, we will be discussing the classification of traumatic brain injury and the principles of anesthetic management based on few latest recommendations from BTF guidelines and recent updates if time permits. So as we know, trauma is the leading cause of death and disability among this age group, less than 45 years of age, and most common cause of death in trauma is traumatic brain injury. This is regarded as the silent epidemic and is going to be the largest killer by 2022. Deaths due to road traffic accident are more than 1 lakh every year, and half of those are hospitalized only for brain injury. Such is the impact of brain injury. And India is number 1 in many things. Similarly, here, India is going to be the world capital of traumatic brain injury. And TBI is a great concern. Nowadays, we are getting more and more number of TBI patients often having other extracranial injuries like those in abdominal organs, limbs, lungs, maxillofacial bone. Suppose consider a young patient, 35-year, alleged road traffic accident on admission, having GCS 12/15, SDH on the CT scan with 2 mm of midline shift with few abrasions on back. After resuscitation, GCS improves to 14/15. How to manage that? And suppose another case, 60-year-old lady walking on roadside, alleged accident run over by a truck with severe TBI with GCS 6/15. On CT scan, EDH is there, SDH is there, multiple rib fractures are there, splenic injury with multiple long bone fractures in the lower limb. How to manage such a patient? We might be called upon for perioperative management of such patients, which often requires a multidisciplinary approach. Anesthesiologists are involved in the care of such patients at various situations like sedation, giving sedation and anesthesia for diagnostic imaging, for resuscitation in emergency department, for craniotomy or decompressive craniectomy, for extracranial surgeries, and ICU management proper. We must keep in mind that surgical and anesthesia-induced alterations may worsen the existing brain injury by second hit. And as we are living in the era of evidence-based medicine, being anesthesiologists, we need to know the proper approach to and execution of anesthesia in such a victim of TBI. Now, before we go to anesthetic considerations for traumatic brain injury, let us first discuss how it is classified. TBI is classified based on mechanism of injury into open or closed, based on whether the dura has been breached or not, and based on pathophysiology into primary or secondary traumatic brain injury. Primary TBI occurs at the time of impact, and secondary insult occurs as a delayed non-mechanical processes leading to cytotoxic or vasogenic edema, blood-brain barrier breakdown leading to neuronal death. And as per severity, based on Glasgow Coma Scale, it can be classified into mild, moderate, or severe. Mild TBI constitutes around 80% of cases. Now we should remember another scoring system for trauma patients: 4 score, full outline of unresponsiveness. You just remember that, omitting this verbal response, 2 more additions have been done here for tracheostomized or intubated patients: brainstem reflexes and respiratory pattern. This is 4 scoring, FOUR. Now, what are the causes of secondary TBI? Hypotension or hypertension, hypoxemia, hypocapnia or hypercapnia, anemia, hyponatremia, hyperglycemia or hypoglycemia, hypoosmolality, acid-base disorders, and fever. All these can lead to secondary TBI, and this needs to be prevented. Now, you might be called upon for perioperative management of TBI patients, or you might be called upon to anesthetize a patient for extracranial surgery in a patient with TBI, or you might be posted in duty intensive care unit and you might be receiving such a patient. So whatever might be the scenario, the principle behind the management remains the same. So what are the goals of anesthetic management in TBI? To facilitate early cerebral decompression in expanding intracranial hematoma, to maintain cerebral perfusion pressure and treat increased intracranial pressure, to avoid secondary insults, seizures, and coagulopathy, to provide adequate analgesia and amnesia, and to facilitate early postoperative neurological evaluation whenever possible. If a theory question comes, this slide is very important. This has to be written in the answer. Now, if you are posted on duty, you must be knowing which surgery is urgent, which anesthetic techniques should be used, for how long is the patient at risk, that is, what should be the optimal time for any surgical intervention in such a patient of TBI. So remember, if you are finding EDH more than 30 ml, regardless of GCS, you have to take the patient on OT table on emergency basis. Similarly, if SDH, subdural hemorrhage, is more than 10 millimeter in thickness with or midline shift more than 5 millimeter, you have to take the patient on emergency basis. Similarly, if intracerebral hemorrhage is more than 50 ml in amount, or it is more than 20 ml with midline shift of more than 5 mm, then you have to take the patient on OT table. You cannot postpone these surgeries. As per ENLS guidelines 2015, emergency neurological life support, emergency surgery should be considered for any extra-axial hematoma, that is EDH or SDH, more than 1 centimeter thickness, intraparenchymal hematoma more than 3 centimeter in diameter, and any hematoma with more than 5 millimeter of midline shift. You should not delay in taking those patients. Now, what is the timing of surgery for extracranial surgeries, injuries with TBI? Actually, timing is unclear and must be individualized according to the status of ICP, presence of mass effect, stability or instability of neurological state, and severity of associated injuries. And CT abdomen along with CT head may help in deciding about the lesion to be dealt first if you are dealing with splenic injury, for instance. Now, by the time you visit the patient, NCCT might have been done because it is the modality of choice. And there are many recommendations when to go for CT scan. There are a lot of rules. You can remember any one rule, like Canadian CT head rule. If any sign of basal skull fracture is there, or vomiting more than 2 episodes, or age more than 65 years, or any dangerous mechanism of injury was there, then you have to go for CT head. Now, based on that, there are 2 scoring systems on the basis of finding on CT scan: Marshall scoring and Rotterdam scoring. Just remember the names and remember that if anything, any midline shift more than 5 mm is there, it amounts to 4th grade Marshall. And anything which is not surgically evacuated and it is more than 25 ml of amount of any blood or mass, it amounts to 6th Marshall grading. And regarding Rotterdam, if scoring is 5, the modality amounts to 50%. Just remember that. Now, where to look for midline shift exactly? It can be looked at septum pellucidum, or third ventricle, or pineal gland. Now, your patient can have this type of CT. What is this one? This is EDH. You can remember like biconvex or idli sepid, EDH. And this is SDH, concavo-convex or banana sepid. This is actually an emergency because if the amount of blood increases, it will never cross the suture lines, rather it will impinge the side by lying brain. So this is an emergency, EDH. Or your patient might be having this type of CT scan. This is what? This is diffuse axonal injury with loss of gray and white differentiation with lot of punctate hemorrhages here, and effaced systems. This is diffuse axonal injury. You might be called upon to anesthetize this for decompressive craniectomy. So whatever might be the situation, the principles what we will discuss now remains the same. So you will be doing one quick preoperative evaluation, because traditional approach to PAC may not be feasible, we may not be getting that much of time. A brief sample history can be taken, and relevant clinical examination has to be done as per ABCDE protocol, right? And important is to exclude signs and symptoms of raised ICP or impending herniation, like headache, vomiting, altered consciousness, pupillary dysfunction, lateralizing signs, extremity weakness, and Cushing's triad, hypertension, brady, and irregular respiration. Now, what are red flag signs? If GCS is less than equal to 13 or deteriorating consciousness, or if any episode of seizures are there, or any lateralizing signs on neurological examination is there, or any signs of CSF leak, or signs of basal skull fracture, or neck pain or tenderness is there, if any of these signs are there, you have to be alert, more alert. You have to order one urgent CT scan. If CT is abnormal or cerebrovascular injury is there, or CT is not consistent with the clinical signs, you have to ask for an urgent neurosurgical consultation. You have to take the patient into OT table as and when required. Main aim is to prevent and reverse or at least attenuate secondary injury. Now, a lot of centers have these adjuncts now available with us, like you can do one e-fast if you have an ultrasound, bedside ultrasound with you to rule out pneumothorax, hemothorax, peritoneal or pelvic bleeding. You can do one quick echo to exclude stress cardiomyopathy, what is called as cardiomyopathy, whose incidence is very much in severe TBI patients. You must be doing one CT neck, because it is assumed that all TBI patients have cervical spine injury unless proven otherwise with CT neck. And you have to order laboratory investigations like blood grouping, typing, hematocrit, coagulation profile, blood glucose, ABG. And if you have thromboelastography, good, you have to do that. And you can take the use of ultrasound for non-invasive estimation, quick estimation of ICP by doing optic nerve sheath diameter or transcranial Doppler. I will not go into details of that. And these all monitoring are essential for guidance and optimization of therapy and early detection and diagnosis of secondary brain insults. You also can go for EEG monitoring if you have the provision for that. And nowadays, it is recommended to go for jugular venous oxygen saturation and brain tissue oxygen partial pressure, if it is possible at your institute. Now, venous access, whether to take peripheral vein or central vein. This should be tailored to the planned procedure, expected intraoperative blood loss, and estimated preoperative blood loss. Yes, it can be placed for secure venous access and vasopressor administration, but the choice of site varies institution from institution, because many institutes prefer to avoid IJV because they, according to them, JVP might raise and ICP might raise. Yes, theoretical that can happen, but incidence exactly is not known. So choice depends on your preference. But for sure, Trendelenburg position should be avoided during placement of central venous catheter because it will raise intracranial pressure. Now, choice of anesthetic agent. Everything revolves around all these four conditions. One is cerebral metabolic rate, cerebral blood flow, third is cerebral blood volume, and mean arterial pressure. As I have shown you in one slide, the cornerstone in the management of such patients is to maintain cerebral perfusion pressure. What is cerebral perfusion pressure? How it is calculated? It is mean arterial pressure minus ICP. So the drug which maintain cerebral perfusion pressure at a better level, those drugs can be used. For instance, when you are using propofol and barbiturate, actually they are very good drugs because that will decrease CMRO2, leading to cerebral vasoconstriction, leading to decreased cerebral blood flow, and thereby decreased ICP. But if hypotension, which will occur after bolus of these drugs, is not taken care of, that will actually lead to decreased cerebral perfusion pressure. Though they decrease ICP, they might decrease cerebral perfusion pressure if hypotension, the hypotension will be more than decrease in ICP. So you have to be very cautious. If you are using this, try to give them slowly, very slow, and try to treat the hypotension which will ensue after giving this drug. Now, etomidate will actually increase cerebral perfusion pressure because there will be no much hypotension, but it will decrease CMRO2, cerebral blood flow, and ICP. So actually cerebral perfusion pressure might increase. But what is the problem with etomidate is it will decrease the seizure threshold. The chances of seizures will be more. So you should not use this etomidate. Better to use propofol barbiturate with taking care of hypotension that will ensue thereafter. Now coming to benzodiazepines. If the patient with TBI is not protected, airway protection has not been done yet, be cautious while giving benzodiazepine because it will lead to respiratory depression and you might land up into catastrophe. Now, what about ketamine, nitrous oxide? All these have a lot of controversy still going on. Ketamine will actually increase cerebral blood flow because there will be increase in CMRO2 and cerebral vasodilation, thereby increasing intracranial pressure. But according to many trials that have been done, due to good analgesia, that can decrease ICP also. So it is advisable not to use ketamine alone, but that can be used with propofol or barbiturate for proper analgesia. Now, when to use nitrous oxide? That is also a lot of controversies. At least it has to be avoided when you are dealing with pneumocephalus or when you have to stop the nitrous oxide just before closing dura because it is known to increase the amount of air. Now, again, it should not be used as a alone anesthetic agent. It can be used with propofol or barbiturate. But remember, it increases CMRO2, it increases cerebral blood flow, thereby has propensity to increase intracranial pressure. Now, what about inhalational agents? They actually decrease CMRO2, but due to direct action on cerebral vessels, they dilate the vessels and increase cerebral blood flow, thereby increase intracranial pressure. So this has to be avoided. If at all you are using this one, try to use this with a MAC less than 1. And this increase in cerebral blood flow, halothane has this increased propensity to have increased ICP. Hence, now this is an obsolete in neuroanesthesia practice. So if you are using any inhalational agent, try to use with MAC less than 1 and try to avoid halothane completely. Now, there are no data demonstrating improved TBI outcomes based on type of anesthetic agents. A balanced anesthetic technique is thus acceptable. Now, which is an ideal sedative? It should be rapid in onset and offset, easily titrated to effect, like active metabolites. It should have an anticonvulsant property, able to lower CMRO2 and ICP, able to preserve neurological examination. So, till now, there is no ideal anesthetic agent or sedative with us. Dexmedetomidine can be close to ideal, which can be used as ecotherapy with other anesthetic agents as an adjunct. Now, airway concerns. We have to prevent rise of CMRO2 and cerebral blood flow, thereby we have to prevent increased intracranial pressure, and we have to avoid sudden increases or pronounced changes in BP. We have to consider all these patients with TBI as full stomach, and we have to remember that 8 to 10% of these patients might have cervical spine injury. So rapid sequence intubation is important. Also important is to maintain manual inline stabilization. Now, critical pressure is still a controversy. Now, if these TBI patients have maxillofacial injury or airway trauma, these are anticipated difficult airways. So video laryngoscopes can be used. If you are expert, you can use fiber optic intubation. But remember, fiber optic intubation never comes in emergency airway. Now, nasopharyngeal intubation is fully contraindicated in basilar skull fractures, and you have an option of cricothyrotomy or surgical tracheostomy if you are dealing with facial or laryngeal trauma. Now, whether to use succinate choline or ochronium, my previous speaker also have dealt with this topic. If you are using succinate choline, you will be getting ideal intubating conditions within 30 seconds, and it is the effect will stay for 5 minutes. But the problem is many of the these polytrauma patients will be having hyperkalemia, and this can lead to cardiac arrest. And there are certain concerns of increased ICP with choline, but that is also a controversy. Now, many anesthetists are moving towards rocuronium because similar ideal intubating conditions can be obtained with this dosing, 1.2 milligram per kg, within 60 seconds of giving this drug. But we have to remember that the duration of action stays for 60 minutes. So if you are not able to intubate following rocuronium, then the patient is gone, you are gone. So the choice is yours. You can use either of them, but many of the anesthetists are moving towards rocuronium. Now, once you have intubated, how to go for ventilation? Whether you should follow historical brain injury approach or lung protective ventilation. Now, in historical brain injury approach, what we do is we give high tidal volume in a hope of maintaining mild hypocapnia, and we institute low PEEP to preserve venous drainage. But what actually it does is it will lead to barotrauma and atelectroma and increased ARDS up to 30% with increased length of stay in ICU. But in lung protective ventilation, what we do is we give low tidal volume and a high PEEP for targeting optimized oxygenation. But what actually it does is it will lead to permissive hypercapnia. Low tidal volume will lead to permissive hypercapnia, increasing the cerebral blood flow and intracranial pressure. So how to balance all these things? Actually, we have to go for lung protective ventilation with low tidal volume, but the PEEP has to be set below 15, never go beyond 15, because it has been seen that effect on intracranial pressure is significant only when PEEP is more than 15 centimeter of water, that too with hypovolemia. So maintain adequate volume status and never go beyond 15 centimeter of PEEP. Now, what is the role of hyperventilation? It should be better avoided in the first 24 hours because remember, initial response to traumatic brain injury is ischemia. So this hyperventilation is recommended only as a temporary measure, only if you think that there is impending brain herniation, that too only for 15 to 30 minutes to maintain PaCO2 of 30 to 35. This is according to ENLS protocol. So target of PaCO2 should be 30 to 35, and prolonged hyperventilation is required only when you are dealing with a refractory intracranial hypertension. And that too, you have to monitor SGPGI or PBTO2 along with that if you are going for prolonged hyperventilation. What Brain Trauma Foundation says, it says never go below 25. So ideal PCO2 is 30 to 35. That too for a temporary period of 15 to 30 minutes, never go below 25 mmHg of PCO2. Now, oxygenation. What should be the ideal level of PO2? According to Brain Trauma Foundation, it says target PO2 should be more than 60. According to European Brain Injury Consortium, target PO2 more than 75. According to Association of Anesthetists of Great Britain and Ireland, PO2 should be more than 97. What to follow? Usually we follow BTF guidelines, so target PO2 should be more than 60. Now, hemodynamic support. Hypotension is a major determinant and independent predictor of outcome in severe TBI. It is seen in up to 73% of cases, and this is the variable which is most amenable to prevention. So, BTF Brain Trauma Foundation says maintains systolic BP more than 100 millimeter of mercury for patients of this age group, 50 to 69 years. Rest of the age group maintain more than 110. So, 50 to 69 years of age group, systolic BP should be more than 100 millimeter of mercury. Now, what fluid should be used? Avoid hypoosmolar glucose containing solution. Avoid Ringer's lactate because the osmolarity actually is 254 due to incomplete dissociation. And target should be to maintain euvolemic and isotonic or mild hypotonic state with goal-directed based dynamic indicators of fluid responsiveness. You should guide your fluid therapy by dynamic indicators of fluid responsiveness. Now, what is the fluid of choice? Isoosmolar crystalloids such as 0.9% normal saline and plasmalite A. What about colloid? Colloid is a big no in traumatic brain injury. It actually increases mortality rates, and albumin is fully contraindicated in traumatic brain injury. Now, what about tranexamic acid? According to a recent publication in last year, tranexamic acid is safe in traumatic brain injury, and treatment started within 3 hours reduces head injury associated deaths, that too in mild to moderate head injury cases. Dose is 1 gram over 10 minutes, started within 3 hours of injury, followed by infusion of 2 milligram per hour for next 6 hours. So actually this will decrease the mortality rate. What about transfusion triggering traumatic brain injury? This is a clear-cut message. Anemia should be avoided. But what should be the level of hemoglobin in such patients of TBI? Brain Trauma Foundation is fully silent on what should be the level of hemoglobin. American Society of Anesthesia says 8 should be the level. British Committee for Standards in Hematology says 9 should be the level of hemoglobin if cerebral ischemia is there. According to Boost 2 study, this is a study Boost 2, according to which if PBTO2 is less than 20, that is if cerebral ischemia is there, hemoglobin goal should be more than 10. According to recently published Boost 3 study, hemoglobin goal should be more than 9. So what should we follow? As per current consensus, one size fits all may not be the optimal approach. If hemoglobin is 7, restrictive strategy is well tolerated. Between 7 to 9, actually you have to monitor PBTO2. What is PBTO2? Brain tissue oxygen partial pressure. If any time you find that PBTO2 is coming less than 20, that is cerebral ischemia is ensuing, then you have to target hemoglobin of 9. You have to transfuse to maintain hemoglobin of 9. So 7, well tolerated. 9, if cerebral ischemia is there. Now, what about hemostatic therapy? These are nice guidelines. If a patient with TBI was on warfarin therapy for some reason, in that this warfarin has to be reversed immediately with prothrombin complex with a dose of 15 to 50 units per kg. And according to NICE guidelines, we have to maintain platelet count more than 75,000. But according to many other guidelines, it has to be more than 1 lakh. Now, if the patient was on aspirin or any other clopidogrel, any antiplatelet medications, platelet infusions or desmopressin may be useful to for those patients who require urgent neurosurgical intervention. Now, role of vasopressors. Drug of choice, noradrenaline. This can be used in the hypoperfusion phase, which is for the first 72 hours of traumatic brain injury. But remember, after 3rd day, hyperemic phase might ensue. So you should be cautious while using NORAD after 3rd day of traumatic brain injury. And the target mean arterial pressure should be more than 100 to maintain cerebral perfusion more than 70. This is as per Brain Trauma Foundation guidelines. Dopamine has to be avoided because it will lead to cerebral vasodilation, which will increase intracranial pressure. And phenylephrine, yes, it is recommended, especially in cases where tachycardia is present. Many have used vasopressin also. It is as effective as phenylephrine for maintaining cerebral perfusion pressure, but intracranial pressure and PBTO2 improved at the expense of the periphery because vasopressin will cause intense peripheral vasoconstriction. So actually it will improve CPP, but at the expense of periphery. Now, what about hypertension? When to treat? Hypertension aggravates vasogenic brain edema, as we all know, which will raise ICP. However, this might be a compensatory mechanism also to maintain cerebral perfusion pressure as a part of Cushing's reflex. So, prior to ICP monitoring, hypertension should not be treated. So, if it is more than 160, systolic BP is more than 160, no need to treat unless until you are monitoring ICP. Only treat hypertension only if systolic blood pressure crosses more than 180. Now, what is the purpose of ICP monitoring? As I said earlier, cerebral perfusion pressure is the cornerstone of TBI management because cerebral ischemia is the single most important secondary event affecting outcome. Now, we need a surrogate marker to measure CPP. The surrogate marker is ICP, intracranial pressure. Now, many institutes have Codman catheter system to monitor intracranial pressure through a intraventricular catheter. Just remember, this has to be zeroed. This transducer with tri-way has to be zeroed at the level of midbrain. Midbrain corresponds to external auditory meatus. So this has to be zeroed at this level. Now, what are the indications of ICP monitoring? According to Brain Trauma Foundation, any patient who cannot be serially neurologically assessed has to be undergone ICP monitoring. If you are getting an abnormal CT scan in a patient, you have to do ICP monitoring. And if CT scan is normal, but with 2 or more among these 3 variables, then you have to go for ICP monitoring. What are these 3 things? Age over 40 years, unilateral or bilateral motor posturing, and systolic BP less than 90. If any 2 of these 3 things is present along with normal CT scan, you have to go for ICP monitoring. Now, it has been seen that the 2 weeks post-injury mortality decreases if you are using ICP monitoring as a monitoring tool, and the threshold has been recently changed into 22. The treating threshold for ICP is now 22, not 20. Now, what we'll get actually in this Codman monitor, normally P1 is more than P2. P1 is atrial waveform and P2 is tidal waveform. In a non-compliant cranium, you will get P2 more than P1. If a theory question comes, this is a very important slide. You have to mention this cutoff for ICP treatment and this graph. Now, the cerebral perfusion pressure should be maintained at a minimum of 60 mm of mercury in the absence of cerebral ischemia and a minimum of 70 in the presence of cerebral ischemia. How to know you are dealing with cerebral ischemia? Do a PBTO2 monitoring. If it is less than 20, you are dealing with cerebral ischemia. Now, in the absence of cerebral ischemia, if you will aggressively attempt to increase CPP more than 70, you will actually land up into ARDS. So 60 is the cutoff. If cerebral ischemia is there, you can go towards 70. Now, how to manage a patient with increased ICP? This is a tier approach, 0 to 3rd tier. First of all, you will be maintaining the neck and head in the midline with head of bed elevation 30 to 45 degree and maintaining, you should maintain sedation and anesthesia in a proper manner. That comes in 0 tier. If after doing all these things, ICP is still more than 22, you have to go for intermittent CSF diversion. That is intermittent removal from external ventricular drain. If still ICP is more than 22, you have to go to 2nd tier management. Here comes the role of osmotherapy. Don't jump into giving mannitol at the first instance you see a patient with TBI. It comes only in the 2nd tier. First of all, manage 0 and 1st tier. In 2nd tier, give osmotherapy in form of mannitol or hypertonic saline. If still ICP is more than 22, you can go for 3rd tier, like hyperventilation to a level of PCO to 25 to 30, decompressive rhinectomy, barbiturate therapy, and you can go for lumbar draining. Now, as I told you, CSF should be removed at an intermittent manner at a rate of 1 to 2 ml per minute for 2 to 3 minutes. That is, over 3 minutes, you should remove 3 ml to 6 ml of CSF with a interval period of 2 to 3 minutes in between. In such a manner, you have to remove CSF until you are getting a satisfactory ICP or until CSF is no longer egressed. Now, what about hyperosmolar therapy? Brain Trauma Foundation is still silent whether to use hyperosmolar therapy or not and which hyperosmolar therapy should use. Because according to BTF, there is no mortality benefit with using mannitol or hypertonic saline. But it says restrict mannitol use prior to ICP monitoring. I will not go into details about the mechanism of action, how they act. Remember the dose, you might be remembering the dose of mannitol, 0.25 to 1.5 gram per kg over 15 to 20 minutes. But many of us don't know the dose of hypertonic saline. It can be given in 2 forms, bolus dosing or infusion dosing. it is recommended to give bolus dosing as per symptom based. Whenever you see a symptom of increased ICP like unequal pupils or vomiting or sudden headache, or if you are monitoring ICP and you are seeing that ICP is increasing beyond 22, give a bolus of 5 ml per kg hypertonic saline over 5 to 20 minutes. Range is 2.5 to 5 ml for adults, 5 to 10 ml per kg in children. This can be repeated where osmolarity remains less than 360 or when sodium remains less than 160. This can be repeated as per Wiener's criteria. Now, what about infusion dosing? It is based on sliding scale. You monitor serum sodium every 4 hours. If it allows, you have not reached a sodium level of 155 or 160, you can continue this infusion and titrate this infusion at a dose of 1 to 3 ml per kg per hour for adults and at a dose of 0.1 to 1 ml per kg hour for pediatrics. You should remember these dosing schedules. Now, as I told you, BTF is still silent regarding whether to use hypertonic saline or not. But there was a recent publication last year by Neurocritical Care Society, which suggests us that hypertonic saline should be used over mannitol for the initial management elevated ICP because of putative advantages of hypertonic saline, because it is a quicker onset, more robust and durable level of ICP reduction is there. It is recommended in cases of mannitol failure. It can act as a fluid resuscitator and it will have a better cerebral perfusion, and there will be no crystallization while you give. Remember, while giving mannitol, you have to use a filtered IV tubing because crystallization occurs very much with mannitol. Now, NCS suggests that neither hypertonic saline or mannitol should be used in the pre-hospital setting with the intention to improve neurological outcome. Yes, if you want to decrease ICP, use hypertonic saline over mannitol, but neither of them can improve outcome. Well, now mannitol is suggested only when if you are unable to give hypertonic saline, like in cases of hypernatremia more than 160 or fluid overload. So, according to NCS, yes, hypertonic saline with symptom-based bolus dosing, evidence supporting hypertonic saline is more robust. Now, anti-seizure prophylaxis. Give anti-seizure prophylaxis only for first 7 days to prevent early post-traumatic seizure. Not recommended beyond 7 days. Steroids, big no in traumatic brain injury. Temperature modulation, yes, moderate hypothermia has a theoretical benefit of reducing CMRO2, cerebral blood flow and ICP, but actually outcome is controversial. So as of now, treats fever. Fever should be aggressively treated and try to maintain normothermia. Now, glycemic control, hyperglycemia is associated with poor outcome.
Dr. Badri, if I may intervene. Dr. Badri, you'll have to, yeah. Oh.
2 minutes. Intensive insulin therapy has actually no functional outcome advantage. So recommended target is 140 to 180 in such a patient. Now, stress ulcer prophylaxis, yes, chances of Cushing's ulcer are there. So you can go with PPI or S2 blocker or sucralfate. Now, dyselectrolytemia, hypophosphatemia, and hypomagnesemia is very common, which should be treated. And we should know the causes of hypernatremia and hyponatremia in such patients. Now, DVT prophylaxis, the risk of DVT is around 20% in the post-op period. So, in the absence of contraindication, you have to start low molecular weight heparin after discussing with the operating surgeon, because he is the best person who will say you whether you will be increasing the hematoma size or not. So, have a consultation with neurosurgeon and start low molecular weight heparin.
Dr. Badri, I'll request you to conclude now, please.
Now, so many patients can be extubated on table as per difficult extubation guidelines, and we might need an immediate post-op check CT. I'll not go into details of this. This is an update. Just remember that secondary decompressive laryngectomy should be performed only for late refractory ICP elevations. Late meaning after 3 days of treatment of those tire approach. So secondary decompressive laryngectomy only for late refractory ICP elevations. For pediatric population, ICP threshold is still 20 and cerebral perfusion pressure has to be maintained at 40. Now, so to conclude, we need a dedicated neurocritical care team, and if we follow evidence-based guidelines to attenuate secondary injuries, to optimize cerebral oxygenation, and to maintain cerebral perfusion pressure, this can prove to be a success tripod in such patients for better outcome. Thank you, sir.
Thank you, Dr. Badri. I have just one quick question. You mentioned lung productive ventilation. I guess in a patient with TBI who has ARDS, would you be thinking of 6 ml per kg of tidal volume? In the others, I'm sure you'd prefer normal
now, sir, there is a concept of preventing ARDS, sir. There are a lot of risk factors which might land up into ARDS. So in that case, it is recommended that even if you don't have ARDS, you have to give low tidal volume itself. I mean, lung protective ventilation only you have to follow, sir. So that
yeah, so you'll have to weigh the hypercapnia with the lung protection that you achieve.
Yes,
Thank you
sir.
so much, Dr. Badri. And with this, I hand it back over to Professor Sahu. Thank you very much. Good evening.
Thank you, sir. We have Dr. Parul Jindal also the chair as a chairperson. Madam, you want to add something or to conclude the session?
I would like to add 2 points. One, that for the orthopedic patients, now the trauma is because of the increase in life expectancy, we have more old patients. We have patients in the age group of 80s and 90s also who are coming to us. So more care has to be taken for these patients. And secondly, most of us have talked about all these problems and all, but we've just missed out a small point that in today's scenario, we have COVID, which is a very big issue. So some care about the personal precautions has to be taken by the anesthesia team also.
Nice, madam. Your points are well taken. And I thank you to the both chairpersons, Brigadier Sivinder Singh sir and Professor Parul Jindal madam, and all the 3 speakers and Dr. Badri in the last, Dr. Chavi and Dr. Prateek. Thank you so much for making this course very successful, and thank you. So we will request to please start the next session. We have the chairperson, Professor L.D. Mishra sir here, who has been being my examiner when I was doing the PDCC. Namaskar sir. And we have Brigadier Prabhakar sir here. Professor Deven Gupta sir. ये शेयर करना है उसको जाएंगे देखो जरा शेयर स्क्रीन so share हो रहा okay so the chairperson for this session is Dr. Brigadier T. Prabhakar, and we know him because he is the senior most anesthetist here in Lucknow, and he has been the vice chancellor of UP University of Medical Sciences Lucknow. And presently, sir is the director of Vivekananda Institute of Medical Sciences, Lucknow. And being serving in the army, he has got ACE award medals. The another chairperson we have is Professor L.D. Mishra, sir, who is now the distinguished professor of anesthesiology and chief medical superintendent and professor anesthesiology. He remained so many years, I think more than 30 in BHU. And now he is heading administrative post as a CMS at Saraswati Medical College, Unnao. He has been pioneer and I will say visionary, being a senior most anesthesiologist in UP nowadays, as the people we know. And I know him from my student life because he is a very good orator and speaker and recipient of various awards, even the Bhopal ISA Academic Excellence Award, and he also being the former president of SNAC and the ISSP. And he is very good orator, I will say, and very good examiner. A lot of paper, and sir is like a milestone for anesthesia. Like we like person because we see him and we try to be like him. And
my pleasure.
Besides this, sir, besides L.D. Mishra sir, we have Dr. Deven Gupta, who is a professor in Department of Anesthesia at SGPGI. Boss has joined, but I think the voice is not coming. Devendra boss. Okay, sir. There are 2 speakers. The slide is there. You can introduce Dr. Charu and Dr. Rudrashish.
Yeah, the ball is in Dr. Brigadier Prabhakar's court. Is he there on board?
I think not on board now.
Okay, Charu is a very pleasant personality. Is a very dedicated neuroanesthesiologist working at All India Institute of Medical Sciences, Neurosciences department. She is academically and research-wise very sound. She organized the neuroanesthesia update last year, which is kind of a national academic activity, almost like today's national conference. She is editor and on editorial board of many journals, and she has written 5 books along with very renowned anesthesiologists from our institute, and she has 90 plus publications. I'm impressed, really, Charu. I'm really impressed. You're going so fast. Be careful, find little time to your family as well. Academics is always very interesting and very attractive. Family also remains quite a strong support to you in your all endeavor. So find some time. She has very cute children. I think 2 of them I met last year.
Yes, sir. Thank you, sir. Sir, I have 2 daughters.
Thank you, Charu. So
Thank
you can go ahead, Charu. Yes, please. So
Dr. Charu, sir, before Dr. Charu, we have Dr. Udarashish Haldar talk, and Dr. Udarashish Haldar, I don't have the slide, but I will introduce him. He is working as a associate professor in Department of Anesthesiology, SGPGI, and his special interest and working in the neuroanesthesia division in SGPGI, and he's also done the PDCC in neuroanesthesia here, and he is very quite मैं कहूँगा बहुत ही शांत लेकिन बहुत ही समझदार एनेस्थेटिस्ट हैं, और I know from the PDCC because at that time I was faculty in neuro also. So I will request Dr. Udarashish to share your slides first, then after that Dr. Charu will take over.
Yes, Udarashish, welcome.
Thank you, sir.
Thank you,
sir, for the kind introduction. At the outset, please accept my greetings and my greetings to all my seniors, and of course, a very good evening to the students. The topic on which I will be talking today is approach to a case of face-occupying lesion of the brain, specifically restricting myself to supratentorial tumors. So without much ado, let's begin. Now, since I'm restricted to the supratentorial region, let me just give you a brief outline about the anatomy of the supratentorial region. It is that region of the brain which is located above the tentorium cerebelli. It's the largest compartment of the brain, and it consists of the anterior as well as the middle cranial fossa, and amongst it, the cerebrum is the main component. Now, tumors arising in the supratentorial region can be either primary, which are commonest, 85%, and they include gliomas, meningiomas, colloid cysts, PNETs, or pituitary tumors. And in rare occasions, they can be secondaries, of which lung is the commonest primary site, followed by breast, and rarely it can come from malignant melanoma, hypernephroma, or colonic carcinomas. Now, supratentorial tumors are, on the basis of their locations, divided into either intraaxial or extraaxial. Intraaxial, amongst the brain parenchyma, we get gliomas, astrocytoma, oligodendrogliomas, and pinealomas. And it can be intraventricular, like epididymomas or choroid plexus papillomas. And extraaxial locations include meningiomas, pituitary adenoma, schwannoma, dermoid, craniopharyngoma, and chordoma. Now, supratentorial tumors, they have certain characteristics. Number one is they are more common in adults compared to pediatric age group, where the posterior fossa these tumors, they present with headache, seizures, or neurological disorders. Their imaging studies, that is the CT and MRI, will exhibit in contrast enhancing rim with surrounding edema. And since they have significant mass, so the treatment consists of either surgical excision or surgical debulking, chemotherapy, or radiotherapy. Now, there are certain important neurophysiological considerations which need to be taken care of before proceeding with supratentorial tumors. We have to keep in mind that intracranial compartment has a fixed volume, and the three components, that is the brain, matter, blood, and CSF, they all coexist in that. So increase in any component of the supratentorial region will cause volume spatial compensation, and this compensation occurs up to a point where a particular rise in a particular component will be compensated by the decrease in the other, till a point when the ICP will rise exponentially, blood flow will reduce, and herniation will occur. Now, brain herniation, briefly, we need to know about it. They are of different types. It can be transcalvarial, where the brain matter extrudes out from the bony defect. It can be subfalcine, that is below the fossa cerebri. It can be uncal, or it can be the cerebellar herniation, which occurs through the foramen magnum. Now, amongst the neurophysiological consideration, this is one formula which governs the entire neuroanesthetic mechanism. That is, cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. So, when cerebral perfusion pressure is the determining factor, mean arterial pressure and intracranial pressure are the different entities which governs the cerebral perfusion pressure, which ideally should be kept within the range of 70 millimeter of mercury. Any increase in ICP leads to decreased cerebral perfusion pressure, and it may further proceed to cause cerebral ischemia. Now, for keeping in mind this consideration, we need to know that intravenous as well as inhalational agents all can cause decrease in cerebral metabolism, and the technique lies in balancing the metabolism with blood flow, which will determine whether there is any increase or decrease of cerebral blood flow with that particular agent. And net cerebral blood flow in the brain is in totality determined by concentration of anesthetic agents, changes due to the pathology or anesthesia, autoregulatory changes which are inherent in the brain, and the impairment of carbon dioxide responsiveness. Now, amongst the commonly used intravenous anesthetics, we can see that all of them, the commonly used one, barbiturates, propofol, and edominate, equivocally cause a decrease in cerebral metabolism, cerebral blood flow, as well as intracranial pressure. The only exception is ketamine, which causes an equivocal rise of CMRO2, CBF, and ICP, and thus is not a very preferred choice. If we come to inhalational agents, we'll see that nitrous causes an increase in CMRO2, cerebral blood flow, and intracranial pressure. And apart from that, majority of the inhalational agents cause a decrease in CMRO2, but cerebral blood flow and ICP, they rise to varying degrees. This is a rough diagram which was presented by my previous speaker. It says that the agents above this red lines need to be avoided because all of them causes rise in ICP as well as cerebral blood flow. Now, coming to the clinical features of supratentorial tumors, there can be, as I said, that the cardinal feature is the rise in ICP. It causes headache, which is bursting or throbbing, often awakening the patient from sleep and aggravated by cough, posture, change, and strain. They can be vomiting and papilledema as secondary features of raised ICP. Seizures can occur depending upon the location, and also depending upon the location, you can have focal neurological symptoms like sensory deficits, hemiparesis, and cranial nerve palsies. Now, while going for a preoperative assessment, we follow the same rules as we do for any other anesthetic. We need to document chief complaints, history of present illness, past history, personal history, drug history, and allergies. However, certain important considerations, especially when dealing with patients with supratentorial tumors, are the concomitant drug intake and their clinical implications. These patients are often on anticonvulsants like phenytoin, carbamazepine, and levetiracetam, and patients on long-standing anti-epileptic treatment actually require larger doses and or more frequent doses of non-depolarizing neuromuscular agents. They can be often on diuretics like furosemide or mannitol, which can lead to dyselectrolytemia and volume contraction. Steroids are often prescribed for reduction of brain edema, which themselves can cause hyperglycemia, HPA suppression, or mucosal effects on the gastrointestinal tract. And acetazolamide, which is often prescribed for reduction in CSF production, can cause metabolic acidosis and hypokalemia. So these interactions should be kept in mind. Then the general examination and the systemic examination proceeds in almost the same manner, except slight emphasis is given on the CNS, like higher mental functions, cranial nerves, motor sensory coordination, etc. Airway examination, as we do in other cases, where we document the Mallampati scoring, thyromental distance, sternomental distance, mouth opening, condition of the temporomandibular joints, dentition, neck movement, etc. Now, few considerations which need to be kept in mind. First, depending upon the level of consciousness of the patient, GCS needs to be ascertained. Lower cranial nerve involvement, sensory deficits, hemiparesis, all of them need to be looked for, because these might cause impaired gag dysphagia. These may be elicited by the history of impaired gag dysphagia, history of aspiration, pneumonia, etc. Whether or not there is presence and degree of raised ICP that can be assessed by the amount of papilledema, Cushing's response, sutural diastasis, and bulging fontanalis. The last two, that is sutural diastasis and bulging fontanalis, is more common in pediatric patients because the skull hasn't fused as yet. Presence and absence of seizures in these patients, and the nature, position, and vascularity of the tumor also needs to be known beforehand, whether that's a solid or a cystic lesion. Other physiological conditions which need to be kept in mind is the limitation of the cardiorespiratory reserve, orthostatic hypotension, obesity, whether the patient is cachectic or dehydrated, presence or absence of any cervical spine diseases, or pre-existing bony or neuromuscular pathologies. This is because neurosurgical procedures usually involve varied procedures which are more than often unphysiological. So these are the factors which actually will govern whether the patient will be able to tolerate a decent degree of unphysiological positioning for prolonged periods. Now, regarding the radiology, nobody expects you to be masters in that, but then it's a good idea if you can have a brief amount of preoperative look at the scans, because this will give you a decent amount of idea about the position of the tumor, the expected the consistency of the tumor, the proximity to important anatomical structures, venous sinuses, etc. And this will help you anticipate your anesthetic course. Now, coming to the investigations, routine investigations like hemoglobin, TLC, platelet count, coagulation, electrolytes, RBS, renal function test, HbA1c, and long-standing diabetes, chest X-ray, and ECG that we do for routine cases. However, certain specialized investigations also need mention, like transthoracic echocardiography, especially for those patients who are scheduled for sitting position, USG abdomen for those patients who who have angioblastoma to rule out polycystic kidney and pheochromocytoma because they may be a part of the MEN, multiple endocrine neoplasia. Now, the ideal anesthetic management here consists of a smooth induction, maintenance of hemodynamic stability and cerebral perfusion pressure, providing a relaxed brain so that there is optimal surgical access, cerebral protection in case you cannot do it. There can it should be done in a manner so that there is no harm. Nowadays, neuro monitoring is coming up in a big way, so your anesthetic should be compatible with that, and aiming for a rapid and smooth emergence. Pre-medications like anxiolytic, sedative, and analgesic, they have to be titrated. If at all has to be given, should be short-acting or better avoided. This is because benzodiazepine and opioids can cause hypoventilation and partial upper airway obstruction, which can lead to hypercapnia. And hypercapnia itself can lead to raised cerebral blood flow, cerebral blood volume, and ultimately raised ICP. Aspiration prophylaxis is required because there may be increased acid secretion due to increased ICP and steroid treatment. And the raised ICP itself can cause delay in gastric emptying. So this is a must. And all the more important in patients having altered consciousness level, those who are diabetic because of the gastroparesis, same with pregnant patients, and those with impaired gag reflex. Pre-medications nowadays often is done with newer agents like Dexin, etc. Among other medications, anticonvulsant should be advised to be continued till the morning of surgery. So should be the steroids and CA inhibitors. Now coming to the intraoperative monitoring, the usual minimum monitoring requirements include ECG because it helps in detecting response to intracranial retraction and manipulation. Brainstem manipulation often is associated with tachycardia, bradycardia, sinus arrhythmias, or PVTO. Whole lot of tachyarrhythmias can occur. So ECG, continuous ECG monitoring is important. Pulse oximetry, non-invasive blood pressure monitoring. Capnography is essential because it helps in facilitating ventilation, managing PaCO2, and detecting venous air embolism. However, it may not always correspond in elderly or patients with ventilation perfusion mismatch. That has to be kept in mind. Urine output, it'll give us an indication of the perioperative fluid balance, the amount of diuretics, and the diuresis consequent to their use. In case of reduced output, there may be indication of hypovolemia or ADH released. And more so, these patients are prone to develop sodium and electrolyte disbalances like DI, SIA, DH. So early detection of those as well as diagnosis of those sodium and other electrolyte disabilities. So urinary output monitoring is important for those patients. Then specialized monitoring, we have invasive arterial catheter. As far as possible, preferably should be placed before induction for estimating the arterial blood pressure and cerebral perfusion pressure. Here, the transducer should be zeroed at the level of external auditory meters, which estimates the mean arterial pressure at the level of circle of Willis. Additionally, it also provides a sampling source for ABG and glucose. Then comes central venous catheter, which can be placed through the jugular, subclavian, or antecubital vein, depending upon the feasibility. CVP helps a rough estimate of fluid status and also provides a reliable mean of fluid, inotropic, and hypotonic solution administration. Especially should be placed if the tumor is in proximity to large arteries or venous sinuses, if the large vascular tumors are present, or if there is a risk of VAE present. Additionally, the other monitors are peripheral nerve stimulator because it helps in recognition of persistence of drug-induced skeletal muscle or paralysis, and highly specialized monitoring like transesophageal echocardiography, PA catheter, and ICP monitors can be used, but these are all patient selective and have to be used on a case-to-case basis. Induction and intubation of these patients, usual drugs like thiopentone, propofol, or barbiturates can be used because all of them decrease CBF, CMRO2, and intracranial pressure. Non-depolarizing muscle relaxants are usually preferred because choline increases ICP transiently. Often lignocaine or beta blockers can be used to blunt the hypertensive response prior to intubation. As we had said that the induction should be smooth and the pressure response should be as low as possible. And opioids or narcotics like morphine and fentanyl should be given in titrated doses. After induction comes the positioning. Commonly used positions are supine, sitting, park bench, and prone. Of course, there are many other, but these are the commonest. We'll just run through those briefly. Supine position, as we can see in the figure, it's the most common. Here, the head is elevated to 15 to 30 degrees to facilitate venous drainage. Excessive flexion or extension of the head should be avoided because venous drainage may be impaired. Sitting position has its own share of advantages like excellent surgical exposure and facilitation of cerebral, venous, and CSF drainage. However, disadvantages include decrease in blood pressure and cardiac output, or the potential hazard of venous air embolism. Then we have park bench position. The drawback here is that there is a good deal of ventilation perfusion mismatch, and common peroneal nerve is prone to getting injured. Dependent pinna also can get injured. Prone positioning causes pressure over the eyeball, pinna, and the genitalia. There may be kinking of neck veins. Extreme flexion of the head can cause migration of the ET tube or kinking. And brachial plexus, ulnar, and sciatic nerve injuries may occur with this type of positioning. Post positioning, the next step is pin fixation. We use different plays like different frames like Mayfield or Sugita's frame. So it's an intensely noxious stimulus because pin actually gets attached to the pericranium. So needs appropriate blunting by propofol, fentanyl, espoliol, labetalol, whatever may be the agent you prefer. And this is a potential phase where venous air embolism can occur. So should be careful about these complications during this phase. Now, once positioning has been done, the maintenance can be done with oxygen and air mixture added to volatile anesthetics or propofol as and when required. And maintenance is with intermittent doses of non-depolarizing muscle relaxants and opioids. The usually targeted PSO2 is somewhere close to 32 to 35 millimeter of mercury. Either it's normocapnia or slight hypocapnia. Now, a bit about the volatile anesthetics. Amongst the different anesthetics, halothane is the one which causes maximum vasodilatation, followed by desflurane, and sevoflurane causes the least. CO2 responsiveness is preserved, and the autoregulation is preserved. And amongst them, the least impairment causing agent is sevoflurane. As we can see in this diagram, up to 0.5 MAC, CMR suppression occurs. So there is a net CBF decrease. At 1 MAC, CMR suppression equals vasodilatation. There also the CBF remains unchanged. However, beyond 1 MAC, CMR gets reduced, but the vasodilatory effect predominates. And this is where luxury perfusion comes into play. That is, the cerebral blood flow increases disproportionately to that is actually what is required for the cerebral metabolism. Now, nitrous is a very controversial topic. We'll just touch through it. Of course, it is known that it causes rise in the cerebral blood flow, cerebral metabolic rate, and ICP. And this effect is exaggerated when nitrous is used with other inhalational agents. However, when used with propofol, this augmentation is minimal. So it has to be selectively used. Apart from that, apart from the rise in ICP, other concerns are presence of intracranial air pockets, development of pneumocephalus, air embolism, effects evoke potential monitoring, and can cause post-operative nausea, vomiting. Now, this is what we had already talked, that up to 1 MAC, there occurs a correlation or a cordial relation between the cerebral blood flow as well as the CMR, cerebral metabolism. But beyond 1 MAC, cerebral blood flow predominates, whereas metabolism remains low. And that is where this uncoupling occurs. Now, the use of PEEP, we'll come to the ventilatory strategies. Often the use of PEEP is utilized for intraoperative ventilation. It should be used cautiously with monitoring because while increasing the PEEP, there is an increase in mean intrathoracic pressures, which impairs cerebral venous outflow and cardiac output. Up to less than 10 centimeter of water PEEP can be used without significant rise in ICP or decrease in cerebral perfusion pressure. We often come across a term called intraoperative tight brain, which actually requires brain relaxation. So here we need to actually look out for the cause and then treat it accordingly. Usual causes are relevant pressures like JVP, airway pressure, arterial pressure, etc. may be disturbed, not within the normal range. Metabolism may be not controlled because of the patient's depth of anesthesia is not adequate. The patient may have seizures. Use of potential vasodilators like nitrous, calcium channel blocker, or nitroprusside, or any unrecognized mass lesion inside the brain, for example, blood or air pockets or nitrous pockets. So there may be raised JVP also, which may occur due to extreme head rotation or jugular venous compression, head up posture, bronchospasm, straining, cupping, pneumothorax, etc. So these, whatever may be the reason for the intraoperative tight brain, the first step is to identify it, and whatever may be the cause, amongst all of these, that has to be treated. Now, hyperventilation earlier used to be pretty popular because lower PSAO2 causes, the 1 millimeter mercury drop causes a cerebral blood flow change of 1 to 2 ml per 100 gram per minute. This ICP lowering is transient, which stays for approximately 8 hours, and this maintains PSAO2 between 30 to 35 millimeter of mercury. We have certain drugs which are often used for reduction in brain volume. Commonly used are mannitol, hypertonic saline, and fusimide. We'll just run through them briefly. Mannitol, which is the commonest drug, is used in the dosage of 0.25 to 1 gram per kg. It acts by causing an osmotic gradient, which causes movement of extravascular water to intravascular space across the blood-brain barrier. Action begins by 4 to 5 minutes, peaks at around 30 to 45 minutes, and lasts for around 2 to 3 hours. Apart from reduction in brain volume, it also causes free radical scavenging and inhibits cellular apoptosis. However, the side effects include hypotension, rebound intracranial hypertension, and renal failure. And it has to be used very cautiously if the serum osmolarity is more than 320 milliosmol. Then we also have hypertonic saline, which reduces cerebral edema, lowers ICP, and augments the cerebral perfusion pressure. This acts by causing osmotic shift of fluid from intracellular to intravascular and interstitial space. Theoretical benefit of hemodynamic stability also occurs in resuscitation of patients with shock and hypotension. And there may be hypokalemia, hyperchloremia, and mild metabolic acidosis. Complications with these agents include central pontine myelinolysis, skin sloughing, coagulopathy, and red cell lysis. Lastly, we have fusimide, that is the common LASIK, which hastens excretion of water from intracellular space and helps in maintaining the osmotic gradient. The presumed mechanism is the inhibition of chloride channel and prevention of accumulation of idogenic osmoles. And usual dose is 1.5 to 3 milligram per kg. Lastly, in extreme cases, we might have to resort to CSF drainage by either directly puncturing the ventricle or through the lumbar spinal catheter. However, it has to be done cautiously as brain herniation may occur, and in one setting, around 10 to 20 ml of CSF is drained. Now, fluid management, we need to avoid glucose-containing solution because hyperglycemia causes increased lactic production, intracellular acidosis, and aggravates neuronal injury. And the aim of intraoperative fluid management is to maintain normovolemia, normal tension, and avoiding reduction of serum osmolarity. Target hematocrit should be around 30%. Among crystalloids, normal saline, which is the commonest used or the most preferred solution, it is slightly hyperosmolar to plasma, and in large volumes can cause hyperosmolar chloremic acidosis. Ringal lactate, though is hyposmolar, is not that preferred. It has the disadvantage as large volumes can cause cerebral edema. Rarely, different colloids may be used. However, it is well known that starch causes reduction of coagulation factors, interferes with clotting mechanisms, and so limited doses should be used. Albumin is a reasonable choice, can be used depending upon the situation. Now, post-surgery, emergence has to be done in a very controlled manner, and it has to be done only in neurologically intact and uneventful in patients who have undergone an uneventful intraoperative course. The goals of emergence include smooth emergence, calm, cooperative, and response to verbal commands, and avoidance of coughing, bucking, and ventilator fight. Before going for emergence, it is important that normovolemia and normothermia is ensured, normotension is ensured, normoglycemia, mild hyperosmolarity, and appropriate hematocrit levels should all be ensured before planning an emergency. Quite often, many of the patients actually require postoperative elective ventilation. These are those patients who are neurologically compromised, and in those patients where extensive manipulation has taken place, or those who have developed facial or neck swelling, they are hypothermic or have undergone metabolic derangements, have significant brain edema or raised ICDs, surgery which involves vital areas, or in those patients who have suffered significant ischemia due to prolonged vascular clipping or extensive retraction. Now, delayed emergence, it is an undesired condition which occurs, or rather it is defined as when the patient is unable to follow simple verbal commands after 20 to 30 minutes of pharmacological cessation of anesthesia. This is a commonly encountered scenario in neurological procedures. Once the anesthetic causes have been ruled out, we need to find the non-anesthetic causes, which usually are seizure, cerebral edema, intracranial hematoma, pneumocephalus, ischemia, or metabolic or electrolyte abnormalities, and it has to be corrected accordingly. Both early awakening and late awakening have their advantages and disadvantages. Early awakening has the advantages that early neurological examination and intervention is possible. There can be early indication of further investigations, and there is less stress response. However, the drawback is there is increased risk of hypoxemia and hypercapnia, and they require vigilant monitoring in the ICU.
Dr. Rudrashish.
Yes, sir.
Because we are running late, I request you to complete next 5 or 6 minutes, please.
Right, sir. I'm on time. I should be covering within 5 minutes.
Thank you. Thank you.
Delayed awakening has the advantage of less risk of hypoxemia and hypercapnia, better hemodynamic and respiratory control, and earlier transfer to ICU. And the disadvantages include lesser neurological monitoring and larger catecholamine surges because the patient remains intubated. Just a few words about the upcoming modality, which is awake craniotomy. Here the patient remains relatively awake, and surgery is conducted under sedation with local anesthetics. The advantages is that it avoids functional LESA, that is loss of function, by allowing maximum resection with simultaneous preservation of neurological function. And it has specific indications like epilepsy surgeries or tumors and AVM in those areas of brain which are known as eloquent areas, or they control the motor movements of the brain, of the body. Advantages include it avoids GA, monitoring required is less intense, cortical brain mapping can be done, and better resource utilization. However, not every patient is a good candidate. There are certain requirements like the patient needs to be cooperative, able to participate in cognitive testing, uncomplicated airway, absence of sleep apnea, absence of pre-existing paralysis, and absence of mental impairment. Various anesthetic protocols include neurolab anesthesia, propofol opioid infusion, which used to be done previously, a sleep technique using LMA, and nowadays, which is being followed is MAC or conscious sedation, short-acting anesthetic agents and local anesthetics. However, the complications of awake craniotomy should also be borne in mind. They include seizures, decreased level of consciousness, increased ICP, neurological deficits, nausea, vomiting, and pain and loss of cooperation. That's all from my end. Thanks a lot. And I'll be happy to answer any queries. And all the students, wishing you all the best.
Thank you, Dr. Rashesh. Thank you very much for completing on time. Yes, please. There are some questions on the chat box. Should we go, Dr. Rashesh, can you see them? Some questions in the chat box.
So is it for me specifically, because the question is if post-op thromboembolism is suspected, how early to give LMWH?
Only you are the speaker. I don't know. It is not relevant to your talk, but all right. If you like to answer, you may, please. Yes, this is.
It's a very, I'll say it's a, I mean, post-op thromboembolism is suspected. How early? Of course, the thumb rule is as early as possible, but of course we'll have to look out what type of surgery has been done, what is the preoperative coagulation profile, is the patient at risk for intracranial bleeding and all. So it's not a very, sorry, I cannot come to a pinpoint answer, but the overall answer, I'll say if it is suspected, then it shouldn't be delayed.
Correct, correct, very correct. Very correct. That should be the answer. So there is nothing else in the chat box. I don't know why I can't see chat box now. I was saying earlier, now I can't. Anybody, Dr. Deven Gupta, would you like to say something, please? Brigadier Prabhakar? Charu, maybe you ask question, please. Yes, Dr. Charu? Okay, Ridrasis, you spoke so well and so much in details. Just I would like to just emphasize here. Probably you mentioned, but I'm not very sure. I heard. I would like to emphasize here that while taking history of such patients, we have not to forget inquiring about drugs, because most of them will be on drugs like steroids and like I say diuretics or say ferritinins. So one should be very clearly knowing as to what
I dedicated a slide on this same thing, that yes, these patients are often concomitantly taking drugs, specifically anti-epileptics, acetazolamide, diuretics, and steroids, and all of them have their anesthetic implications.
So, and some may be continued, some has to
exactly.
To be, you know. And then what about what is your institution following about pre-incision a dose of steroid or mannitol or both?
Steroids, of course, if the patient is on steroids.
You see, because most of these supratentorial tumors, you see, you have their own problems of little bit hypertension or ICP rise will cause a lot of problem. No?
Right. So as far as
and most of them are on steroids as well.
Yes, sir. As far as steroids are concerned, of course, they are administered for reduction of cerebral edema. They need to be continued till the day of the surgery. Of course, because of long-term usage, patients actually depend on it. So we need to avoid the HPA suppression too. And regarding the mannitol, yeah, we actually in titrated doses depending upon the speed of the surgeon expected. We can start it right at incision or when the bone flap is reached. depends upon how soon the surgeon actually, because it takes close to around 25 minutes for its effect to be evident.
Correct. Very correct. Very correct. Okay. What about prophylactic dose of beta blocker or local anesthetic before extubation?
Yes, this is another. This is of course a very good practice, and
I think we should universally practice this.
yes, because our goal is to smoothen the emergence process as smooth, make it as smooth as possible. So whatever may be the modalities used, in case it can actually prevent those catecholamine surges. So this can of course be helpful.
Thank you, Rudrasis, for a very, very learned presentation. I'm really, I have become wiser, and I believe most students have become wiser. And now the dais is to talk over to Dr. Charu. Dr. Charu Mahajan.
Thank you, sir.
Good evening, sir. Good evening, everyone.
Good evening.
So, after Dr. Rudrasis has nicely explained the basics of neuroanesthesia, I'll be discussing the anesthetic management of the posterior fossa tumor. So first of all, to understand what makes the posterior fossa different, we have to understand its anatomy. So the portion of the intracranial part that is below the tentorium cerebelli constitutes a posterior fossa, that is the infratentorial compartment. It is bounded anteriorly by the dorsum sella and the petrous part of the temporal bones, posteriorly by the squamous part of the occipital bones. The roof is formed by the unyielding tentorium cerebelli, and the floor is formed by the occipital and the petrous bones. So this area, although it's a large cavity, but still it's an unyielding and a very tightly packed cavity. It contains midbrain, pons, medulla oblongata, the cranial nerves 3rd to 12th, the various sigmoid, transverse, and the occipital venous sinuses, the ventricular system comprising of narrow cerebral aqueduct and the 4th ventricle, as well as the major blood vessels. It also contains the reticular activating system, which is responsible for our consciousness. Many vital centers, those controlling the cardiovascular system, the respiratory center, swallowing, coughing, they are all located in the posterior fossa. So any small increase in the intracranial pressure within this cavity can have devastating effect. It can cause a structural damage as well as increase the mortality and the morbidity of this patient. So coming to a case scenario, we have a 19 years old young male admitted with chief complaints of difficulty in walking for last 1 month, nasal regurgitation of fluids for last 2 months, headache with vomiting for last 3 months. So from the chief complaints, we can see the patient has difficulty in walking. So it can be either sensory or the motor ataxia. The nasal regurgitation of fluids, it indicates towards the involvement of the lower cranial nerves, and headache with vomiting, which are the manifestations of the raised intracranial pressure. So most likely from the chief complaints, we can make it out, it's an intracranial SOL or the intracranial pathology, I would say, and likely to be in the infratentorial compartment. So what else we want to elicit? The other signs and symptoms which we have to see, the features of raised ICP and the presence of hydrocephalus. Does the patient has headache, nausea, vomiting, drowsiness, and blurred vision? The cerebellar signs, does the patient has dysdiadokinesia, nystagmus, ataxia, dysmetria? Features of 3rd to 12th cranial nerve involvement, any motor weakness or the sensory involvement. So we have to see all these things in our history and during examination. So for confirmation of the diagnosis, we have to get the CT image of the head or the MRI. So these are the MRI images, the sagittal sections showing a posterior fossa tumor. You can see this is a cerebellar SOL. And this is another image showing the posterior fossa SOL likely to be a brainstem glioma, which is pushing the cerebellum outwards. So both these are situated in the posterior fossa, that is below the infratentorial compartment. This is a picture showing the coronal and the sagittal section of the pineal gland tumor. Although it is not strictly a posterior fossa tumor, but the approach is usually the infratentorial and the supracerebellar approach. So the anesthetic concerns and the surgical concerns remain the same as in the posterior fossa patient. So what are the challenges associated while dealing with such patients? So we have already discussed that there are many vital structures which are situated in a confined space. So it can lead to very rapid increase in the intracranial pressure and brainstem herniation. These patients are usually operated in non-supine positions, either sitting position, the lateral position, the prone or the semi-prone positions, and it has its own anesthetic challenges. The patient might have hydrocephalus. The operating in non-supine position increases the risk of development of venous air embolism and pneumocephalus, which poses challenge to the anesthesiologist. And these patients usually have a very protracted post-operative course, usually requiring long-term mechanical ventilation and even tracheostomy in the post-operative period. So during the pre-anesthetic considerations, always see for the brainstem or the cranial nerve dysfunction in these patients. See whether the patient has elevated intracranial pressure and whether any shunting procedure has been done pre-operatively. Assess the risk for the blood loss, discuss with the surgeon and arrange adequate blood cross-matching and grouping should be done beforehand. Ask the surgeon which position he would operate in and accordingly make the OT ready for such position. Assess the risk of the venous air embolism depending upon the position the surgeon is asking for and the monitors you will be using intraoperatively. Ask the surgeon whether he'll be requiring doing any other special monitoring such as facial nerve monitoring or the evoked potential monitoring, and accordingly we have to modify the anesthetic regimen accordingly as per the monitoring technique. So our goals of anesthesia should be to maintain the cerebral perfusion pressure and stable hemodynamics, proper and safe positioning of the patient. We should take all the measures to prevent, early detect, and prompt treatment of venous air embolism. We have to facilitate electrophysiological monitoring intraoperatively, and we should aim for early and smooth emergence. In the pre-medication, usually we avoid sedators in posterior fossa tumor patient because it not only impairs assessment of neurological status, but it also might cause respiratory depression, further increasing the intracranial pressure. Anti-salogogs may be given and they are quite helpful when you are positioning the patient other than supine. It will prevent the endotracheal tube from the dislodgement by avoiding the wetting of the tapes and the securing tapes. So induction and maintenance, we take a wide bore venous line, attach all the non-invasive standard ASA monitors. The induction and the intubation is standard as Dr. Rudrashish has already discussed for any neurosurgical patient. For these patients, for posterior fossa tumor, usually the neck is extremely flexed. So we usually use a flexometallic tube so that the portex tube does not get kinked. So we use a flexometallic tube. Maintenance is on oxygen or nitrous. Oxygen and nitrous, volatile or TIVA can be used in addition to fentanyl and muscle relaxant. So this maintenance of anesthesia has to be titrated according to the additional monitoring that you are using intraoperatively. The other monitors that we use are the arterial line for the beat-to-beat measurement of arterial blood pressure, as well as for intermittent ABG sampling. But always remember that the transducer has to be zeroed at the level of the tragus, so that to give an adequate measurement of cerebral perfusion pressure. The central venous line is inserted in almost all the patients because these surgeries are usually long-lasting, and also if we might need to aspirate the air, we need a central venous line in place. Monitors for the VAE, if the patient is being operated in sitting position, the different monitors for VAE should be inserted. I'll be coming to this later. The other electrophysiological monitoring such as motor evoked potential monitoring, somatosensory evoked potential monitoring, and the brainstem evoked potential monitoring might be used intraoperatively. So we can see that in this patient, we are inserting a TE probe. This patient has to be operated in a sitting position. And because of the risk of the VA associated, we have decided to insert a TE probe. So TE probe is, after insertion, we focus on the bicable view or the fourth ventricle view. So this also helps in the right positioning of the CVP catheter. As we can see in the right atrium, we can see a speck dot. So by this TE, we can also confirm the right position of the CVP catheter, which should be just below the RA and the SVC junction. The other uses are for, we can also diagnose the patent foramen ovale intraoperatively also with the help of TE. As far for the JR levels, I'll not be going into the details for this. So what are the advantages of the sitting position? The main advantages of the sitting position is that it causes the gravitational drainage of the CSF as well as a venous blood flow from the operative field. So this results in a cleaner field for the surgeon and there is better hemostasis. The other advantages are there is improved surgical exposure, there is improved access to the tracheal tube, chest wall and arms for the anesthesiologist. The FRC is increased because the diaphragm moves downwards. So we have free diaphragmatic movements and the and there is increase in the FRCs. We can also observe the phase for neuromonitoring and this results in a shorter surgical time, although the time taken for positioning increases, but yet the surgical time is less. And there is decrease in the intracranial pressure because of the better drainage. So the physiological changes, there are many, some are advantageous and some are not. So coming to the central nervous system, compared to the supine position, in the sitting position, the ICP decreases, as I've already discussed, because of the better drainage, gravitational drainage of the CSF in the blood, the ICP decreases. The CPP is maintained as such. But we also should also know any hypotension in the sitting position can result in cerebral ischemia. So we have to be very careful of maintaining the blood pressures. In the cardiovascular system, because of the venous pooling in the limbs, there is decrease in the venous return, decrease in the cardiac output. So the heart rate increases and the systolic blood pressure and the mean arterial pressure decreases. In the respiratory system, the total lung capacity increases, the V/Q mismatch decreases, and there is less atelectasis in the lungs. So the benefits are it has low ICP, minimal bleeding compared to the prone position, and better access to the airway. However, the risk involved in the sitting position are the venous air embolism, the paradoxical embolism, development of hypotension, pneumocephalus, paraplegia, quadriplegia, and macroglossia. So the contraindications to sitting position are the presence of a ventricular-atrial shunt and cerebral insufficiency when upright. Large patent foramen ovale and extremes of age are also contraindications. So while positioning, few things we have to keep in mind. So to prevent the venous pooling, we have to apply the DVT pumps beforehand, preload the patient with 8 to 10 ml of crystalloid before positioning. And whenever you position, it should be very graded and slow with alternate movements of the head end and the leg end of the table. And also ensure that there is minimal blackout. That is, the time when the patient is unmonitored, when the monitors are detached, should be minimal. It is better to keep an arterial line in position while positioning so that you are able to monitor the blood pressures. Also, while flexing the neck, ensure that there are 2 finger breadth space between the chin and the sternum to avoid any increase in the venous pressure and the endotracheal tube kinking. Keep an eye on the airway pressures also when the surgeon is positioning the patient. While applying the head clamp, give some local anesthesia at the site of pin insertion to blunt the noxious stimulus. So usually this is the how the patient looks after he's placed supine, placed in the sitting position. So as you can see, the chin is flexed. Ensure 2 fingers breadth between the chin and the sternum. Ensure that all the pressure points are padded. The sciatic nerve, the common peroneal nerve, these are very prone to injury. So we have to take care and adequately pad them. Avoid hyperflexion of the at the hips. Ensure shoulders are supported so that the brachial plexus doesn't get injured. And a very important thing, after the final positioning, always auscultate for the bilateral air entry. Because of the extreme neck flexion, the endotracheal tube might move endobronchially. So adjust your TE probe, adjust your endotracheal tube and reconfirm before giving the patient over to surgeon. So this is how the OT looks, and you can see the pressure transducer has been zeroed at the level of the tragus. So there's very little space left for the anesthesiologist to work in such scenarios. So all of a sudden we see that the ETCO2 falls from 35 to 30. So what do we suspect? So it might be a venous air embolism. What is VAE? It is a sudden and sustained decrease in the EtCO2 of 3 to 5 mmHg in the absence of any change in the minute ventilation. So how does it manifest? The early changes will be, there will be fall in EtCO2, while if you do an ABG, there will be increase in the PaCO2. This is because of the pulmonary air, which causes a VBAC-Q mismatch. So there will be hypercarbia. Hypoxemia is usually a later sign. There will be development of pulmonary hypertension, and in extreme cases, pulmonary edema might occur. In the cardiovascular system, there can be hypotension or hypertension, dysarrhythmias, changes in the heart sounds. We'll be able to see hear a millwheel murmur on if a Doppler is in place. There may be ECG evidence of ischemia. In the central nervous system, there might be hyperemia and brain swelling. So what are the different monitors for VAE? This chart you can find in every book, so I'll not be going into details. So just highlighting the salient points. T is the most sensitive invasive monitor, while precaudal Doppler is the most sensitive non-invasive monitor. T can detect tear in the left side of the heart also. The capnography is a very cost-effective monitor, and it can detect all the hemodynamically significant VAE. So at many centers, those centers which don't have T or the precaudal Doppler, they rely on capnography only. End-tidal nitrogen is the most specific monitor. You should remember these 4-5 points which I've told you. So the treatment you will be asked, if you get this case, it should be on your tips. So intraoperative, inform the surgeon immediately, discontinue nitrous oxide immediately, ask the surgeon to flood the surgical field with fluids, provide bilateral jugular vein compression, aspirate from right atrial catheter, and give supportive treatment. So what are the complications, other complications of the sitting position? So patient, any hypotension can have deleterious effect because of accentuated effect. It can result in cerebral ischemia. So you have to be very careful. There can be pneumocephalus and tension pneumocephalus, macroglossia because of the impairment of the venous drainage and the lymphatic drainage from the face because of extreme flexion of the neck. There can be quadriplegia in this patient because of extreme neck flexion and mechanical compression of the cord. So in the pre-op period, if the patient is scheduled for sitting craniotomy, so ensure that the cervical spine is also normal. Rule out any pathology of the cervical spine also. And peripheral nerve injuries can also occur. So this is the other positions used for posterior fossa tumor surgery are the prone position. So all the pressure points should be padded as for any other surgery. See the neck flexion for the posterior fossa, ensure 2-finger breadth space between these 2 points, and ensure that the abdomen is free. There should be no pressure, otherwise the respiration will be hampered, as well as there will be increased bleeding because of the venous engorgement. The park bench position, all the positioning principles are same for all the position. But ensure in this park bench position or the lateral position that you place an axillary roll beneath the lower chest. It should be, the axilla should be free so that there should be no any brachial plexus injury. It should be placed in the lower axilla. Also, for any position, ensure that your endotracheal tube and your IV lines, arterial lines, CVP lines, and all the monitors are attached securely. Maintenance of anesthesia. The anesthesia can be maintained on TIVA or inhalational, but it has been found that the threshold for transpulmonary passage of venous air is higher during anesthesia with intravenous anesthesia compared with halothane. And if the surgeon is intending for evoked potential monitoring, we prefer TIVA. PEEP may increase the likelihood of PAE after venous air embolism has occurred. It has no role in the prevention of venous air embolism, and many centers keep a PEEP of around 5 mmHg. There is no concrete evidence of avoiding it. But yes, if VAE has occurred, please avoid PEEP. Nitrous oxide for posterior fossa tumor, it can be used safely in the sitting position neurosurgery till the end. There are 2 concerns for the development of VAE and the pneumocephalus. But for the VAE, nitrous oxide has not been implicated to increase the morbidity. But one has to be watchful, and if venous air embolism occurs, we have to switch it as soon as it occurs. For the pneumocephalus, there is no concrete evidence that it should be continued till end or it should be discontinued before the dura closure. And it has been seen that incorporation of nitrous oxide has no substantial effect on amount of intracranial air detected after posterior fossa procedures performed in seated patients. Emergence and extubation. For such patients, assess the preoperative consciousness. The decision to extubate the patient depends upon all these factors, whether the patient had intact consciousness, what was the state of the lower cranial nerves, what was the intraoperative course, was there any brainstem handling. Depending upon these issues, we take a decision whether the patient will be ventilated or not. So these patients often, if they have impaired lower cranial nerve injury, lower cranial nerves, or neurologically, they were not fully conscious preoperatively or had raised intracranial pressure. So we go for postoperative mechanical ventilation in these patients. And often those patients who have lower cranial nerves involved, impaired gag reflex, impaired cuff reflex, these patients are also tracheostomized. So the other postoperative complications, pneumocephalus, hematoma, postoperative nausea, vomiting, pain. Pain is more as compared to the supratentorial procedures because of extensive muscle cutting. Hydrocephalus, respiratory, swallowing, and cardiovascular disorders because the vital centers are located in the posterior fossa. So coming to the pneumocephalus, so the patient may present as delayed recovery. If we are trying to extubate the patient might not wake up. So we should suspect that patient may have pneumocephalus, especially if he has been operated in sitting position. He may have headache, neurological deficit, confusion, agitation, and seizures. So this is a scan showing the development of the tension pneumocephalus where the cerebral hemispheres are being compressed and tenting of cerebral hemispheres has occurred. This is known as Mount Fuji sign. So the treatment is high flow oxygen, and in case it's a tension pneumocephalus, burr hole and aspiration of air should be done. To conclude, posterior fossa surgery is a challenging job, and we should follow basic principles of neuroanesthesia. The positioning should be very safe, and we should remain vigilant for intraoperative complications and should know how to promptly manage these complications.
Hands up to you, Dr. Charu Mahajan. You have saved a lot of time. You are very sensitive about us running late somehow.
Yes,
And you completed.
I still have one more presentation to go.
Yes,
Yeah,
of course. Can we finish this and then you go for the hydrocephalus?
Yes, sir, sure, sir.
In the chat box, there is one question. Will you please just take up that? What
sir,
will the
can you please tell me the question?
What will the airway of, oh, it's gone. Just a minute.
Sir, I will read that.
Yeah, please.
It is saying that when we are having sitting or prone position, the airway choice. So airway choice, I think, is no different from
endotracheal intubation with a flexometallic tube, because in the posterior fossa surgeries, we need extreme neck flexion. So for these cases, we routinely endotracheally intubate the patient with a flexometallic tube.
And double, triple fix.
Yes,
as much
definitely.
as better you can fix. And in prone position, use anti-silog if needed,
Yes.
because of lot of secretions, because this all dressing will 10 साल बाद नीरो का जवाब दे रहा हूँ.
No. I'm sorry. About this, the role of anti-silog in prone position, I would like to know Dr. Charu's opinion. What is his
current?
Sir, at our institute, we are routinely using an anti-silog, especially in those surgeries where they are being operated other than supine positions, especially in prone and sitting and lateral. So we have seen it is very helpful. The amount of secretions is definitely decreased, and the amount of wetting and the wetting of the endotracheal tube tapes.
Yeah, but some are concerned about the possibility of tachycardia and the disturbances.
Sir, glycopyrrolate 0.1 mg given half an hour earlier before starting of the surgery, sir, we haven't seen any significant cardiovascular effects.
Yes, and looking into the advantages, I think it is well indicated.
Yes, sir, definitely atropine, I would not say in an adult patient, but glycopyrrolate in an adult patient has been seen to be safe.
And what will be your plan for pre-medication in low GCS patients?
So definitely, I would not pre-medicate, as I've already said that I would avoid pre-medicating any patient with any sedatives.
So Dr. Aditya, it is clear now to you. We will give anti-silog in other than supine positions, but not other sedatives.
And I will just
Yeah.
I will just add on, sir. Give anti-glyco. If you have concern with tachycardia, you give IM 45 minutes prior.
Oh, great. Oh, great. Yes, yes.
आप ही लोगों ने पढ़ाया है सर ये सब पहले.
नहीं, सही बात है. Very, you are yourself very learned. Dr. Subhajit Guha's question is, in posterior fossa surgery, what are the lower cranial nerve that can be monitored and how?
Yes, there are special endotracheal tubes by which we can monitor the lower cranial nerves, but unfortunately we don't have them at our institute, so we will not be able to monitor the lower cranial nerves. But yes, we are routinely doing the facial nerve monitoring, the trapezius monitoring, the glossopharyngeal monitoring. Those nerves are being routinely monitored. Yes, but the lower cranial nerves, you don't have that special equipment to monitor those.
Dr. Charu, yes.
Sir, I think for PG students, the posterior fossa as well is a very rare case that you will get if you don't find any case at that center. But hydrocephalus you will definitely can get. I think this is more important to discuss for PG point of view. Posterior fossa, only we should know what is the difference from supratentorial and anatomical difference and anesthetic consideration. That's all.
Yes, you are very good. You are very correct. But then Charu must explain to us, please, as to what is more sensitive, ETN2 monitoring or ETCO2 monitoring, because you said it is quite specific, but
yes,
we want to know which one is more sensitive and how much.
Sir, as per for the sensitivity, the non-invasive one is the Doppler, and the invasive, more sensitive one is the transesophageal echocardiography. Between the end-tidal nitrogen and the end-tidal CO2, the end-tidal CO2, it detects all the hemodynamically significant VAE. TA is too sensitive and it might detect all the VAs which are not manifesting or which are not clinically important. But the ETCO2, it detects all the hemodynamically significant VAE. So I would say that end-tidal nitrogen, I haven't seen end-tidal nitrogen, and these days no center has end-tidal nitrogen monitoring, but it is most specific for ear because it can detect air, it can detect nitrogen.
No, Charu, there are studies which say that it is really very much sensitive compared to ETCO2. Okay, what is important is we anesthesiologists should learn to buy machines with ETN2 monitoring, We should not go only for ETCO2. We should also ensure that our machines are in the neuro OTRTs, ETN2. Thank you so much. Okay, thank you so much, Dr. Charu. I think now Dr. Sahu wants us to let you go for hydrocephalus. VP shunt.
Yes, sir, please.
Yes. Yes, please.
Please start.
So the next case I'll be discussing is management of a child with hydrocephalus. This usually comes as a short case. So I'll not be discussing the anatomical and the physiological changes in a pediatric case. So all the PGs are requested to read them from the book nicely. I'll be just highlighting the practical points regarding the anesthetic management. So we have a clinical scenario where the parents present their 2-month-old child with chief complaints of recurrent vomiting for last 2 days and increase in head size since birth. The parents give history that the child was born at 37 weeks of gestation by normal vaginal delivery, and since then there has been progressive enlargement of the size of the head. The child is irritable, lethargic, and feeds poorly and is unable to hold head. So in the antenatal history, we have to ask the mother whether she had any history of infections during antenatal period. Did she go for regular antenatal checkups? The history of folic acid intake. Regarding the milestones, see, in a pediatric case, you should know all the milestones and the anthropometric measurements. So for this 2-month-old child, the only milestone which he can achieve is the ability to hold head at 3 months. So the child has not attained the relevant milestones yet. The family history, the child had no history of sibling being affected with the same disease or any other family member being affected from the same disease. You should ask about the immunization history and about the treatment history for this complaint or for any other comorbidity or other congenital illness. So in the examination, see the GCS of the patient. Patient was conscious but somnolent, was vomiting, appeared dehydrated, was very lethargic, and measure the vitals. Usually these children have tachycardia with blood pressure slightly on a lower side. Not for the JS, but I would recommend that the PDCC, they should know what is the pediatric GCS score. You might be asked in the pediatric case. So read from the book, the pediatric GCS. On examination, the head circumference was increased. It measured 48 centimeter. So at the age of 2 months, the normal head circumference is around 38 centimeters. So you should know the anthropometric measurements, especially weight, length, head circumference, and the chest circumference. So this child had increase in the head circumference. The overlying skin was shiny with dilated veins. The sunset sign was positive. What is it? It's the upward gaze fallacy, where the sclera is visible on the above the pupil. The upper sclera is visible. There is bossing of forehead. The anterior fontanelle, which normally closes around 9 to 18 months, is open, wide, and bulging. Then the posterior fontanelle, which normally closes around 2 to 3 months, is also full. It's not yet closed. So on pupils examination, they were sluggishly reacting to light, and there was papilledema on examination. Very important in these children, we should also examine the other systems, because the presence of congenital anomalies is very common in these patients. Go for respiratory, cardiovascular, renal, and GI complete examination. Remember the acronym VACTRIL. VACTRIL stands for vertebral, anal atresia, cardiac defects, tracheoesophageal fistula, renal, and radial anomalies. Rule out all these congenital anomalies. Take note. Also, we have to examine the spine in these children. There can be a swelling in the lower lumbar region, which can be a meningomyelocele, or a swelling in the cranial region, which is known as the encephalocele. These neural tube defects are very commonly associated with the hydrocephalus. Meningomyelocele is almost 70% of the children with meningomyelocele have hydrocephalus. So you should take note of these congenital anomalies also. For confirmation of the diagnosis, we go for the CT head. So on the CT scan, the size of the ventricle will be visible. The cause can be make out whether it's due to a tumor or an aqueductal stenosis or an Arnold-Chiari malformation. And also from the CT, we can see the site of obstruction if it is an obstructive hydrocephalus. So what are the main features of hydrocephalus which we can see on the CT scan? There will be loss of differentiation between this white and there will be loss of gray and white differentiation. The sulci will be effaced, and very important, we can see that the ventricles are dilated. There is ballooning of the temporal horns of the frontal horns of the lateral ventricles. These are the frontal horns of the lateral ventricles. These are balloon, known as the Mickey Mouse sign. So this is an indicator of presence of hydrocephalus. Also, the third ventricle, which is usually a slit-like, is ballooned. So the dilatation of the lateral ventricles as well as the third ventricle, it points to the site of obstruction somewhere below third ventricle. So what is hydrocephalus? The hydrocephalus, it's an abnormal or excessive accumulation of cerebrospinal fluid in the intracranial cavity due to disturbance in formation, flow, or absorption. So the normal CSF pressure is 3 to 7.5 mm of Hg, and the volume in infants is around 40 to 60 ml. In an adult, it's around 150 ml. And the rate of formation is around 0.3 to 0.4 ml per minute. So you will be asked about, if you get such a case, you will be asked about the classification of hydrocephalus. So it can be classified either as communicating or non-communicating, or as congenital and acquired. So in the communicating causes, it can be due to the excessive formation because of the choroid plexus papilloma, or due to decreased absorption as in post-trauma, post-hemorrhage, post-inflammation, or congenital infections. The obstructive type usually occurs due to congenital anomalies such as aqueductal stenosis, Arnold-Chiari malformation, meningomyelocele, brain tumors, where the tumor may be directly compressing the ventricles, or in the AVM. The other classification, congenital and acquired. Congenital causes are aqueductal stenosis, neural tube defects, Dandy-Walker syndrome, in utero intraventricular hemorrhage. And the acquired causes are aqueductal stenosis, hemorrhage of prematurity, brain cysts, tumors, and infections, and even in TBI. So the therapeutic management aims to relieve the hydrocephalus and treat its complications. So for when such a child comes for surgery, in the pre-anesthetic checkup, we ask for hemoglobin, we ask for serum electrolytes, because such patients are dehydrated and vomiting. So we should know the sodium and the potassium of the patient. Ask for the renal function test, coagulation study, and the chest X-ray. So chest X-ray is also helpful to rule out any other congenital anomaly in the heart. So the treatment modalities are of two types. Either we drain the CSF from the ventricles, or we don't drain the CSF but make an other opening. That is done by endoscopic third ventriculostomy. So to drain the CSF on the ventricles, the different procedures are external ventricular drainage. It is usually performed as an emergency procedure when the neurological status of the child is dipping rapidly and there is risk of brainstem herniation. So we do it as an emergency procedure. The others are placement of a ventriculoperitoneal shunt. The ventricular end is usually placed on the right side of the head in the ventricle, and the other end is in the peritoneal cavity. The ventriculoatrial shunt, where the other end is put in the right atrium of the heart, and the lumboperitoneal, which connects the intrathecal with the peritoneal cavity. So the pre-op assessment, see for the signs of raised intracranial pressure, the level of consciousness, see the underlying cause of hydrocephalus, whether it's an obstructive or the non-obstructive type, and any other pre-surgery temporizing measures. Has the child ventriculostomy has been done, or what are the medical measures that have been given to the child? Assess the fluid status. These children might be dehydrated, so assess the fluid status. See for the associated congenital anomalies. Assess the airway. It's very difficult to assess the child's airway, but see for any external craniofacial malformations or whether the child is syndromic or not. Then age-related pathophysiology, whether the child is premature, because these patients will be prone to apnea in the post-operative period. And especially in the neural tube, children with neural tube defects, please ask the history for the latex allergy. Goals of anesthesia are the maintenance of cerebral perfusion pressure, control of hemodynamics, and smooth extubation. So the anesthesia management, the pre-medication is usually not required. Unlike the other pediatric patients, these are usually lethargic and drowsy. So they might not be even fully conscious or anxious. So these usually don't require any anxiolytic or any other sedative agent. The fasting guidelines are the same. The nilpar orally for 6 hours for solids and 2 hours for clear fluids. In the OT, prepare your OT beforehand. Set the right temperature, increase the ambient temperature to 24 degrees Celsius, arrange all the pediatric equipment. The pediatric doses of drugs should be calculated beforehand. All the ventilator and the monitor should be set on the pediatric mode. Attach the ECG, non-invasive blood pressure and pulse oximetry to the patient, and especially the patients who have meningomyelocele, all the encephalocele, they should be very carefully positioned, because any pressure on the sac can cause its rupture or increase in the ICP. So what do? We place a donut on the OT table, and we place the encephalocele sac or the meningomyelocele sac inside the donut. So any direct pressure doesn't come upon the sac, and the ICP doesn't increase further. Induction of anesthesia, it depends upon the level of the anxiety of the child's ability to cooperate, the presence or the absence of a full stomach. In these children, if we can attain an intravenous access, the first choice of induction should be intravenous induction of anesthesia. The intravenous anesthesia induction is in a standard manner with fentanyl, propofol or thiopentone, and with muscle relaxant procronium. Intubation, because the head is large in children, and in the hydrocephalus it is even more large. So we have to ensure that the oral pharyngeal and the laryngeal axis are in the same line. So we place a sheet below the shoulders, so to align the 3 axes. The maintenance of anesthesia by volatile agent, oxygen and air, and the PCO2 is usually kept between 30 to 32 mm of Hg. If we can place an analgesia, for analgesia, paracetamol suppository can be inserted rectally before the start of the surgery. Intraoperative concerns, the positioning in this, the patient is usually exposed from head to torso. So, and with the head turned opposite side, secure the tube safely. Avoid hypercarbia, hypoxia, and hyperglycemia, and even hypoglycemia, especially in preterm children. Maintain hemodynamic stability. These children are usually dehydrated, so maintain normovolemia. And very important, during the insertion of the ventricular end of the VP shunt, there can be rapid drainage of the CSF, and at this time the child is very prone to development of hemodynamic changes and arrhythmias, and even reverse transtitorial herniation has been also seen to occur. So be very cautious when the surgeon is inserting the ventricular catheter, and be watchful for the any hemodynamic changes. Specific issue is hypothermia, as I've already said, that the whole of the child torso is and the head is exposed. So you have to ensure that you are using warm fluids. If you have a warm mattress, use that. If you have overhead heaters, use those things, and preferably wrap all the extremities in the cotton pads to avoid hypothermia. During surgical stimulation, insertion of the ventricular catheter, there is tunneling, and this is a very noxious stimulus. So a short-acting opioid can be given to blunt the noxious stimulus and any associated tachycardia and hypertension, or by increasing the depth of anesthesia. So during the emergence, neuromuscular blockade is reversed and extubate only if the child is awake and the protective reflexes have returned and the child is normothermic. Patient that can be extubated will need a supplemental oxygen and apnea monitoring for 24 hours in addition to regular neurological observations. In the post-operative period, observe for the signs of increased ICP, see whether the child neurological status has deteriorated or not, assess the pupil size, see for abdominal distension. Sometimes the rate of absorption of the CSF is much less than the production. So the peritoneal cavity gets distended by the CSF. Watch for the abdominal distension, any respiratory distress or episodes of apnea. The complications, acute lowering of the ICP during the rapid drainage of the CSF can result in development of subdural hemorrhage because of the damage to the bridging veins. Even the direct injury to the blood vessel can also result in intracranial hemorrhage, although these are very rarely seen complications, but yes, these can occur. Pneumothorax can occur during the tunneling phase. Shunt infection and shunt obstruction are usually the late complications. CSF overdrainage, if occurs, it may result in slit-like ventricles and intracranial hypotension. So the features of the shunt failure will be, again, the child will become, manifest the features of raised ICP, irritability, bulging fontanelle, vomiting, loss of developmental milestones, and increase in head circumference. So coming to the alternate procedure, the endoscopic third ventriculostomy, it is usually used to treat the obstructive hydrocephalus. And instead of draining the CSF away, it keeps the CSF within the brain and the spinal cord. What happens in this, the neurosurgeon makes a hole. It makes a thin hole in the floor of the third ventricle. So now instead of the CSF flowing into the fourth ventricle, it directly goes from the third ventricle to the cisterns. So this channel is bypassed. This narrow aqueductal area is bypassed and the CSF flows directly into the cisterns. The intraoperative complications, the irrigating fluid that we use for the endoscopic procedures, it can distend the ventricles and cause increase in the ICP. So watch for any hemodynamic changes intraoperatively. Watch for hypothermia because lots of cold saline is used for irrigation during endoscopy. So maintain temperature. Electrolyte imbalance because of the same reasons, because we are using normal saline or RL for irrigation endoscopically. And bleeding might occur because of the floor of the third ventricle is closely associated with the major vessels. So bleeding might occur if the surgeon accidentally damages the vessels. Thank you.
Great, Dr. Parul, very much on time. I'm sorry, I didn't see the chat box. Let's see chat box, if there any question. No question. Yes, you explained so well, so nicely. There may not be any question at all. Operate before asked sorted that. Yes, how can we help? I operate best when asked short, direct questions. Oh, okay. Good, very good. Good, Dr. Parul. So anybody else would like to make any comment, please? Dr.
Devendra is there.
Huh?
Yeah.
Dr. Devendra was is there. You have to add on something.
Devendra, please, most welcome. Most welcome. Can we have a look into your handsome face, please?
I am not handsome.
You are.
Okay. So good evening.
What about your video?
As usual, you have a very nice presentation. And one very important question normally examiner asks to resident during the exam, that suddenly the surgeon decompress the CSF during shunt procedure and there is a bradycardia. So what it does mean and what is the treatment of that?
The sudden CSF egress from while the surgeon is putting the ventricular end, it can result in the lowering of the supratentorial pressure as compared to the infratentorial pressure. If there is some SOL present in the infratentorial compartment, it will push the brain into the supratentorial compartment. That is known as the reverse herniation. So as I've already mentioned it in a very quickly, that reverse herniation might occur. So it's the herniation of the brain from the infratentorial compartment to the supratentorial compartment. So to avoid this, we have to very slowly egress the CSF, ask the surgeon to very slowly remove the CSF. And the other is we have to insert the saline liquids into directly inside, so that to maintain the pressure in the supratentorial compartment equal to the infratentorial compartment, to stop further herniation. So the bradycardia is a manifestation of the Cushing's, in fact, Cushing syndrome.
Yes, yes. So there was one question about choice of fluid from Dr. Aditya. Choice of fluid in these children.
See, for the hypoglycemia, first you have to assess the risk of the hypoglycemia. What are the children, the preterm infants, the children of the diabetic mothers who are prone to development of hypoglycemia? So the best is you monitor the glucose control. Glucose monitoring has to be done intraoperatively. And if there are features of hypoglycemia, then you have to mix 5% dextrose with normal saline and then you give it. So this is for any other patient, even for a non-neurosurgical patient, the basic principles of management of hypoglycemia remains the same, and the indications of giving glucose remain the same.
Okay,
so
yes.
For Aditya question that we are using for neurosurgery, every neurosurgery patient give dextrose. There is no need to give dextrose, even not neurosurgery, perioperatively in any patient. Because
we are not routinely using dextrose in any of the patients unless the patient has documented hypoglycemia.
Especially in neurosurgery, it is big no. Use balanced salt solution, or because in pediatrics now ringer lactate is good for maintenance, even not the dextrose or 0.5% neurosaline that we are using at our resident time. So now no hyperglycemia, and if you have chance that you have the patient, like madam has said, you can monitor. If the glucose is within normal limit, don't give anything, because stress, surgical stress and inflammation during anesthesia and surgery itself is a stressful procedure and will increase the glucose in even normoglycemic patients.
Yes, Aditya has highlighted that in children he is using dextrose, not in every patient. So Aditya, see, if the child is a preterm or born to a diabetic mother or has been fasting for more than 12 hours or 6 hours, so or is a neonate or less than 28 days of life, then you may consider giving dextrose, and that too under monitoring of glucose. But for other than these indications, we are not routinely giving dextrose to every child. No, we are not using.
And dear students, when you are asked to how to do the anesthetic management of these children, you have to not forget to answer that the basic principles of neonatal and pediatric anesthesia will apply first. So you have to really talk about anatomy, physiology, pharmacological, psychological aspects of neonatal anesthesia.
We have discussed this pediatric patient on day 2 itself. So I think they have to go again and read.
Okay, good. Well, but they have to remind it that the hydrocephalus is not standalone. First is the basic of neonatal and then hydrocephalus. Very good, Dr.
Charu.
Yes, sir.
There is one questions that there a lot of patient has come from the neurology ward of tubercular meningitis, and with tubercular meningitis, with the very poor GCS, what is the difference in the management as per these kind of the patients versus the other hydrocephalus patients?
Sir, usually the TB meningitis patients, they have a long history of multiple hospital admissions. They have poor venous access. Their neurological status is not good. They are chronically debilitated patients. So, and moreover, they have those obstructive kind of hydrocephalus is present in these patients.
Yes.
and they usually are on long standing IV antibiotics have been given with no IV access, difficult IV access. These children usually have difficult IV access.
And what about the post-operative, whether to extubate or not to extubate? What are the different pre-operative parameter on which we have to decide whether we have to extubate these kind of the patients, or we should keep the patient?
So the baseline neurological status is very important. What was the baseline neurological status in this patient? That determines, and what was the intraoperative course? Was there any hypothermia? Was there any metabolic derangement? So all on these factors, the preoperative factors, intraoperative factors, our decision of extubation depends. And usually if they are obtunded, they usually go on ventilator.
So I request chairperson to please end the talk here.
No, thank you so much. Thank you so much, Charu. You did it.
Thank you, sir.
Very good
Thank you,
job.
chairperson. Thank you, Sam.
Thank you.
Thank you, chairperson.
Okay, thanks
and,
to everyone.
Dr. Charu and Dr. Rashish to cover almost all aspects that is a must to know and more than must to know for PG students. Thank you so much.
Thank you.
So I request now for the next session, Dr. Mamta Harjai to please share the screen. And for this session, we have Professor S.K. Mathur, sir, as a chairperson from PHU.
Good evening. Good evening, everybody over here. Am I audible to everybody?
Yes, sir. Yes, sir.
Yes, you are.
Okay. So it's late night session. We hope people are awake, are not too hungry, and for a session which is not very theoretical. Maybe that they may consider that these are the topics which are not of much clinical concern for them. But let me tell you that so they are दाल के साथ अचार जैसी चीज जरूर है ये. Major topics तो आपने जरूर cover कर लिया है, and but still they are very important. They give you the test. They are equally important as far as the clinical outcome of the patient is concerned. So I think we'll do justification if we know the equipment and we know how to use them to their best ability, and similarly for examination, they give you an edge over others because this is the practical aspect. Usually you do not get them in the theory part. So if you can know them, can speak about them, this gives you an edge over others. And I hope Dr. Mamta will take care of all these things. We'll let you know what are the various equipments, how best they can be used, and what is physics at times involved in them. So may I call Dr. Mamta to please start.
Hello.
So let me introduce Dr. Mamta. Yeah, you're audible. Your slide is visible. Let me introduce you. Dr. Mamta Harjai is working as additional professor in Department of Anesthesia, RML Institute of Medical Sciences, Lucknow, and she is associated with for last so many years with the PG Assembly. And it's over to you, ma'am.
Thank you, sir. Good evening, Dr. Sandeep Sao. Good evening, Mathu sir, and good evening, everyone who is listening to PG Assembly at this hour. Actually, sir, hello. Am I audible, sir? Hello.
To me, you are audible.
Okay. Thank you, sir. I must congratulate Dr. Sandeep Sao you for organizing this 9th literature course so well, and I should thank you also for giving me this opportunity. Anyway, sir, as said that we will be speaking on basically the achar of the with the dal, that is anesthesia equipments. As we all of know, there are two kind of table vivas. One is the drug viva and another is the equipment viva. So the equipments which I have picked are the very basic equipments which we are using on the daily basis. So I don't want students to fumble on those daily use equipments. I have picked up very basic questions of those equipments. So either you are given the equipment of your choice, the examiner tells you to choose the equipment, or examiner or you choose the equipment, or examiner gives you whatever the thing is. First, you have to identify the equipment. First and foremost, identification of equipment is must. Then you go on with the parts. You mention the specific functions. Then the Viva will go on with the uses, indication, contraindications, the method of use, and then the specific points may be asked related to the history or the person invented it. Okay. So first equipment which I have picked up is very common instrument which we are using on the daily basis is the laryngoscope. So first you will identify it as a Macintosh laryngoscope with a curved blade. Then you will further start with the parts and all. Now everybody, some problem. I think, sir, one slide is missed. Anyway, I will continue with the parts. So laryngoscope is divided into two parts. One is the handle and second is the blade. Now, if we describe the handle part, the handle is divided into the tip, which we use to elevate the epiglottis. This curved part is called as the tongue or the spatula. And the part which are you seeing the projecting of is known as the flange. And the part which attaches flange to this curved blade is called as a web or a vertical step. The light source is a part of a flange. So this is basically the division of the parts, and there's a base which attaches to the handle. Now the laryngoscopes are named on the basis of whether the blades are straight or curved. As this blade is curved and it was discovered by Sir Macintosh, so it was named as a Macintosh blade. The other common blade which we commonly use is a straight blade. It is called as a Miller blade. So it has a long curved tip with a straight blade. The most common use is the pediatric anesthesia. You should be aware of the sizes which we commonly use, like 000 and the 1. And the person who was responsible for discovering this was Sir Robert Arden Miller. Are you then the question may be, are you aware of any other straight blades? Yes, a Wisconsin blade is there, which is also straight. But in the Wisconsin, the curved tip is not so curved. The distal end is little wider. Okay, so this is the difference between the Miller and Wisconsin blade. Now the second part was the blade. Handle. The most important question which will be asked about handle is that what is the connection between the blade and handle? It is called as a hook-on connection. There's a hinge pin on the handle which fits into the slot on the base of the blade. So the most common connection is the hook-on connection. Why this is serrated? Because so that we can grip it firmly. Now some examiners I have seen, they are fond of asking which battery. So like this handle we use 2C type batteries of 1.5 C voltage. You must have seen the pediatric pen light handles. They use 2 AA size batteries of 1.5 voltage. So these are the questions which can be asked about handle. Now there are some short and stout handles which are indicated in obese patients with a large breast, or where the cricoid pressure has to be used. They are more useful in those situations. Now, again, as I told you, after parts and after proper indications, you will be asked about the uses. We all know laryngoscope is used for inserting endotracheal tube, placing a device into esophagus, checking the position of tube when we have to remove the foreign body, or for assessment of airway glottic event. Similarly, the complications. We all are aware of the hemodynamic changes, but thing is that you should be well aware of them. You should be able to enumerate your list of complications or uses of that instrument. Now, this is another blade which will you very commonly found on the table. That is the McCoy blade. It's a similar to the Macintosh blade. It's a curved blade, but the thing is that it has got an adjustable hinge tip and a lever is present. Now, idea is that you squeeze the lever and you elevate the epiglottis gently. So it is more common, useful in the situation where the larynx is very anterior, and with the help of the squeezing the lever, you can change the grading of Cormack length from 3 to 2, or you can at least use that situation of anterior larynx, you can make it less anterior. But the problem is that there could be trauma of epiglottis. Epiglottis can happen if that epiglottis, it gets caught in the hinge of the movable tip. So it is also very common laryngoscope you will found. Now, another thing which is very common nowadays, and I think in good institutions or in medical colleges, they will be on the table, and these are the video laryngoscopes. In COVID era, we are very commonly using them. So you should know what are the indications of them, that this is part of indirect laryngoscopy, what are the others video laryngos, at least you should name them. CMAC laryngoscope is there, this is King Vision, other are AirTrack, McGrath is there, Glidoscope is there. So you should be aware of the video laryngos, so you should be able to identify them, you should be able to tell them the indications. Now, another very common equipment which are using on the daily basis is the face mask. Now, you cannot miss this on identifying this. So this is, I have used two pictures. One is with hooks and other is without hooks. Both are available. So face mask, as we know, it allows the gas administration to the patient from the breathing system without introducing any apparatus. Now, thing is that it is made up of anti-static material. Why it is black in color? It is made up of black rubber. But why it is black in color? Because some charcoal is always being incorporated to give that color black. And it is made anti-static material because of that. Reason is we don't want the ignition of any anesthetic gases there. So it can be made up of black rubber. The face masks are available in plastic. There is elastomeric material or disposable masks are also available. Now, this is the most common mask, hooked mask, anatomical mask, which we are using. So identification is, it is anatomical rubber, black rubber face mask, also called as Cornell mask. So you should be aware of the sizes 0, 1, 2, 3, 4. These are, now next question is, why the hooks are there? I will come to that. Now you have identified, the next part is come to the parts of face mask. The first part is the body. The body is the main part of the mask. It could be transparent, it could be opaque, it could be black, it could be or silicone-like transparent. So the main part which you see, you take it in your hand, the main part you see, it is the body. Now another question will be like, why the face masks are transparent? That's another question. The second part is seal. Seal is basically the rim, the flap or edge which comes in contact with the face is called as a rim or flap or edge. It is basically responsible for making that seal. Now it could be two types, the pad or cushion type or flap type. The cushion type is when you inflate it with air or filled with a material that will conform to the face when pressure is applied. Second is the flap type, because there's a body is very flexible, and that flexible extension conforms to the contour of the face and it pressed into the face to create a seal. Now the third part is a connector. That is opposite to the side of the, that is on the opposite side of the field. It has a thickened fitting with a 22 millimeter internal diameter. So you should know the diameter of this. Second, why the hooks is this? You can see a ring with the hooks. Why this ring with hooks is placed around the connector? So that the mask straps can be attached there. Now, what kind of mask straps? Normally, they are not seen usually nowadays, but yes, for the table viva, it can be important. So these were the mask straps which were used with these hooks to tighten the mask on the face. Now, problem is that these masks can cause facial injury. These mask straps, if tightened, can cause facial injuries. So the gauze sponges have to be placed between the straps and the skin so that to protect the face from the excessive pressure. Another risk of using these mask straps is that it will take longer time to remove the mask if vomiting or regurgitation occurs. Now, this is very common mask. Everywhere you can identify where it is a Fawcett mask. Okay, some examiner can ask you spelling also. So it's a triangular mask designed for the pediatric patient. The rim, the seal is flat kind of seal. It is usually available in 00, 01, and 2 sizes. It has a very low dead space, 4 ml in size 1 and 8 ml in size 2. Sorry, I forgot to tell about the dead space of anatomical mask. That was around 150 to 250 ml. It very adequately fits into the child face and no special seal is needed. Now, you can see variety of masks around. They could be ambu transparent masks. They could be silicone transparent masks. Thing is that the parts are same. Another mask which was very common in our days was this. It was a trimer mask. It's similar to Cornell mask, but it has a shallow body and it is very less dead space. Now, again, further, the examiner can ask you about how do you hold it, how you can, what are the one-handed techniques, what are the CE technique, what are the two hands technique. So one name is a very examiner is very fond of asking is Eschmark-Hebug maneuver. It's nothing but a jaw thrust maneuver. Okay, so Eschmark-Hebug maneuver is a jaw thrust maneuver. Don't confuse it with the heavy spelling. Now again, the next is the advantages. Like if a patient who has to be undergone under general anesthesia with a mask, then advantages are definitely less sore throat, less depth of anesthesia, resuscitation and ventilation can be done. But disadvantage, you cannot go on for prolonged surgeries in that. MRI, CT scans are not possible. More desaturation episodes, more facial injuries, more pressure injuries, risk of aspiration, and the user fatigue is very common. Plus the risk of environmental pollution is always there. So the next important instrument is the oral airway. The Goodell's where I think everybody is very, very much familiar with. So First, you have to identify it, that it's a good oropharyngeal airway used to maintain the patency of oral airway for an unobstructed breathing. That is the thing you will say about that. Now come to the parts. Now parts, the first part is flange, which remains outside the lips, is a flange. It is to limit the depth of insertion. It should not it hampers the over insertion of the oropharyngeal airway into the oral cavity. Second is the color coded. The white is color coded because range of sizes are available, like because of the color. About 9 sizes are available, and they are in the 9 different colors. Then there's a reinforced white block. Then the curve. The curve is made like it should conform to the contour of your tongue. You know, it is kink resistant and it keeps the epiglottis off the posterior pharyngeal wall. Then the edges are tapered. So to reduce the oropharyngeal mucosal trauma or on insertion, it is made up of latex-free, biologically inert polymer. These were the different sizes I was talking about. 000 is used for the preterm neonates, and 6 is basically used for the morbid obese patients. Parts I have discussed. Now, again, very, very important is they will ask you about the method of insertion, because in children, you don't reverse it to the 180, you don't change it to the 180 degree. You can use it with the help of tongue depressing, you can directly insert it. Though in the adults, you first go with the concave side and then you turn it into the 180 degree. Again, correct size estimation, very, very important. Why the correct size is important? Why not to use the oversize? Why not to the undersize? Oversize will cause the injury to the laryngeal structures. Oversize will push the epiglottis and further will cause the obstruction of the glottis. So correct size estimation. Now, how do you do the correct estimation? I have compared both nasopharynx and oropharyngeal here on the one slide. So for the oropharynx, you put the flange on the angle of the lip, and this tip should come onto the angle of mandible. While in the nasopharyngeal airway, the tip should be on the lateral edge of nostril, tip should be on the tragus of ear, and flange should be on the lateral edge of nostril. So this is the way we estimate the correct side, and we should always put the optimum size airway. Again, what are the uses of oropharyngeal area? As I told you, to maintain the open airway, to prevent the tongue bite, to facilitate suction, conduit for passing devices into pharynx. The point to remember here is that you should not use oral oropharyngeal airway in the patients who are very conscious because of the risk of gagging, vomiting, and aspiration. And hence, the more injury of soft tissue trauma to the tongue, palate, and pharynx also occur. So the contraindications are intact gag reflex and oral growth. Now, I would also like to mention here some specific airways which may be present in the museum of any some medical colleges or institutions. One is the water's airway. The water airway is now hardly it's being used, but it was made up of metal with an oval flange, and the bite block was straight with an anatomically curved pharyngeal section, and holes were present at the side near the distal end. And the port you can see, you can give oxygen through that. Now the use has been discarded because it can cause damage in soft tissue a lot. Moreover, it's not transparent, so you cannot see any foreign material lodged within it or not. The same metallic airway, another is called as the Connell's airway. The difference between water and Connell's airway is only this, that the oxygen port is not there. Now the other is the COPA, very common airway, very commonly found, very commonly seen, so you should be well aware of that. It's a modified version of the oral airway with a cuff. So when the cuff is inflated, it provides an airtight seal. It is more likely seen as like an LMA only. Okay. So, but it requires more manipulation for placement. The next is the Berman intubating airways. These are the new airways which you should be well aware of. The main special thing about these airways are that these airways are first used as an oral airway, as well as they are used as an aid to fiber optic or blind orotracheal intubation. The reason is that they are tubular along its entire length and they're open on one side. So when the tube is inserted, they can be very easily removed. They can be very easily removed from around. They can be split and removed from around the tracheal tube. So that way the tube is not disturbed. Another is Ovasapien fiber optic intubating airway. It was also designed to deliver a fiber scope as close to the larynx as possible. At the buccal end, if you can see, there are two vertical side walls, and between them is a pair of guide walls that are curving toward each other. That is a part through which the tracheal tube passes, like this. And up to 8 or 9 millimeter of endotracheal tube can be easily passed. They are available in 3 sizes. And when the tube is inserted, it is also unlatched and taken out. Another intubating airway now, which is seen in the market, is a William intubating airway, and it is also used for blind orotracheal intubation. The distal part only is open. The rest is like the normal oral airway. Next is the partial Syracuse endoscopic airway. It is made from aluminum, and it is designed to aid the fiber optic intubation. So this is the special part is that it has lateral channels and a central groove on the lingual surface to allow a fiber scope with the tracheal tube to pass. And there's a slit at the distal end which allows the fiber scope to be manipulated in the anterior posterior direction. So you have lot of name of airways which you can use as aid in fiber optic intubation. Another, when you're talking about oropharyngeal airway, you have to talk about nasopharyngeal airway. The parts are same, tip, curved body in a flange end. Like, okay, the very important question which is commonly being asked is when you insert it, how do you insert it? Where should be the bevel facing? Bevel should be facing toward your nasal septum. What are the various sizes available? And the method or the how to estimate the correct size that I have already told you. Now again, the use of naropharyngeal airway is to maintain the airway in patient. The here speciality is that you can use it in the patient with an intact gag reflex. Okay, in the conscious patient, then they are far easy. Those patients, this airway is far easy to tolerate than the oral airway, and it can act as a guide for fibroscope or nasogastric tube. And you can also use it to dilate the nasal passages in preparation for nasotracheal intubation. So you have to remember the list and the uses. One thing is very important is the contraindication, where you don't have to use it. The base of skull or nasal fractures, coagulopathy, nasal pathology, and wherever there is a history of epistaxis, there you will avoid putting nasopharyngeal airway. Now, this was this stillet. This is a Dr. Talwarkar stillet, and this was present in my KGMC institute. So I have seen it. I have put it here only just to show that this is some kind of a stillet. I don't know whether nowadays it is available. It is not right now. It is not available in our institute. It is called as a direct Dr. Talwarkar stillet. The main, the good part about the stillet is that you can still change the shape of the curvature of the stillet while you're intubating. So it can be used for the nasal intubation. It can be used for the oral intubation, both through the red rubber and the PVCs. So I find it fascinating. So I thought to put it here. Now again, very important thing, which is very favorite instrument of examiners, and I think you cannot miss this on identification because you're using it as a part of BLS resuscitation teams. So it's a very common instrument to be used every day. Now it is called, the names are self-inflating bag, or it is called as a bag wall mask assembly, or it is called as a manual resuscitator, or the AMBU, which is very commonly name being used. You should know the full form AMBU, that is artificial manual breathing unit. Before going into the parts, I must tell you the indication first. As we all know, it is used to provide positive pressure ventilation to all those patients who are not breathing adequately. The device is a required part of resuscitation kit in and out of hospital, both settings, and it can be used for the temporary ventilation of patients. Now, what are the various parts of this? Now, this bag, this is an assembly. Sometimes the examiner can detach the whole assembly and can provide you the parts and will tell you to assemble it. So you should know how to assemble it. The assembling is a mask is there, the self-inflating bag is there, and a reservoir bag is there. The bag which you are seeing here is made up of inert plastic, and it is self-inflatable. You compress it, it will come back. The various sizes available are 240 ml, 500 ml, and 1600 ml, the infants, children, and adults. The part where the oxygen is connected is away from the patient, opposite to the patient, and here we attach the oxygen, and there's an oxygen inlet, and there's a attachment for the reservoir bag. Now, the oxygen flow rate should be or equal to higher than the minute volume of the patient to allow 100% oxygen to be delivered. Now, the way we attach the oxygen reservoir, there are two one-way valves. One is for the air in and one is for the air out. Whenever the pressure of oxygen is less or less flows are being being given to the patient, it will entrain air from outside. And whenever there is a pressure out, whenever there is a pressure more, it will exit the excess oxygen from that air outlet valve. And another valve we've seen is the air inlet valve, which does not allow oxygen to come back into the reservoir. At the patient end, there's a non-rebreathing valve, which directs the fresh flow of oxygen to the patient and prevents the exhaled gas re-entering the bag. As usual, a standard 15 mm adapter for attaching to airway devices. The blue valve which is seen is a pop-up valve, and it basically manages the increased pressure in the circuit. It releases at about 60 centimeter water, and the PEEP valve can be attached, or sometimes they are built in the ambu bag only. So again, after the part and assembly, after the indications, next thing is the complications. The complication, there's a chance of hyperventilation with these ambu units anytime. If you are not able to manage it with a proper CE grip, there will be poor seal, risk of gastric distension, aspiration, claustrophobia, and the exhale secretions can cause exhalation valve dysfunction and increase resistance to expiration. If proper valve is not proper working, then there's a risk of barotrauma, and anytime there could be equipment failure due to incorrect assembly. So next will be, they can ask you again how to hold it and how to give the proper ventilation with this. Now, the most very common use you cannot miss on this is the endotracheal tube. Endotracheal tube is used to deliver the oxygen into the lungs. You should not miss on the parts of this. If you start with the distal end, then the parts which we should know about the endotracheal tube is, you will identify it as a PVC endotracheal tube. Okay, it's made up of, the tube which you are seeing on the screen is made up of PVC. So we'll identify it as a PVC endotracheal tube used to give for giving oxygen, providing oxygen to the lungs. Now, if you start at the distal end is which goes into the trachea. There's a first part is bevel. Second is a Murphy eye. Then is the cuff. Next is a black marker, which acts as a vocal cord guide. Then you can see a blue line, which is a radio marker, radio opaque line. Then is a inflation system, which there is you can see an external inflation line with the pilot balloon, and a single one-way valve spring loaded valve is there. And it's transparent with a 15 mm adapter. Now coming to the parts. Now this first is the bevel and the Murphy's eye. First coming to the bevel. Now bevel is, if we take the endotracheal tube in our hands, the bevel will face towards the left side. So why it is made left side? Because for the better visualization of glottis, the bevel is been curved like this, and for the easy insertion through the glottis. Now, what is the angle of bevel? The angle of bevel is around, it's acute, it is around 38 degree plus minus 10. It's very commonly asked. Now, second part is the Murphy eye. What is the advantage of Murphy eye? Whenever there is a distal occlusion because of secretions, or the main hole is occluded because of secretions, at least there is some alternate hole, so that to deliver some oxygen to the lungs. J. Murphy was a person who had this idea. So on the name of it was named as a Murphy eye. Now, what is the disadvantage of Murphy eye is that because of the Murphy eye, cuff has to be placed proximally. Now, if cuff is more distally, it will definitely decrease the chance of inadvertent bronchial intubation. So this you should know about the Murphy eye and bevel. And Murphy eye is absent in which tube is the Medull's. The red rubber tube is I will come next. Is absent in the red rubber tube. Angle of bevel I have told you. In most of the tube, it is written Z79 or F79. That refers to that your tubes has passed the tissue toxicity test. The next is the cuff. Now you should be aware of what kind of cuffs are available: the high pressure, low volume cuff, and high volume, low pressure cuffs. Your red rubber tubes mostly have the low volume, high pressure cuffs. They are more circular in shape, while your high volume, low pressure cuffs are more elliptical in shape. You should know the advantages and disadvantages. At high volume, low pressure cuff will definitely decrease the chances of tracheal ischemia and necrosis, but definitely increase the risk of microaspiration. Similarly, low volume, high pressure cuff will prevent microaspiration, but increase the chances of the tracheal ischemia and necrosis. And you should know which target pressure you should be able to achieve. That it should be between 20 to 30. You should not never go beyond 30 centimeter. Now, there's a black marker, which is basically a vocal cord guide. If your this black mark should cross the vocal cords. If in some tube there are 2 black markers, then the vocal cords should remain in between these 2 black lines. Now, very common is being asked question is that when you talk about the size like 6 size, 7.5, 8, what does it refer to? It refers to the internal diameter. Okay, and why always largest possible size should be selected? To decrease the resistance. The lesser the size, there will be increase in 4 times the resistance. Okay, so always the largest possible size should be chosen. Now, I find it very interesting that to tube we know that this is a catheter mount, but why this is called as a catheter mount? The catheter mount has its own advantages and disadvantages, but why it is called catheter mount? Because when endotracheal tubes were designed initially, they were not called as endotracheal tubes; they were called as endotracheal catheters. Okay, and so anything mounting on endotracheal catheters were called as the catheter mounts, and it attaches to your tube 15 mm diameter. It's a standard universal connector. Now the tubes, another tubes which are very commonly seen on the table is red rubber. Red rubber, why it is called red rubber? Because it is made up of India rubber that is red in color. These are reusable, these are autoclavable, and there's no Murphy in that. The angle of bevel is same, around 30 degree in this. I forget to mention the radius of curvature. The radius of curvature, is the curvature of the tube, and that is also called as the Magel's curve. Why Magel's curve? Because the Magel was a person who designed this tube, and so the curve is named on his behalf. To give him the honor, it is called as a Magel curve, and the Magel curve is around 140 mm plus minus 20. So the radius of curvature is same as that in the PVC tube, and there's a risk of later allergy. Now, again, when you talk about the endotracheal tube, the next most favorite question will be how will you differentiate red rubber tubes? What are the differences between the red rubber tubes and the PVC tubes? Red rubber tubes can be reused multi-times, while PVCs are more disposable. They are not transparent. PVCs are transparent. The red rubber tubes have a problem. They become hardened and become sticky with age, and they're very poor resistance to kinking. They become clogged by dried secretions. While PVC tubes are less likely to kink than the rubber tube. They can kink, but less likely than the rubber tube. And they are stiff enough for intubation at room temperature. Plus, the risk of latest allergy is always with the red rubber tubes. Now, another very favorite tube to be asked is a flexometallic armored or reinforced tube. So it can be called as a reinforced, it can be called as armor, or it can be flexometallic. Again, what was the use that we need to use this tube? What are the indications in which surgeries it should be used? It is a spiral viral embedded tube. Now, this tube, because of the spiral embedded wire, it is used in those, it has a less risk of kinking and getting compressed. So all those surgeries where there's a risk of compression and kinking, like headache nerve surgeries, thyroid surgeries, cervical spine surgeries, prone position, this tube should be preferred. Okay. Now, these are the advantages. Now, what are the disadvantages? Since this tube is very flexible, so it requires tillet and forceps for the insertion. Moreover, this could be permanent deformity if patient bites it. If you shorten the tube, it cannot be cut. So these are again, advantages, disadvantages you should be aware of. Next is the preformed ET tubes. Why they are called as the preformed ET tubes? Because already the shape is preformed. You cannot deform that or you cannot change the shape. So they are called as the preformed ET tubes. The other names are RA tubes. The RA tubes are the example of preformed ET tubes, ring Adair Elvin tubes, or they are also called as a north facing or south facing tube. The tube which is in the upper direction is south facing. The connector is facing towards your feet is called as south facing. If universal connector facing towards the forehead is fixed on the nasal bridge and forehead, it is called as the north facing tube. North facing is more commonly for the nasal surgeries. South facing is the nasal intubation. South facing is for the oral airway. Now again, there's a mark at the vent which denotes the position at the teeth or nares. It should lie at the teeth or your nares, and these tubes are easy to secure, and once they are secure, the risk of unattended extubation is less. But the problem is these tubes are difficult to suction and there's a high chance of increased resistance. Now another very favorite tube is DLT. If you pick up a DLT, you're thorough with this. You tell all the points of the DLT, you are 100%, there's no chance of failure. You know, it's such a tube. And the tube which you are seeing on the screen is a left-sided Robertshire double lumen tube. Basically, these are the two tubes which are incorporated into the one another, naming as the double lumen tubes. Okay, one is for the trachea, one is for the endobronchial. So all the parts which you are seeing is the left-sided Robertshire double lumen tube. Another tubes are the Carlin's tube. The Carlin's tubes are the double lumen tube. They are the left-sided tube with hook. Another is the Wright's tube, which is the right-sided with hook. The Robertshire is most common. They are available red rubber as well as the disposer. PVCs are also, Robertshires are also available. This is the Carlin's tube, which is seen on the screen. It has a carinal hook, now not hardly used. Now this is a PVC tube with this is a double lumen tube with a part. Always remember, it is made up of the disposable and made up of PVC. There are two cuffs. One is the bronchial cuff and there is the tracheal cuff. The tracheal cuff is above the tracheal lumen. The bronchial cuff is above the bronchial lumen. And the blue color is given basically in the tube to denote the endobronchial component. Blue pilot balloon, blue cuff, the blue tube. That means that is a tube which is going endobronchial. Okay. And this port connector, another which you are seeing on the screen, is that is connected to the tracheal and bronchial end, and the tube which is connected, which is coming after the port connector and will be connected to the ventilator, is made up of silicone, very soft, and it is the part where the tube should be clamped. Okay, and we should know how much air we have to infuse into the tracheal cuff and into the bronchial cuff. Another difference is the right side tube has widely shaped eccentric cuff. The idea is to prevent the occlusion of the upper lobe bronchus. The left sided has normal cuff. Okay. Now again, when DLT is there, you will be definitely asked what are the indications, where they have to be used. You should know all the indications, or the lungs for the lung separation, to isolate the lung, to control the distribution of ventilation, or for the bronchopulmonary lemma. You should be well versed with all these things. Now, so questions can be types of tube, what are the sizes available, uses, indication, contraindication, complications, how do you check for positioning, why left side is preferred. Left bronchus is 50 to 60 millimeter, right is smaller, so there's a more margin of safety. What should be the depth of insertion? Usually with the 177 centimeter, the depth is 29 centimeter is fine, but with 10 centimeter difference in height, the 1 centimeter variation there, those are very vague kind of thing, but it's written in the literature, so I'm mentioning it. Now, what is the problem with these tubes? You should always remember there's a high chance of failure of intubation. There's a high chance that the lung isolation will not be proper. Injury to airway is common, hypoxemia can be there, and these tubes need expertise to put, and they are contraindicated in difficult airway. So, if like you should, if I summarize it, you should be well versed with the DLT if you're picking it up. From the method of insertion, and checking of how to check whether it is left-sided or right-sided. Another tube, it could be present there is a laser-resistant ET tube. Then your Viva will move toward why we need this laser-resistant ET tube, what is the risk, and what is the risk of flammability, what are the surgeries where it should be used, what kind of more ET tubes are available like this. So either the standard tubes are like red rubber or PVCs are wrapped in the aluminum or protective metal foil, or some silicone-based laser shields tubes are available. And what other preventive measures you can use, you can do to decrease the flammability in the laser surgeries. So these are the questions which can come with the laser-resistant endotracheal tubes. Right. Another instrument which I picked up is cuff manometer, because you should know how to use it. How it is connected to the pilot balloon. There's a hook which is directly connected to the pilot balloon. You should remember that it measures the airway pressure. It also adjusts the airway pressure. There's a red button on the side, which if you use it, it will deflate the extra pressure. So if next question can be, what is if you find the pressure 0? What is the possibility? So either either cuff is disrupted, there is some injury to the cuff, or there's occlusion to the tube. So that way the question will arise, but you should be able to identify it. Next, I picked it up because it was in my institute. I have seen this personally. It is also called as a airway prop, also called as a London dental prop. It's basically a circular hollow piece of metal to prevent the biting of ET. It's a kind of a bite block, and tube is inserted in the hollow of the prop. One of my very favorite instruments, so I picked it up. You cannot miss this on identifying it. It's a gum elastic bougie. Though I should tell you that the gum elastic bougie is a misnomer. There's nothing which is made up of. It's not made up of resins or something like which is like gum-like, or it is neither elastic nor it is used for the dilatation. Usually bougies is a word which is used for dilating something. So it is not a gum elastic. The name is Eschmann tracheal tube introducer. Okay. It's a flexible device, 60 centimeter in length, 15 French diameter with a small hockey stick angle at the distal end, and the angle is 35 to 40 degrees. And some bougies are available with a central lumen and a port for ventilation, and they can be used as the tube exchangers. Now the different sizes are available, 10 or 15 Frenches there. Then they can ask you what do you hear what do you listen when you this is inserted into the trachea. The tip, as it touches the tracheal link, there's a click sound, and you should know about the indication in the use of difficult airways during tracheal intubation, during cricothyrotomy. You should be well aware of the indication. So it is called as a Esch introducer. Now, another very simple instrument, you can pick it up, and I picked it up because there were some specific points I should like to mention here. It is called as a Magel faucet. But the curve which you are able to see is the Dynafor curve. The Dynafor curve was made so that we can insert into the oropharynx. Okay, sorry. And there's an angle. The angle between handles is the oblique angle. Why there's an oblique angle? Because to prevent the obscuration of the view of the airway during use, it should not come into the view. If you're using it for packing, or if you're using it for passing the endotracheal tube into the larynx, the angles were made like that they should not come into the view. So, and the serrated. So this is the two important parts, the Dynafor curve and the oblique angle. Now, uses all of you are aware of that it helps in the passage of endotracheal tube into larynx. It aids gastric tube passage into to remove the foreign bodies from the airway, to place the pharyngeal packs, and the problems are local trauma, cuff damage can there. One arm may lodge in the Murphy eye. You are unable to grasp the small objects, and it definitely needs practice. Now, another thing is the oxygen delivery device. Because it's the huge bunch of oxygen delivery devices would be lying on the table, and examiner would definitely talk about that, would ask about that. So you should be well aware, since there's one talk on the oxygen therapy, I know about that. So you should be well aware of what are low flow systems, what are high flow systems. When you identify the oxygen delivery device, you should be able to tell that whether it's a low flow, high flow, fixed performance, variable performance, how much FiO2 we can give, how much nasal flows we have to maintain, and what are the advantages and disadvantages. Low flow systems are nasal cannula. They're dependent on basically patient tidal volume, intranasal catheter, simple mask, partial rebreathing, and non-rebreathing. While your high flows, venturi system, phase 10, high flow nasal prongs. And the first, coming to the nasal props, you should aware of the flow rate. How much flow rate we can give? It's about 1 to 6 liter per minute. The FiO2 we can give is 0.24 to 0.44. That is the nasal prongs. What are the advantages? What are the disadvantages? It's ideal for the patients on long-term oxygen therapy. Patient is very comfortable with the nasal prongs. They're very lightweight. Patient is able to speak. Humidification is not required, and they are definitely very cheap. But the disadvantage, you cannot provide high flow oxygen. It causes dryness of mucosa. It's very irritating, and high flow rates are very uncomfortable. Similarly, next is the simple face mask or the Hudson mask. Very common instrument. You're using it seeing it on the daily basis. You should be well aware of this instrument. Again, it's a low flow device with a variable performance. It's a variable with a variable performance system. It's the reservoir capacity of this mask is around 100 to 250 ml. Okay. Now, different oxygen flow rates would result in high variable unpredictable FiO2. Okay. So if you are keeping the flow rates less than 2 liter, there is a chance of rebreathing. 4 liter of a minute per oxygen is enough to deliver about 0.35 to 40% of FiO2. If you increase it up to 8 liter, there is no increase in FiO2. So 5 to 8 flow liter flow rate you have to keep, and FiO2 you can deliver is 40 to 60%. Again, merits are it's good for patient with the blocked nasal passages. It's easy to apply if the patient is comfortable with this. But demerits are you cannot, proper fitting is required, risk of aspiration in unconscious patient, and chance of rebreathing is also there. Plus, patient cannot eat with this one. Now, this is again, thing you pick it up, and the patient and the examiner will be very happy. And if you are thorough with that, again, no chance of failure. So it's a Venturi mask. It's a it's a fixed performance device, high flow device. Okay, you should be well versed with this equipment. Now, it's another name of Venturi mask is air entrainment mask. Why it is called as air entrainment mask? I will tell you. Now, first thing is that it delivers fixed concentration of oxygen. The size of the wall, the constriction of that wall, the size of the constriction determines the final concentration of oxygen for a given gas flow. The next question is, on which principle does it work? It's work on the Venturi principle. The Venturi principle is that if air or gas or a liquid, if it flows from a large orifice to a narrow orifice, the velocity increases, but the pressure decreases. And to compensate for that pressure, it entrains the fluid or gas, whatever it is. Similarly, this as the forward flow of inspired air increases, the lateral pressure to the vector of the flow decreases. It results in entrainment of gas. Smaller the orifice is, remember, the greater the negative pressure will be generated. There will be more fall of the pressure, more ambient air will be entrained, and the lower will be the FiO2. So how much FiO2 we can deliver? From 24% to 60%. Now, this is the adjustable Venturi valve, which is more commonly you have seen in your wards. And you should be well aware of all the color-coded valves available, and which at what FiO2 they can give, and at what liter per minute. Okay, this should be, you should be, well acquainted with this. Now, this was the Venturi principle I was talking about. Now, another question is, how is Venturi mask different from others? First thing is, it is used in the patients who require long-term oxygen therapy, and who they are dependent on their hypoxia drive. For example, COPD patients. It's a very good for COPD patients. It is different from other. It's different from other masks because it is more effective at delivering the accurate oxygen concentration. Okay, so a fixed kind of high flow oxygen can be delivered through this mask. This is the basic concept of this mask. Again, very favorite of examiners is the non-rebreathing mask. One is partial rebreathing mask. This is non-rebreathing mask. It's a bag with the oxygen reservoir. The parts are, there's an inspirational unidirectional valve, which allows the oxygen from reservoir back to the patient. And there's a port to deliver the oxygen, through which the oxygen is connected, and 2 expiration valves. So total 3 valves are there. 2 expiration valves, which are unidirectional, and 1 is inspirational valve. The expiration valve, when patient expires, the unidirectional inspiration valve is closed, and the patient expires. And when patient is when the oxygen is delivered to the patient end, the expiration valves are closed. There's no entrainment of air from the outside. So it's kind of provide 100% of oxygen to the patient like this. These are the expired one-way valves. These are the inspired one-way valve. And there's no mixing of inspiratory and expiratory gases. This is the same, that one-way valves in the mask prevents the entrainment of room air. The expired air escape through side vents and around the sides of the mask. Now, they're capable of giving 90 to 100% FiO2 at 10 liter flow rate. Now, indications, very important. All the patients who require high FiO2, more than 40%, this can be used. But the contraindication, patients should not have poor respiratory efforts or apnea. They become the more for the mechanical ventilation. Now, advantages are, you can give highest possible FiO2. They are suitable for spontaneously breathing patients with severe hypoxia. Disadvantage is it interferes with eating and drinking. It requires tight seal, and it becomes uncomfortable for the patient. So not very suitable for the long-term use. And malfunction can cause CO2 buildup and suffocation. Now, this is a partial rebreathing mask. Now, how does it differentiate from the, if you can see, if you can make out the, there are expiration valves. There are no expiration, there are no flaps on the expiration valve. This is the difference. And because of this, the patient, when the patient inspires, oxygen delivers to the patient end, but when patient expires, and it entrains also, it goes outside, air is also entrained, plus there's a mixing of the inspired and expired gases. So it leads to partial rebreathing, but still is a very useful mark, though not much in the clinical practice, but it can be lying there on the table, and you should know what is the basic difference between the partial rebreathing and the non-rebreather mask. It can deliver an FiO2 up to 0.8. A minimum of 8 liters per minute should enter the mask to remove the exhaled CO2 and to refill the oxygen reservoir and to prevent rebreathing. And the flow rate should be sufficient to keep bag 1/3 of half inflated at all times. Now again, maybe this would be lying on the side of the table, and you're very commonly seeing it nowadays, and everybody's talking about this. So I just picked up this slide and put it here. It's a high flow nasal cannula. You should know its indication, how much oxygen can be given, what FiO2 and all. You should be aware of that. This is a table in which I summarized all the like what are variable devices, which devices are fixed, which are variable, how much a liter of oxygen should be given to maintain how much FiO2. Now, a reason to pick up the spinal needle is that I think every day anesthetist is using spinal needle or epidural, but I have seen students fumbling even the length of, if the length of spinal needles is asked. So I thought to just pick up 1 or 2 slides on the spinal needle and the epidural needle. You should be well aware of its length, whether the needle you are picked up is dura cutting or dura separating. The dura cutting are the quinque needle which we are commonly using. Dura separating is a Whitcare and Scotte. You should be aware of the sizes, what colors are available. 20, for the at least for the most common you are using. The most common standard spinal needle which we are using is the quinque needle. The length is 3.5 to 4 inches or 90 millimeter. Okay, the different lumen sizes are there. Why there is a stellate? I have seen one examiner asking why there is a fitted stellate which can be detachable. Very simple answer is so that you the epithelial cells coming into the way should not be tracked into the subarachnoid space. That is the reason. There is a fitted stellate which can be detachable. So, and once you are able to tell about the spinal needle parts, then color coding, positioning, structure pairs, drugs, adjuvants, what are the factors which are responsible for the height of block, complication, management period, the Viva can go in any direction, Again, about the Toe's needle. Length of Toe's needle is 80 millimeter, 8 centimeter. The markings are at the 1 centimeter apart. I have seen 110 centimeter also. The most common epidural Toe's needle which we use are of 16, 17, 18, 19 gauge. 19 is of pediatric. It is of 5 centimeter. The epidural filter size is 0.2 micron. The catheter length is 100 centimeter. The Huber tip is the needle tip, the blunt tip which we see. The idea is to not to injure the dura, so it has the bevel is made the blunt. What is the angle at the curve tip is 15 to 30 degrees. These are very simple questions you should know, and examiners, if you pick up, they will ask these questions. Okay, in CSA kit, the spinal needle length is 13 centimeter and 26 gauge. Remember this. And Toe's is 16 to 18 gauge. Which technique? Needle through needle, or you are using different space techniques, that you should be aware of that. Very few slides. This is I've also picked up this because standard monitor, ETCO2 monitor, your standard, it's a standard monitor which you're using in every case. So it's a capnometry, basic capnometry instrument for capnometering, for monitoring the ETCO2. One is the mainstream capnometer. On the right side is the side stream capnometer. So you should be aware of what are the mainstream, what are the side stream. The mainstream which is coming in the coming in the direct path of the gas source is called as the mainstream, which is away from that is called as the side stream. Then coming to the if you picked up this instrument, then definitely you will be asked about the indications. Confirmation of proper ET tube placement, continuous monitoring of respiratory pattern, effectiveness of CPR, monitoring of pulmonary and cardiac. So you should be aware of that. Now, what is the principle of capnography? Is infrared spectrography. I'm not going into detail of this, but you should know what is infrared spectrography. Disadvantages. Very common question which is being asked is the mainstream disadvantages is it add dead space and it adds weight to the circuit, and it needs time to heat up to avoid condensation of the heater. Now, about side stream capnometer disadvantages, that the sampling capillary tube can easily become obstructed by water secretions, and water vapor pressure changes within the sampling tube, it can affect the CO2 measurements. So once capnography, you can be asked about the normal capnogram and all the abnormal waveforms, they can be, the Viva can definitely go in that direction. So you should be quite aware of that. Thank you. Dr. Sandeep?
Thank you, Dr. Ajay.
Hello, your voice is not audible, sir.
I'm Dr. Mathur calling. Am I audible now?
Hello.
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 Am I audible? Hello.
Yes, you are audible, sir.
It was very nice that you covered very many of your instruments which are being commonly used and are in.
Many have been missed. Many have been missed, but I try to pick up the basic ones.
They are going to be because equipments are enormous, and you have chosen the most commonly used equipments. I think it's good, and probably the other parts will be taken care of by the other team. In chat box, we don't have any questions being there.
Sir.
Dr. Sandeep is driving.
Dr. Sandeep is driving.
आपकी फोटो तो दिख रही है सर.
You are doing lot of hard work.
म्यूट तो नहीं है आपकी तरफ से.
आप बहुत मेहनत करते हैं सर. डॉक्टर संदीप, आई मस्ट कांग्रेचुलेट, आप बहुत मेहनत करते हैं और हम लोगों से भी करा लेते हैं. अच्छी बात
तो ये चल रहा है. आप लोगों के रहने से कोर्स चल रहा है
क्योंकि फैकल्टी है, पढ़ा रही है. हम लोग भी पढ़ लेते हैं थोड़ा बहुत.
थैंक यू सो मच माथुर सर. एंड
नहीं, थैंक यू सर.
Thank you so much. There are limited participants.
Okay, bye.
We'll hope to. And if they have got any questions, they can ask.
Yes, sir.
Voice नहीं आ रही सर.
I don't think that they have got any questions.
जी.
So, thank you very much, Dr. Mamta.
Thank you, sir, for your patient hearing. Thank you, sir.
Thank you.
Thank you, Dr. Sandeep. Good night, sir.
Okay, bye.
Thank you, Dr. Sandeep.
Bye, sir.
Bye.
Bye.